Hello. 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 Hello.
ಹಲೋ, ಯಾರು?
ಇದು ಡಾಕ್ಟರ್ ಸೋಮಶೇಖರ್. ಸ್ಕ್ರೀನ್ 1 ಸ್ಕ್ರೀನ್ 2 ಇದು?
ಇದು ಸ್ಕ್ರೀನ್ 1 ಸರ್. ಇದು
ಹೌದಾ? ಸ್ಕ್ರೀನ್ 2 ಹೋಗ್ಬೇಕಲ್ಲಪ್ಪ. ಇದೇನು ಎಕ್ಸಿಟ್ ಆಗ್ತಾ ಇಲ್ಲ. ಸ್ಕ್ರೀನ್ 1 ಕನೆಕ್ಟ್ ಆಗ್ತಾ ಇದೆ ನಮ್ದು.
ಅಲ್ಲ, ಕೆಳಗಡೆ ಇದೆ ನೋಡಿ ಸರ್. ಇನ್ನೊಂದು ಅದೇ ಕಾಂಟ್ಯಾಕ್ಟ್ ಅಲ್ಲೇ ಇನ್ನೊಂದು ಸ್ಕ್ರೀನ್ 2ಗೆ ಅಂತ ಸಪ್ರೇಟ್ ಇದೆ ನೋಡಿ ಸರ್.
ಹೌದು.
ಅದನ್ನ ಕ್ಲಿಕ್ ಮಾಡಿದ್ರೆ ಅಲ್ಲಿ ಹೋಗ್ತೀರಿ ಸರ್.
ಓಕೆ ಸರ್, ಥ್ಯಾಂಕ್ ಯು.
ಅಲ್ಲ, ಸೋಮಶೇಖರ್ ಅಲ್ಲಿ ಬರ್ತಾರೆ. ಹೌದು.
Good evening, Dr. Chandrasekhar.
Hello.
Good evening, sir.
Good evening, sir. Good evening. Just a time. Sir, shall we start, sir?
Yeah, I'm sure, sir. Should I share my screen or?
Allah, actually, you have already shared with us. So, name
Yeah,
Marti,
correct.
sir. Name Marti, sir.
Okay, nodi.
ಇಲ್ಲಿ ಬರಂಗ್ ಮಾಡು. ಅಲ್ಲ ಬರಂಗ್ ಮಾಡು, ನಾನು ಮಾತಾಡ. ಸರ್ ಬರ್ತಿದೆಯಾ ಸರ್ ಈಗ?
ಬರ್ತಾ ಇದೆ. ಎಲ್ಲರದು ನಮ್ದು ವಿಂಡೋಸ್ ಇದೆಯಲ್ಲ ಅಡ್ಡ.
ಅಲ್ಲ ಅದು ಮಿನಿಮೈಸ್ ಆಗುತ್ತೆ ಸರ್, ನಾವು ದೊಡ್ಡದು ಮಾಡ್ತೀವಿ.
Okay. Yeah, I can see in the backdrop my presentation.
ಓಕೆ. ಎಷ್ಟು ಚೆನ್ನಾಗಿದೆ.
Good evening, Jaka.
ಜಾಕ ಸರ್ ಬಂದ್ರ?
Guru Shantappa sir.
Good evening and welcome, sir.
Good evening,
Sir.
yeah, Rajshekhar.
Sir, good evening, Jaka sir. I am Dr. Chandrasekhar.
Good evening, sir.
Good evening. Sir, shall we start, sir?
Yes, sir. Yes, sir.
Yes, sir.
Please.
Sir, I am Dr. Chandrasekhar, Secretary KSCASI. So, for a third day MidCon program, I welcome all the delegates, speakers and chairpersons. And now, our screen manager in charge will start with proceedings.
Good evening, everyone. Moving on to our first session of the day, I would like to invite Dr. Venkatachala K. Sir. He is a renowned surgical oncologist at Bangalore, HCG Hospital, Sakaravalta Hospital, and Saint Philomena Hospital. Sir is also a professor at Sri Shankara Cancer Institute for a lecture on hyperthermic intraperitoneal chemotherapy. Sir, now I would like to call upon the chairpersons for the session, Dr. R.D. Manjunath Sir, surgical oncologist and associate professor at Mysore Medical College and Research Institute. Also, I would like to call upon Dr. Rajshekhar C. Jaka Sir, head of the Department of Surgical Oncology, Sparsha Hospitals, Bangalore. We welcome you, sir, to chair the session. Dr. Venkatachala Sir, we can start the session now, sir.
Can I see the presentation, please?
Yes, sir.
Sir, is it visible, sir?
No, I have all those 4 videos and the timer in the front. So the presentation is on the backdrop. I can't see that.
Hide thumbnail, sir, in that. If you just go to the video, sir, in the top left of the videos, there is a hide thumbnail of the video.
Which one? View.
On the videos, there are multiple icons, sir. On the top left of the videos, there is hide thumbnail video.
Only one. And the time,
Sir, or else, will you share the video?
Or should I share the screen?
Yes, sir. I'll stop sharing now.
Okay.
co-host
That
one.
will be better.
Sir, you
Yes,
can,
sir. You can now. You can share, sir.
Okay. Are you able to see?
Yes, sir.
Okay. Thank you. Good evening, everybody. At the outset, I would like to thank Dr. Chandrasekhar, Dr. Arvind Patel, and the state chapter for giving me an opportunity to deliver this talk of today. I was told to give a talk on IPEC, hyperthermic intraperitoneal chemotherapy. I added cytoreductive surgery points also, because without cytoreductive surgery, there can't be any IPEC procedure. So what is the definition of IPEC? IPEC is highly concentrated chemotherapy delivered directly into the peritoneal cavity at higher temperature. So that makes it hyperthermic intraperitoneal chemotherapy. So what are we going to discuss on? We are going to discuss on peritoneal metastasis, without which we won't do cytoreductive surgery. Once optimal cytoreductive surgery is done, we do IPEC, and who are the patients who are eligible for this. So peritoneal disease, as we know that peritoneal dissemination is common in GI malignancies and gynecological, means ovarian malignancies. The incidence of peritoneal metastasis varies from 60% in ovarian cancers to 20% in gastric cancers and up to 17% in colorectal cancers. So in 2016, it was estimated in the United States that 135,000 around colorectal cancers, around 26,000 gastric cancers, and 22,000 ovarian cancers are likely to be diagnosed, with estimated deaths combined from these cancers reaching around 74,000. So as we know that peritoneal disease is the second most common cause of death in GI malignancies, second only to liver metastasis. Average overall survival is 6 months without systemic therapy. Traditionally, a nihilistic approach was adopted. It was managed as an end-stage disease with just systemic chemotherapy without any surgical approach. With the best systemic chemotherapy, median overall survival reached 20 months and median disease-free survival was only 10 months. One man had a vision. He started doing cytoreductive surgery and IPEC in 1980s. This man was Paul Sugarbaker. It is what the surgeon doesn't see that kills the patient. This is what statement he made. So you should see if something can be removed and innovate and treat so that you can only then achieve results. So Paul Sugarbaker said that peritoneal metastasis should not be equated with generalized disease or stage equivalent to any other stage 4 disease. Involvement of the peritoneal surfaces may occur in the absence of hematogenous metastasis into distant organs, or it may just represent the dominant clinical picture. So peritoneal metastasis represent a loco-regional disease and it has to be managed with appropriate methods. What are these methods we are going to discuss? So the patterns of peritoneal metastasis on CT scan we see is peritoneal carcinomatosis, which happen with ovarian, stomach and colorectal cancer, pseudomyxoma peritonei or mucinous carcinomatosis, which happen with appendix and colorectal tumors, sarcomatosis, sarcomas and gastrointestinal stromal tumors, and lymphomatosis in lymphoma. Other than the metastasis, there can be primary malignant peritoneal mesotheliomas or epithelial tumors like primary peritoneal papillary serous carcinomas or borderline tumors arising from the peritoneal cavity. Smooth muscle tumors like leiomyomatosis, peritonealis disseminata, and tumors of uncertain origin like small round cell tumors and solitary fibrous tumors. So what are the current indications for cytoreductive surgery and IPEC? It started all with pseudomyxoma peritonei or jelly belly with mucinous deposits all over the abdomen, appendiceal adenocarcinoma, peritoneal mesothelioma, colorectal cancer with peritoneal metastasis, ovarian cancer with peritoneal metastasis, and gastric cancer with peritoneal metastasis. Any other thing outside this list will be part of a clinical trial. So the peritoneal disease, as you can see, it starts in the pelvis, the peritoneal fluid, ascitic fluid. The circulation is like this. It goes along the right paracolic gutter, above the surface of the liver, that is the subdiaphragmatic area, or under the surface of the liver, and along the bowel surfaces, comes down along the paracolic gutters and on the mesenteric surfaces. So we have to look into all these areas. The recto-uterine pouch, pelvis, the paracolic gutters, the subhepatic surface, that is the Morrison's pouch, the diaphragmatic surface on both sides, the lesser omentum area, the greater omentum forms a big space here, the bowel surfaces, the paracolic gutters. We can see this white line. What we can see in this image is the peritoneal disease. They are all the deposits. Similarly, you can see on the left side, on the omental surface, pelvic deposits all over, as well as the peritoneal deposits forming a white line, thickened white line. Paracolic gutters area, you can see the PET and MRI superimposed images where you can see multiple deposits picking up FDG. This is a pictorial representation of the peritoneal malignant mesothelioma deposits. Unlike the malignant mesothelioma, which form big masses, the disease in the peritoneum carcinomatosis will be like wax droplets, as you can see in this image on laparoscopy. So these are all, this is the ligamentum teres with deposits, the bowel surface and the mesentery of the small bowel having deposits. All these things can be removed, but it takes time and patience. If time and patience is given, then we can achieve wonders. So cytoreductive surgery plus IPEC, cytoreductive surgery and peritonectomy removes the macroscopic disease, whereas IPEC treats microscopic disease. If you have gross macroscopic disease, your IPEC will fail. So what are the techniques of peritonectomy? What do you remove? Anterior peritonectomy means you remove the peritoneum covering the anterior abdominal wall. Pelvic peritonectomy, you remove the peritoneum in the pouch of Douglas, over the sigmoid colon, over the surface of the bladder, and also you remove the uterus and the ovaries. The greater omentectomy, the whole omentum is removed. I will show in the future images how omentectomy has to be done. Lesser omentum peritonectomy, you know the lesser omentum, it is behind the below the liver, between the gastrohepatic ligament and the hepatoduodenal ligament. And a lesser sac also must be removed. Epigastric peritonectomy, which also includes the ligamentum teres. Right hemidiaphragmatic peritonectomy, left hemidiaphragmatic peritonectomy. After you have done all these things, you come to the surface of the mesenteries and the bowel appendices epiploicae. And in the end, you do lymphadenectomy. Until you have done optimal cytoreductive surgery, you are not going to do complete lymphadenectomy, because lymphadenectomy has a bad lymph node metastasis, has a bad outcome when it comes to, say, CRS and IPEC. So here you can see a pictorial representation of a diaphragmatic peritoneum is stripped. The gallbladder always goes with the in the cytoreductive surgery, the cholecystectomy has to be done. So the peritoneum is stripped from the diaphragm muscle all along, and you can see that if necessary, the spleen also is removed. And if there are surface deposits on the liver, they are also removed. The lesser omentum is removed. The greater omentum, here you can see all the gastroepiploic vessels, their branches to the stomach are ligated so that the gastroepiploic arcade is completely removed. So the transverse colon is bared and the whole omentum is removed. So you now label it as right diaphragmatic peritoneum and Glissen's capsule, left diaphragmatic peritoneum, the lesser omentum, the greater omentum, right paracolic peritoneum, left paracolic peritoneum, and if necessary, a bowel resection with hysterectomy and bilateral salpingoophorectomy and pelvic peritonectomy. So the greater omentum, the mesentery, they all have to be approached. What are all the ligaments that to be removed? Lesser omentum, along with the greater omentum, hepatoduodenal and gastrohepatic ligaments, gastrosplenic ligament, spleno or lienopancreatic ligament, lienorenal ligament, lesser sac. Serosal surfaces, liver, even if there is parenchymal invasion of the liver, it can be removed. Spleen, subphrenic space, and the diaphragm peritoneum is removed. Pleura is removed if necessary. If you have to, you can remove a strip of the diaphragm, you can suture it again, or you can put a mesh. Bowel surface or bowel resection can be thought of. Suprarenal nodes and cardiophrenic nodes are specially looked into, because unlike not just the para-aortic nodes or the pelvic nodes, when there is lesser omentum involvement or when the diaphragmatic surface is involved, these nodes can be involved. Perihepatic spaces, as I told you, gallbladder fossa and cholecystectomy, falciform ligament, porta hepatis, everything have to be looked into in detail. So what are the sugar baker's peritonectomy indices? Is that peritoneal carcinomatosis index of sugar baker. What the abdomen is divided into around 12 quadrants. Center is 0. 0 means disease in that area, that is the bulk is the greater omentum. If there is disease in that area, you count it as a regional disease. This means that is not accounted, whatever is the volume of disease in that. So it will be irrespective of the extent of omental disease, it is calculated as 0. Then right upper abdomen, epigastrium, left upper abdomen, left flank, left lower abdomen, pelvis, right lower abdomen, and right flank. So what happens totally is that these 12 quadrants, along with that 9 upper jejunum, lower jejunum, upper ileum, and lower ileum. So the 12 quadrants are formed, and the lesion size is given a score. Lesion size 0 means no tumor is seen. Lesion size is equal to 1. Tumor is less than 0.5 centimeters. Lesion score equals 2 is tumor is between 0.5 to 5 centimeter, and LS3 is tumor more than 5 centimeters. Now you add the scores, and a PCI less than 10 will give good results for after cytoreductive surgery and IPEC. So cancer deposits in 6 or more regions of the abdomen includes high tumor load. That means the IPEC may not give adequate results. Completeness of cytoreduction is calculated R0, R1 or R2. R0 and R1 are very important. Number of resections and anastomosis are also important. So univariate and multivariate analysis were looked into to support that complete cytoreduction of less than 2.5 millimeter residual nodules is the single most important prognostic factor. So completeness of cytoreduction is graded as CC0, no visible disease, CC1 less than 2.5 millimeter residual disease, CC2 2.5 to 25 millimeters, and CC3 greater than 25 millimeter. Or using the R score, R0 complete resection, R1 no gross disease with maybe microscopic positive margins or microscopic disease. R2 is macroscopic residual disease, R2A less than 5 millimeter, R2B 6 to 20 millimeter, and R2C is greater than 20 millimeter. So patient criteria, not every patient can be taken for surgery. Good performance status is very important. There should be no major comorbidities like cardiac, lung, liver dysfunctions, kidney dysfunctions. Patient's age less than 65 is important. Performance score really matters, 70 or above KF score. And PCI of less than 10 is very important. You can do it for 10 to 20, but the results are bad compared to less than 10. And for more than 20, the overall 5-year survival is 0. BMI of greater than 35 is a relative contraindication. Of the absolute contraindications, if there is extra-abdominal disease like lungs, bones, etc., no. Extensive intra-abdominal disease where optimal cytoreduction is not possible. Liver nodules can be removed if you can do a good volume preservation of the liver, functional residual volume. Invasion of hepatic pedicle or retroperitoneum where it cannot be resected. Long bowel segments, if they have to be resected, like if you cannot live 6 feet of small bowel, then you cannot do. Metastasis of unknown primary, you don't know where the tumor has started from, you cannot decide the chemotherapy, there may be disease elsewhere, so you have to be careful. Suboptimal cytoreductive surgery, please don't do IPEC. Intolerance to chemotherapy drugs, you cannot do the IPEC because the drugs can cause serious reactions. Primary cancer, ovarian, colorectal cancer, and primary peritoneal mesotheliomas, primary peritoneal carcinomatosis can be taken. Others are gastric malignancies and sarcomas. Histologically, signet ring cell or poorly differentiated tumors have fared better. So cytoreductive surgery is done first, then you give chemotherapy solution at 41 to 42 degrees. You're circulating through the abdomen for around 1.5 hours. So 90 minutes, drainage of the fluid and incision closure. Before incision closure, you will do the whatever anastomosis have to be done after trimming the bowel edges. So IPEC rationale is the plasma peritoneal barrier interferes with the delivery of chemotherapy drug to the peritoneal cavity. Direct tumor penetration is depth of penetration is only few cell layers to 3 millimeters. So you should know that you can only treat microscopic residual disease and not macroscopic disease. Clearance from the body cavities is slower than with systemic routes, achieving higher regional concentration of active agents and more prolonged exposure. So tumor size less than 2.5 millimeter is very important. Targets microscopic disease. The pharmacokinetic advantage is achieve higher local concentrations of chemotherapy drugs like 12 to 15 times the plasma concentration of these drugs. The mean peak peritoneal concentration of 1,116 times compared to the plasma peak concentration. So high temperature increases the drug penetration by vasodilation and also as a synergistic effect with intraperitoneal chemotherapy. Adhesiolysis is done before doing this thing, so the chemotherapy drug can circulate better. So it is always done after complete cytoreductive surgery and before any reconstruction of the bowel is done. Moderate hyperthermia above 41 degrees to 43 degrees as direct anti-tumor activity, as I told you already. So constant hyperthermia is obtained during IPEC by providing a continuous circuit with a pump and heat exchanger, and temperature monitoring has to be done so that ideal, if the temperature is not maintained, the purpose is not served. During the procedure, temperature probes are placed at different sides of the circuit and in the intraperitoneal cavity, the inflow, outflow drains, bladder, liver, and mesenteric surfaces, as well as at the heat generator. So the carrier solution is around 1.5 liter of isotonic dextrose solution. Peritoneal dialysis solution is most widely used. However, some groups are used normal saline or 5% dextrose in water, depending on the type of the chemotherapy agent. Body surface is an accurate predictor of drug metabolism and also estimates the systemic drug toxicity better. The accuracy increases if the volume of the chemotherapy solution is determined by the body surface area. Females have 10% larger peritoneal surface compared to males, so use 2 liters of fluid instead of 1.5 liters. There is clinical data demonstrating safety with different schemes on an empirical basis, which includes temperature of 41 degrees during 90 minutes and 43 degrees for 30 to 40 minutes. So the temperature monitoring is all, I am stressing it repeatedly, is so important in IPEC. Above 43 degrees, it's troublesome. Below 41 degrees, it is useless. So chemotherapy drugs, mitomycin C, oxaliplatin, doxorubicin, cisplatin, and paclitaxel. You should be aware about the different drugs, what is the dosage, what are the side effects, and where are they used. Depending on the organ that you choose, the drug varies, like appendix or pseudomyxoma peritoniae or colorectal cancers, gastric cancers, ovary, you can use mitomycin C. Oxaliplatin only in GI malignancies. Cisplatin can also be used in GI malignancies and pseudomyxoma peritoniae and ovary also. So similarly, you have to choose the different drugs. So as I told you, appendicular malignancies, mitomycin, GI malignancies, mitomycin, ovary also mitomycin can be used, but in ovaries also, you can use cisplatin or paclitaxel. Colorectal surgeon malignancies, you can use mitomycin C, oxaliplatin, or irinotecan also. Mesotheliomas, you use cisplatin or doxorubicin or mitomycin because those drugs are effective on that. So mitomycin C, as I told you, is peritoneal and colorectal malignancies. The dose over 90 minutes of 12.5 milligrams per meter square. I will not stress too much on the dosage because it is too much for you people. So we choose the dosage. Oxaliplatin is given in 5% dextrose. So you have to look for hyperglycemia and hyponatremia. Pharmacokinetics suggest a better pharmacological profile at 42.5 to 43 degrees. Cisplatin IPEC has been used in mesothelioma, ovarian, gastric malignancies, and you should be aware of the nephrotoxicity. There is no standard IPEC dosimetry. Everybody has used varying dosage ranges, so you have to choose the best for your clinical use. Hope I am not running short of time. So this is the machine, heat exchanger, which gives, the machine, the fluid is circulating through this, heated, and then goes to the peritoneal cavity, comes back again regulated. So you can use this monitor for regulations. So temperature probes are placed everywhere, ear, inflow catheter, outflow catheter to monitor the temperature. Only once you reach the required temperature, you start the circulation. So closed technique, open technique, combined technique, or semi-closed technique or laparoscopic techniques. So closed technique has advantages. You have closed the abdomen. So inflow and outflow lines are placed first, like drains, and then the abdominal wall is closed, and then the IPEC is done. There is no increased risk of anastomotic recurrence or GI fistula with the closed technique. The major advantage is you maintain uniform hyperthermia and you can reach the temperature quickly, as there is minimum heat loss from a closed abdomen. Also, increased peritoneal pressure will add to the benefit of the chemotherapy penetration. However, differences have been noted in distribution of chemotherapy agents with a closed technique because the wound is closed, you don't know how the fluid is circulating. This may cause higher frequency of complications and non-uniform treatment. The open technique allows for manual distribution of each and cytotoxic solution. You can use your hand or you can use some instrument to mix the chemotherapy solution in between. Coliseum technique is what it is called. The skin edges of the abdominal incision are suspended from a Thompson or a Bookwalter retractor by a running suture so that open space is created. A plastic sheet can also be incorporated into the wound, into the suture. So then you create a small incision in the plastic sheet. Your hand with long gloves, gynec gloves, can go in to mix the chemotherapy drug during chemotherapy. So usually one inflow and two outflow catheters are used. Temperature probes are placed near the inflow catheters and the outflow catheters. So smoke evacuators are placed to guard against any potential cytotoxic aerosol contamination to the operating staff. Large volumes of perfusion fluid can be added allowing the small bowel to float in the cavity expander. So that is very important for fluid circulation. Disadvantages are rapid heat loss. So you have to constantly adjust the temperature, maintain the temperature properly, and possible drug leakage, increasing potential exposure to the theater staff, means aerosols. So this is the open technique. This is you can use double Thompson retractor, or you can use Buchwalter retractor. Lift it up and then you can give the IPEC. Here, there is a plastic sheet incorporated into this Buchwalter retractor. You can place your hand inside and give wash. This is the closed technique where the wound is closed and then the fluid is circulated. So perfusion techniques, this study showed that there was no statistical difference between the two techniques, whether it is the abdominal temperature or core temperature, central venous pressure, heart rate, BP, and urine output. So also the morbidity and mortality. So chemotherapy drugs are better absorbed and tissue uptake was achieved with well with the open technique. So the open technique is better favored. The Coliseum method was identified as the best technique in terms of thermal homogeneity and spatial diffusion compared to the closed technique. Excessive heating of more than 43 degrees can cause risk of postoperative ileus and bowel perforation or GI fistula formation. So anesthetists also sitting in the backdrop, they will not be silent. They have to be working restless. So balanced salt solutions like RL and acetate-based solutions must be used. Albumin must be used continuously, and also non-invasive cardiac output monitoring, arterial pressure monitoring, cardiac output monitoring must all be being done continuously. And urine output of 1 ml per kg per hour during CRS and reconstructive phases, and 2 ml per kg per hour during IPEC is the mandatory thing. So urine output goal should be accomplished by using IV fluids and, if required, diuretics. So temperature monitoring, because the core body temperature is heated, they are supposed to do some things to maintain normothermia during the CRS phase. So they suggest passive cooling of the patients before starting IPEC, so that the patient's body is not affected by the heat in the peritoneal cavity. Use of ice packs in the axilla and neck during IPEC phase. Use of cool air blankets. Use of cold crystalloids at around 6 degrees during the IPEC phase. So the core temperature of the body must be 39 degrees, even though the peritoneal cavity is at 41 to 43 degrees. So laparoscopic, some centers have been doing laparoscopic IPEC. If the volume of disease is low, you can do resection of the tumor. Should not be any bowel involvement, particularly appendicular malignancy. It is useful. Long period follow-up is not available, but it can be done in dedicated centers. And also it can be useful in palliative treatment of malignant ascites, like the PIPAC technique, which we do for intraperitoneal aerosol administration of chemotherapy drugs. So there are variety of studies which have gone. No, some are retrospective studies, some are randomized studies, but very large scale studies are still lacking because of the volume of the disease and the operability are not uniform everywhere. But still there is uniform, there is some data which shows that 5-year survival of 35% and a cure rate of 16% can be achieved in IPEC and cytoreductive surgeries across various studies. Some you see that this is, I think, the mucinous pseudomyxoma peritoneae, 16.3 years median overall survival after IPEC. Similarly, like this study shows that median overall survival of 19.4 months versus 11.2 months when systemic chemotherapy and cytoreductive surgery is done. So all these studies show that there is a benefit of IPEC when with optimal cytoreductive surgery.
Excuse me, sir.
Yes, sir. How much time I
Sorry
have
to
left?
interrupt. Sir, just 4 minutes there.
Yeah, can I finish in 2 minutes?
Yes.
Okay. I think I don't have many slides left now.
Okay.
Okay. So average operating time in this study of 2,298 cases, average operating time was 9.5 hours, 80% at complete tumor removal, average hospital stay of 3 weeks, post-operative mortality of 2%, and major morbidity of 24%. As you can see, overall survival and progression-free survival are better when you achieve cytoreductive, complete cytoreduction of 0 versus microscopic disease, that is CCR1. Whereas major debulking, you can see that only it is almost equal to biopsy. So same thing I'm stressing again, disease-free survival of 19.2 months, whereas overall survival of 16 months, morbidity of 31.3%, and mortality of 1.8%. The complications we must be aware, I'll describe that in the next slide. Watch for complications like infections, leaks, paralytic ileus, bone marrow suppression, organ dysfunctions, thromboembolism risks, low WBC counts, neutropenia, and thrombocytopenia. Although systemic absorption of chemotherapeutic agents is limited by the endogenous pharmacological properties, means not much is absorbed through the peritoneal cavity, but there is significant hematological toxicity in the postoperative period, even with whatever volume it is absorbed. So perioperative systemic chemotherapy is very much needed to reduce the tumor load so that optimal cytoreduction is possible. The volume of tumor reduces, the patient may be better fit for surgery. Lymph node positivity is associated with poor outcomes after CRS and IPEC because due to the higher systemic recurrence rates. Perioperative systemic therapy could improve outcomes by decreasing the risk of systemic failure. Adjuvant systemic therapy has to continue after the surgery. So, what this man said again, Dr. Paul Sugarbaker, they thought I was overly aggressive, but it turned out I was right all along. So don't, if you can think, innovate, and justify what you are doing and you achieve results, you can always go ahead with new things. Thank you very much. Hello.
Yeah, thank you, sir. It was a nice, exhaustive information available. If anyone has got any doubts, they can ask. Anything in the chat box? No questions in the chat box?
No questions in the chat box, sir.
Okay.
Shall we?
Yeah, we can.
Thank you very much. I'm
Thank
stopping
you,
my
yes.
session.
Thank you, sir. Thank you.
Thank you, Dr. Chandrasekhar, Dr.
Okay.
Rajshekar Jakas.
Thank you, sir.
Balkrishna sir, Guru Shantapa sir. Okay.
Yeah, thank you,
Yes, sir.
Venkatachala. It was a nice, informative talk.
Thank you, sir. Thank you for the informative lecture.
Thank you.
No.
Thank you for the chairpersons to chair the session, sir. So now moving on to our next session, the next session of the day, I would like to invite Dr. Guru Shantapa sir, Professor and Head of the Department, Karnataka Institute of Medical Sciences, Hubli, for a lecture on policy on hands-on training for PGs. Now I would like to call upon chairpersons for the session, Dr. Bhagavan BC sir, Vice Principal, Professor and Head of the Unit, Department of General Surgery, KIMS, Bangalore. So I also would like, sir is also an ambassador at Global Training and Education Center, begun at United Kingdom. And I also like to call for the chairperson, Dr. Balkrishna MA sir, Professor at Surgery, Surya Medical College, and former Professor and HOD at Mysore Medical College and Research Institute. Dr. Guru Shantapa sir, we can start the session now, sir. Thank you.
Yeah.
Good evening, sir. Dr. Guru Shantapa.
Sir, good evening, sir.
Yes, sir.
Good evening, this is Dr. Bhagwan.
A chairperson for you. I'm really
Thank you, sir. Thank you so much, sir.
Unexpected chairperson.
Yes, sir.
Good evening, Dr. Guru
So,
Shantapa.
Professor
This is
Guru
Dr.
Shantapa
Bhagwan.
did no introduction. It is well known to almost throughout India and more so in southern India. So, I welcome Dr. Guru Shantapa to deliver his lecture, sir. Thank you, sir.
Thank you. Thank you so much, sir, for the kind introduction. At the outset, I thank the organizers of MidCon 21 and the members of KSCASI, the chairman, secretary, treasurer, and EC members of the association for having given this opportunity to talk on this. The postgraduate teaching is my passion. More so giving a surgical training for my postgraduates. I am so much interested. When Dr. Lakshman called me and he gave a option of talking on this, easily I accepted. I thank Dr. Lakshman for having chosen me for this. I want to put a small video. The training is very important in all the professions. Cricket is one of my favorite sports event, even though I don't play cricket. Everywhere the training is required. The art of living, the what exactly to be done, what exactly not to be done, where exactly you need to concentrate, where exactly you need to neglect. So this needs to be done. Even the stalwarts like Tendulkar, the Dravid, Lakshman, and Virat Kohli, the present one, they need coach. Even the Federer needs coach. So whatever the level the person has reached, they need to have a one coach. Recently, I saw one video, WhatsApp video, wherein the senior most surgeon, he gave a talk mentioning that he wanted to have a senior professor as a coach inside the OT, so that he can find out what mistakes that senior surgeon is doing. Then the senior professor could find out that his arm was moving little unwanted movements, light was not getting adjusted. So he could make out those points and then he could correct, and that could help him for his further progress even at the age of 60. What I want to highlight, at whatever the experience we have, we need to have someone as a coach. During our curriculum, what exactly we are running now, we have 3 years of course as a postgraduate. In the first year of life, probably most of the postgraduates, they spend time in writing case sheets, writing all the documents, seeing patients and doing a lot of ward work. During second year of their life, probably they will come across some emergencies they will be doing with the assistance of their seniors, maybe some junior consultants. And third year, probably the first 6 months, they will be doing some independent procedures, but remaining 3 or 6 months, probably they are busy with their dissertation schedule. So they will neglect most of the training skills. In routine operations, probably most of the routine surgeries are done by consultants. Only these trainees, the so-called students, will be assisting them or holding the camera for laparoscopic surgeries. And none of the government medical colleges in India, as for the information, don't have laparoscopic emergency facilities. So hardly the students will be learning laparoscopic procedures for emergency surgeries. Why we are so much apathetic towards our students? If this question is asked, like by the students to most of the consultants, they mentioned that probably most of us in the present era, we have learned our laparoscopic procedures at the age of 40. So probably we have a feeling that why we should teach this laparoscopic surgery for these students at the early age. But this attitude may not be the same for younger consultants, younger teachers, wherein probably they have learned in the beginning itself. So they want these trainees or so-called students to learn laparoscopic surgery at the earliest. The introduction of few laparoscopic procedures at the last 3-4 months or 6 months for a trainee probably may not help them much to become experts in their laparoscopic surgeries. I come across this information from the internet when I was searching Miller's pyramid assessment. This is a beautiful pyramid wherein you can have an assessment for the postgraduates. If you see at the bottom, the base of the pyramid, which is widened, this is the knowledge about a particular disease. Unless we have a broader basic knowledge about a particular disease to diagnose and select modality of treatment, probably the remaining things may not be very effective. So if we can apply this, that is know, how to know or what is the disease, then knows why exactly the disease has happened and how exactly I should choose the procedure, so and so procedure. Then try doing it with the help of some seniors or the teachers, then do it independently. To give an example, simple case of acute appendicitis, If I tell my postgraduates, how will you diagnose acute appendicitis? If they don't know how to elicit ribbon tenderness, we will miss the diagnosis. If you miss the diagnosis, probably chance you may lose doing appendicectomy. So this exactly holds good. If he's doing appendicectomy with a senior assistant, and then when he comes to third year, probably he will be able to do it independently. The first two part of this is called cognitive domain, where there is a knowledge. The second two part of it is called psychomotor or behavioral domain, which constitutes technical skills. There are many modules like this, wherein they put different things in different headings. To one more to label, Javish model, wherein they put up 4 stages. In the first stage, they're just telling a story or the disease about that. Second stage, where the senior consultant or a teacher will assist him and the junior or the trainee will be doing. And the third stage, it's like a dump help, wherein he just stands without giving any assistance. He will watch and then make him to do the things. Final, without any assistance, trainee should be able to do it. This can happen only if a trainee has got a sound knowledge of the particular disease. I felt among all, this is the one which probably I practice in my institute and in my unit with my postgraduates. That is BID model, like briefing, intraoperative teaching of the student, and debriefing. Means we should brief or previously discuss the disease with the students and find out what is their thinking and attitude. And during the procedure, tell them how exactly we are doing it and where you need to take care. And after the procedure, if they have done a mistake, find out where exactly they went wrong, what they would have done, how things can be different. So if you do this, probably this is the best way of doing the training or the skill training for the postgraduates. There is a big question by a mentee, that is a student. Always they will ask, if you don't get hands-on training during our course of 3 years, what is the use? Who will give later? Because they have become consultants. They already got a degree in their hand. So who will give us the training? Who will give hands-on training? Probably the answer is big no. Because most of these students probably may not get their hands-on training. So it is our duty as a teacher, whatever possible, whether it is a minor or a major, if we can train them nicely with a good skills and with good impression, probably they will become good consultants as far as the technique is concerned. The few surgeons probably may have some expertise in a private setups where by paying some expected fees, probably they may get a chance of hands-on training, and some lucky chaps, they will go abroad to get the training and they will come back and start practicing. These are the 3 circles which I have made. Personally, I felt this is very important. Like I've written, see one, do one, and teach one. If you see these circles crossing each other, they are not independent. They are dependent each other. In the sense, unless you see one, you cannot do it. Unless you do it, you cannot teach it. Unless you teach someone, you cannot see it again. So they go hand in hand. So what I mean, if you learn something, unless you teach someone else, probably your things are not complete. You will become an expert. The other person also will learn, so that this circle continues and society will have excellent surgical skilled surgeons. When I was searching that to get trained in a surgical oncology journal, I found out the duration of the duration required to become a consultant to do surgeries independently as far as the oncology is concerned. In India, it is around 10 to 11 years to get a degree and come out and start doing something. But in abroad, it takes around 15 to 17 years. The reason why I have put this slide is, what attitude we have here. If we get a degree today, probably all of us postgraduates feel that, yes, tomorrow they can go and practice. That is not the case. In abroad, to do one surgery, to give an example, laparoscopic surgeries, after doing the degree, 15 to 20 surgeries should be observed or assisted with a consultant, and then another 20 should be done under the guidance of someone, and then you are allowed doing independent. That is why it takes a lot of time. Probably they will become good expertise. They will be showing their good surgical skills. I could find out this information from IJS, our own journal, wherein they could find out from trainees in the general surgery department. When they studied this, it was very surprised. Majority felt that going into the specialty training during the rotations, during second year of course, they felt they will get information, they will learn something, it will help to improve their technique. But surprisingly, 38 out of 89, that is 42% of these felt these rotations adversely affecting their general surgery operative log. So this is the information what we got. And majority of these candidates, they said they joined this general surgery course because just they want a license to do specialty courses. That's what their opinion was, 52 out of 89. Only 8 out of 89 were happy to pursue only at general surgery level. Remaining all they wanted to do, pursue the further degrees. But about 34 out of 89 were okay with either general surgery or a specialist. So what I wanted to highlight, if we keep this mindset to get a license of MS to do specialties, probably we will lack in skill developments. This I could find out from one of the editorial article in IJS, which is by Dr. Lakshman, who has mentioned about the 2 domains for surgical training, that is a cognitive domain and psychomotor domain, which are highlighted in that pyramid. So in that, he has given a solution that this can be solved by 3 means. 1, by providing or showing simulation of doing techniques. Second, good mentoring, where teacher is the person who will change their thinking and attitude. And third, enlisting some private people so that they can guide the trainees. The things like this, like which we conducted workshops, doing on anastomosis, doing on energy sources, doing on some hand trainings, which we conducted and we do conduct often. Do they really help? Personally, I feel they will help. It depends on the candidate, how they do it, how they take it, how they implement it. But definitely they will at least motivate them to learn something, to handle, at least to know what all things are available like that. Definitely this will help. So my opinion is, if the institutes can do this very often, so that in a period of 3 years, if they can do at least 3, if they can come across 3 or 4, probably that will help the trainees. This is one of the area, that is simulation, which recently we opened up in our Department of Surgery at KIMS Hubli with the help of J&J Institute and with our administrators in our department. We could implement this, which was a long time wish in our department, wherein we started with the endo trainer, with having the 3 endo trainers and giving training and a skill lab for suturing and other techniques. I feel definitely this will help for the postgraduates. I have kept a model here, and we have kept a register. We have allotted one of our consultant on rotation, teacher, and limited students, making different batches so that they will be observed and individually they are trained, and whatever we do, that is entered in the register, and every month we'll be reviewing that. This is what we have planned. So if it is done by all the institutes, probably students will be benefited to improve their skill course. For laparoscopy skill courses, there are 2 types. One is a core surgical skill course, laparoscopy skill course. One is advanced. Probably at the level of post-graduation, if we can implement and see that all the students learn the basic laparoscopy skill, probably that is more than enough. I got this information from the internet. Maulana Azad Medical College is the first medical college to have endo trainer skill lab in the Department of Surgery for the help of postgraduates. This is from the information. This can be done by means of different techniques, through endo trainer, by transferring peg transfer, or transferring thermocol balls from one area to other, or keeping into the bowel, and learning clipping skills. There are many things like this, even placing the rod and putting the rings over that, and to check hand-eye coordination. So various technical skills which can be done through endo trainer, and age is no bar. If a person is interested, probably everywhere, if the facilities are available, this is where I went to one of the workshops where robotic surgeries can be, just if you are interested to have a knowledge, it can be done. Here it is suturing techniques which are being trained. Even advanced laparoscopic training or techniques can be learned through simulators, wherein it is shown the placement of the mesh. Like this, there are many things. Even endoscopic procedures can be done through simulators. This is one I wanted to explain. When I was going through Washington University School of Medicine in the Department of General Surgery, they have mentioned, when looking at a surgical training program, you want one with an amazing depth and breadth of clinical experience, the flexibility to create customized training, and a family of faculty and co-trainees who make you feel like you belong. That's what their general surgery department is. Probably if all of us can think about this and implement, probably our students will be lucky to have such things. These people, they have put on like this, One with a surgical scrub and glowing and gowning, which is a minimum thing required for a surgeon, which they should learn at the earliest. Second, suturing techniques, laparoscopic surgery and robotic surgery. The first one, it is not an exaggeration. I do it in my department, in the unit, to house surgeons. When they become interns, probably that is the best time they should know this first part of it, so that if they become surgical postgraduates, further they can learn. There are virtual reality surgical simulators available in sophisticated institutes. Definitely it is of use for learning. Like I was mentioning, there are various techniques through simulators one can learn by picking up the modalities with the help of faculties. I was searching putting hands-on training for surgical postgraduates in the internet, in the Google. These are the things I got immediately. Only certificate course are plenty available in the internet, but will it suffice? Big no. So getting a certificate doesn't mean that we are skillful. So unless you have a practical knowledge, difficult. Teaching in OT is important tool for the postgraduates. So if we can tell them while suturing how to take the needle out rather than describing on the screen or theory, probably it is of no use. So definitely it helps showing during surgical procedures, which I said BID resume. I wanted to show one video here, how we can train our postgraduates even during endoscopic training. Explain a little bit about the anatomy and the function and important aspect of the scope to postgraduates.
Yes, you can do, sir.
Yeah, it's moving.
Moving, sir.
Yeah. Then after explaining few of the important points, then the scope is given to the postgraduate. We have to tell them how exactly that is to be held, where exactly thumb should come, what index finger should do, what the middle finger should do. He's passing this is done by the postgraduate now. He's passing the biopsy forceps. I was mentioning about briefing and this is my postgraduate who is describing to me about the procedure which he is going to do. Once I am convinced that yes, he has understood the procedure and he is able to describe me nicely, and if I am convinced, then he is allowed to operate. So this is, I felt personally, this is the best way of doing things to the postgraduates rather than giving a talk and insisting them that yes, you are supposed to do this, that. There is one more, the 5-turn 4-step approach. Probably this is self-explanatory, what the teacher does, what the trainee does. There are 3 simulated training settings. One, which has got a virtual reality, which is least realistic and most controlled. Probably may not be for everyone. The second one is most realistic using human patient simulators. And third one is the animal model, which every institute may not be able to have it. This is one of the area where people are doing on dummies. We all of us teach most things on technical skills. I'm not going to cover up on non-technical skills, but I want to highlight here about the non-technical skills for a postgraduate, which is the diagnosis. So if person cannot diagnose, more so in acute conditions, probably will not be able to treat the patient nicely. So I insist the student should know, even though it is included under non-technical, we should be able to diagnose when it is a peritonitis, when there is a blunt injury abdomen with hemoperitoneum, when there is a peritonitis with appendicitis, probably so that we'll be able to diagnose and treat them early. Like I mentioned in the beginning, this constitutes 3 points: mentor, mentee, and management. All three includes the skill training. Mentor, one should have an interest and a dedication to teach the mentee. Having understood the responsibility, we should know what is our responsibility, and attending and supervising the cases which they do it. And these are the points which encourage us to do it. And there are many points which may discourage for a mentor to do their work sincerely. Mentee, keeping up to the mark, he should know what is his responsibility, understanding the efforts of a good mentor, contributing with a mentor for the progress of generation next by teaching, which I have highlighted in the beginning. Unless they teach the next generation, probably we may not have good trainees. So mastering the basics than planning far ahead. Plan now master degree with surgical skills best. Further, you can plan later. There is no fixed curriculum that stipulates a minimum number of laparoscopic surgeries to be done or open surgeries to be done. That is a disadvantage for a mentee. What are the challenges for the obstacles for a mentee? There are 5 things. Burnt out. They burnt out in first year itself. There is a confusion in technique because somebody does something, so they are confused. What is right, what is wrong? Unequal learning opportunities, maybe with he or she or some boy, some other. So there can be some inequality, and some people may be neglected, some people may be upgraded, and there is a responsibility misassignment. Some PG is given more responsibility, some PG. So these are the little challenges for a mentee. And one in the third year will be doing everything, but probably may not know anything. The one in the first year will be doing everything without knowing anything. This is a long-standing tradition which is going on. Probably no one are ready to accept this or change it. If you can do well and educate, understand what the mentor is putting your efforts and become an indispensable postgraduate, you will learn good techniques. There are many things in the operation theater which a mentee should understand just standing blindly. When they are seeing somebody is operating, if you can see what's happening there, probably many things can be learned. This is my statement. As is your cognitive domain, so is your psychomotor domain. So if you can become strong with your subject and the knowledge, probably techniques can be learned fast. There are various assessment tools for the postgraduates, depending on what exactly theoretically we are doing or technically we are doing. The management facilities, what I mentioned in that triangle 3 circles, yes, this is, of course, it is really important, more so for laparoscopic surgeries. Yeah, if institutes, all the institutes can give importance and make availability of this skill course and other availability of all the items, probably everyone will start doing simulation and showing techniques to our beloved postgraduates. Facilities for advanced laparoscopic surgeries also should be available, and availability of laparoscopy for emergency surgeries in government institutes, in all the institutes, probably will help us, will boost our postgraduates to learn many things. When I was reading a newspaper on 8th September in Deccan Herald, I just saw this, which comes as a biasis. There is one article, every paper will have this, don't burn the bridges. It was a nice article. I thought of putting this. It is to keep relation between two people. If you burn that bridge, probably relations are lost. So if we keep the bridge between a mentor and a mentee and see that bridge is nice and there is a good communication and good reciprocation in the form of doing everything good for the patients, probably the mentee will be benefited. In conclusion, the surgical curriculum must be state the year-wise goal of a surgical training, what exactly to be done in first year, second year, and third year, including the number of open surgeries, number of laparoscopic surgeries, number of procedures. If it is hernia, how many hernias, how many hydrocele, if they can, university and if the authorities can make a platform, minimum of this and implement, probably that may help to at least to fulfill that. People have to teach and students have to do it. So it will help probably in improving skills. And there should be a performance evaluation before the trainee can be promoted to the next year. It is not just filling up that logbook, showing that how I have done so many procedures and getting the signature. No, there has to be evaluation of performance. We have to evaluate whether he's going to suture nicely, doing hydrocele nicely, doing debridement nicely, doing skin grafting nicely, and give marks and perform evaluation of performance. And a surgical trainee should not get a senior residency merely on the basis of interviews and passing and getting a degree, but there has to be some reference from the mentor, like what abroad they get a fellowship unless there is some somebody give a reference. So like that, if there is some mentor give a reference, honest reference to honest and deserving people, probably that will help in improving the quality of our postgraduates. These are my references, and with this, I conclude my talk. So I hope I have justified in giving my talk how exactly the mentor can help our mentee to improve the skill capabilities and surgical skill for the postgraduates. And again, once again, I thank the KSCASI and MidCon team for having given this opportunity. Thank you, one and all.
Thank you, sir.
Thank you, Professor, sir. Thank you for your excellent talk.
Yes, sir.
I also
Thank you,
faced
sir.
whatever you have mentioned in the first few slides. I was also in the same steps during those days. I have
Yes,
never,
sir.
in the not delay, I have never done even a single surgery as a postgraduate student during my days. And never, not even one single surgery. That is the reason why when I'm in a teaching profession, I allowed all my students. I used to assist them to do the surgery.
Nice, sir. Very
Thank
nice
you for
of you.
your excellent talk and
Thank
encouraging
you.
talk. And even now, there are some people who never give even skin also for the postgraduate student to future. Even now, there are. Then now the topic, I mean, this is open for discussion. Any doubts, you can ask the speaker.
Dr. Gurushantappa, this is Dr. Bhagwan.
Yeah, hello. Yeah. Thank you.
It was a very good talk. I do agree. I was just, I fully agree with you. In UK, it's called as improvised surgical training. It's called IST, where the mentor is appointed for the mentee to take it forward. And what they have recommended is that to cut down on the night work, and non-medical, non-surgical work. Most of the time, we engage our postgraduates in going to the lab, collecting the reports, and then collecting some histopathological things, writing the case sheets. In those things only they spend a lot of time. Instead of that, in the day hours, they should be trained as you have made it structured training, and setting the goal for 6 months or for a year, academic year, what they should learn. Hands-on training is a very good method which has been recommended and which is being followed in many universities which I have seen. And if you implement these things, I think the hands-on training skills will be improved. Otherwise, just merely learning the theory part and going out does not help them to become a good clinician either. So I fully agree with you. Thank you very much.
Sir. Yeah, thank you. Thank you. Yeah, really, it is true. It is true. We are evaluation is done only on theoretical grounds in many areas, especially in a surgical specialty. Evaluating on theory grounds probably will not fetch or will not help our patients.
From Rajiv Gandhi University of Health Sciences, in fact, we are implementing the simulation lab in most of the government colleges. It's going to help the postgraduates in a very big way. The best equipments we are planning to put, and it will help. Of course, it will not replace the human resources as much as possible. It has to be hands-on training on the human beings, from the first year onwards. But anyway, simulation is the best method
definitely.
for them to give good confidence in the beginning.
Thank you. Thank you, Bhagwan.
Yeah.
Okay, sir. Thank you, sir. Thank you so much. Thank you, Dr.
Yes.
Gurushantappa, sir, for such a wonderful and thoughtful discussion. Thank you, Bhagwan, sir, and Dr. Balkrishna, sir, for chairing the session.
Thank you very much. Thanks, everybody.
Okay, sir. Thank you, sir. Thank you, sir.
Thanks, Balkrishna, sir. Thank you.
Thank you, sir. Thank you, Chandru.
Chandru, thank you
sir.
very much.
Welcome, sir. Welcome, sir. Welcome. Thank you, sir.
ಸಿಗ್ತಾರ ಹುಡುಗರು ಒಬ್ಬ ಕುತ್ಕೊಂಡ್ ಪಕ್ಕ ಸ್ಮೋಕ್ ಮಾಡ್ತೀಯನಾ?
Next session, I'd like to welcome you all to the free paper session 5 of day 3. I would like to welcome the chairpersons of the session, Dr. Ganesh Shenoy, Consultant Laparoscopic GI Bariatric Surgery, AV Hospital, Bangalore, Executive Committee Member, Hernia Society of India, Director, Guru Kripa Specialty Clinic, Bangalore. And I would like to welcome the another chairperson, Dr. Mallikarjun M.N., Associate Professor of Surgery, Bangalore Medical College and Research Institute. I would also like to welcome the judges for this session, Dr. Lokesh M.G., Assistant Professor, Mysore Medical College and Research Institute, and Dr. G.S. Mahesh, Professor, Sridevi Medical College. Before beginning the presentation, I will to the presenters, there is a 10 minutes of presentation. First 8 minutes for the presentation and another 2 minutes for the discussion. After 6 minutes, there will be a first warning, and in last 30 seconds, there will be a second warning. I would like to call the first presenter, Dr. And I would request the presenters to switch on their videos during the presentation. And I would like to call the first presenter, Dr. Shabnam Sachdeva.
Good evening, sir.
Start your presentation. Your time starts now.
Yes, sir. I'm going to present on a comparative study of open mesh repair and laparoscopic mesh repair for inguinal hernia. Next. Introduction. Inguinal hernia is one of the most common conditions seen in clinics and is often treated through the general surgery department. Laparoscopic repair and open repair with mesh are typical treatment for inguinal hernia, and both regimes have proved beneficial in treating inguinal hernia. A laparoscopic method of performing a tension-free repair has subsequently been reported to result in low reoccurrence rates and to be associated with substantially less pain in the immediate post-operative period and earlier return to normal activities than the open mesh repair. With a multitude of surgical methods, it can often become difficult in deciding the best method of repair. An array of factors contribute to deciding which operative technique is best utilized for a patient presenting with inguinal hernia. Next slide, please. The basic anatomical principles of laparoscopic hernia were first described by Spaw in 1991 based on human cadaveric dissections. He coined the term triangle of Doom, delineating the region between the vas deferens and the spermatic vessels. The methodology, coming to the methodology, it is a randomized prospective study which was conducted on 40 subjects at a tertiary care hospital to compare laparoscopic hernioplasty and Lichtenstein open mesh repair from November 2019 to April 2020. The sample size was taken according to the inpatient number. The inclusion criteria of the study was patient with unilateral or bilateral inguinal hernia and male patients above 18 years of age. Exclusion criteria was complicated hernia was excluded from the study, hernia associated with varicocele or hydrocele, and recurrent hernias. The patients were divided into two groups of 20 each, and they were randomly allocated to undergo laparoscopic technique or open hernioplasty. Each patient was given a unique hospital identification number and medical history, past surgical history, detailed physical examination was done by treating surgeon as per the study performer, and relevant investigations were done. Patients in group A underwent laparoscopic hernioplasty and patients in group B underwent open hernioplasty. The Lichtenstein tension-free repair was done under spinal, whereas the laparoscopic mesh repair by both TAP and TAP, it was done under general anesthesia. The parameters assessed for comparison are operative time, duration of hospital stay, post-operative complications, pain in post-operative period, resumption of daily activities post-surgery. The post-operative pain was assessed using a visual analog scale as shown. Next slide, please. The data was entered in MS Excel and analysis was carried out using SPSS version 20. The descriptive statistics like frequency, mean plus standard deviation were used, and the inferential statistics like pair t-test was used to compare. If p-value was less than 0.05, it was said to be statistically significant. The results of the study consisted of 40 patients, out of which 20 were operated for laparoscopic and 20 underwent open hernia repair. The mean time taken for bilateral laparoscopic hernia mesh repair was 128.23 minutes, whereas for unilateral, it was 49.79 minutes. The mean time for unilateral open mesh repair was 39.8, and for bilateral, it was 78.5 minutes. This shows the mean pain. The mean pain score for at post-op day. Next slide. The mean pain score at post-op day 0 was for laparoscopy. So the mean pain score at post-op day 0 in laparoscopic was 5.8, whereas at post-op day 0 for open was 7.75. At post-op day 3, the mean pain score for open was 5.75, whereas for lap it was 3.55. For laparoscopic post-op day 7, the mean pain score was 1.15, whereas for open it was 1.5. Next slide, please.
Okay. Next slide.
The mean, this is the same. Next slide, please. The average duration of hospital stay was 3 days for laparoscopic hernioplasty in contrast to the open hernioplasty, which was 5.95 days. The mean duration of resumption of day-to-day activities was 6.8 days following laparoscopic hernioplasty and 8.75 days following open hernioplasty. Next discussion. Our study analyzed both unilateral and bilateral hernia patients, unlike the previous studies such as by Sudarshan PB et al., which looked into unilateral hernias only. In our study, 27 had unilateral inguinal hernia and 13 had bilateral. 7 out of those with bilateral underwent laparoscopic hernioplasty and 6 open mesh repair. The mean operative time for unilateral open hernioplasty was 39.8 minutes and bilateral was 78.5 minutes, whereas for unilateral laparoscopic hernioplasty, it was 49.79 minutes and bilateral was 128.28 minutes. Hasma et al. And Rathod CM et al. Reported the similar results where laparoscopic mesh repair took longer than Lichtenstein open mesh repair. In our study, we did not record any intraoperative complications like injury to spermatic cord, vessels, and viscera in both the groups. Whereas the study by Sudarshan PB et al. And Hasma et al. Had reported similar results in their studies, whereas Numer L et al. Had reported that 4.8% of laparoscopic patients and 1.9% of open repair patients had intraoperative complications. McCormick et al. Conducted a meta-analysis and noted that operative complications such as visceral, especially bladder and vascular injuries, were higher in laparoscopic techniques. Several other older studies had observed higher complications with laparoscopic surgeries. The strength of this study is that it compares TAP and TEP mesh repair with Lichtenstein open mesh repair, unlike the previous studies, which were TEP only, and it included unilateral as well as bilateral hernia. The limitation is that it doesn't look into a long-term follow-up and it has excluded complicated hernias. Coming to the conclusion, with our study, we were able to infer that laparoscopic hernia repair, though takes longer duration to perform, had nil intraoperative, lesser post-operative complications. Patient has lesser duration of hospital stay and lesser post-operative pain and early resumption to daily activities. Inguinal hernia repair is one of the most common surgical procedures, and adapting the laparoscopic approach will have a better outcome and reduce morbidity. Thank you, sir. These are my references, sir.
Okay. Open for discussion.
I request judges to go for the questions.
There are 2 questions in the chat box. Can you please answer those questions? Presenter?
So,
Do you use same set of instruments in bilateral open hernia or a separate set? It's a question for you.
so same set of instruments were used, sir, for bilateral as well as unilateral.
Okay. Duration of follow-up?
The follow-up of 6 months, sir.
Follow-up what?
For 6 months, I have done follow-up, sir. Our study included the follow-up of 6 months.
Okay.
That is from.
Any questions?
I have one
Am I
question.
audible, sir?
Yeah, audible.
I would like to ask a question. Is there any time difference?
Sir?
Yeah, I'm Dr. Ganesh Shanai. So is there any time difference in the duration of surgery between a TEP and a TAP procedure?
Pardon, please, sir.
See, in the laparoscopic group, you have done both TEP as well as the TAPP, isn't it?
Yes, sir.
Was there any difference in the duration of surgery?
Yes, sir. The TAP was much like it took lesser time, sir, as compared to TEP. So because, sir, the operating space was less, so TAP repair was.
So you mean to say TAP repair was faster than the TEP in your case?
Sir. Yes, sir.
Okay, Dr. Shabnam, your time is up. I would like to call the next presenter, Dr. Subhashini Bhaskar Rao. Dr. Subhashini.
Yes.
You can start your presentation. Your time starts now.
Respected teachers and colleagues, today I'll be presenting a paper on assessment of gastroesophageal reflux disease symptoms in type 2 diabetic patients under the guidance of Dr. G. Rajshekhar Babu, Professor, Department of Surgery, and Dr. Manoranjan, UD and Research Institute. So next slide. Gastroesophageal reflux disease is characterized by the presence of esophageal mucosal injury caused by the abnormal reflux of gastric contents into the esophagus. Heartburn, regurgitation, and water brush are the three typical esophageal symptoms. The presence of regurgitation often indicates the progression of GERD. Next slide.
Subhashini, you can switch off your video.
Yes.
Because network is not good.
The objectives of this study is to see whether if there is any discrepancy between the subjective symptoms and grades of endoscopic GERD in type 2 diabetes mellitus patients, and to measure the deviance in subjective symptoms and grades of endoscopic GERD in type 2 diabetes mellitus patients. Next slide, please. The major symptoms of GERD includes the heartburn, which is seen in about 60% of the patients, and chest pain, which is seen in about 12%. Other symptoms include regurgitation, dysphagia, and a sensation of lump in the throat. The major risk factors includes obesity, which is seen in which contributes to about 42%, hiatal hernia, which contributes about 26%. The other risk factors include gastroparesis, scleroderma, and pregnancy. Next slide, please. The study was conducted between February 2020 and February 2021. 200 patients who were treated in Victoria Hospital were included in the study. Group 1 included diabetic patients and Group 2 included the non-diabetic patients. Diabetic patients with a duration of more than 10 years and non-diabetics were included in the study. Patients with history of gastrectomy and patients on PPIs for more than 6 months were excluded from the study. A return informed consent was taken from all the participants. Both the groups were subjected to an interview-based rating scale comprising of 16 questions known as the Modified Gastrointestinal Symptom Rating Scale and to esophagogastroduodenoscopy. Next slide, please. The modified GSRS symptom rating scale includes 16 symptoms rated from 1 to 7. A score of 1 represents the absence of symptoms and a score of 7 represents very bothersome symptoms. A positive GSRS score is indicated when it's more than 2. It was compared among both the groups using Pearson's chi-square test. A p-value of less than 0.05 was considered to be statistically less significant. Next slide, please. On endoscopic GERD, according to the Los Angeles classification, it was classified as grade A, B, C, and D. Grade B or more was considered to be endoscopic severe GERD. Grade A includes more than or equal to one mucosal break less than 5 mm long, none of which extends between the tops of mucosal fold. Grade B includes more than or one mucosal break more than 5 mm long, none of which extends between the tops of mucosal fold. Grade C is mucosal breaks which extend between the tops of more than or equal to two mucosal fold, which involves less than 75% of esophageal circumference. And grade D is mucosal breaks which involves more than 75% of esophageal circumference. These are the grades A, B, C, and D according to the Los Angeles classification. Next slide, sir. Coming to the results, 30 patients were excluded and 170 were included as per the inclusion and the exclusion criteria. 123 males and 47 females were included. The mean age was 60.9 and the mean BMI was 23.7. Now, out of the 170, 108 were diabetics, out of which 36 had a severe GERD on esophagogastroduodenoscopy, and 62 were non-diabetics, out of which 39 had a severe GERD on esophagogastroduodenoscopy. Our study indicates that the question on acid regurgitation in the GSRS is useful for detecting severe endoscopic GERD in patients with and without diabetes mellitus. Furthermore, among the 36 patients with severe GERD, only 10 of the diabetic patients were able to have a positive GSRS. However, in non-diabetics, out of the 39, 37 were able to perceive a positive GSRS score, which showed that the frequency of the positive GSRS was much lower in diabetics than non-diabetics. Hence, the prevalence of patients with a positive GSRS score for acid regurgitation was statistically lower in diabetic patients than the non-diabetic patients. Next slide, please. The discussion, the primary mechanism against the GERD is the lower esophageal sphincter. Anti-reflex mechanism includes the flap valve, the phrenoesophageal ligament, and the lower esophageal sphincter. A complex relationship exists between hyperglycemia, gastric distension, and vagal tone, which increases the lower esophageal sphincter pressure. There were certain limitations to the study. pH monitoring, which is considered as a gold standard for diagnosing GERD, was not used in the study. Information that may have affected the results of, such as the duration of diabetes mellitus, medications other than PPIs, Helicobacter pylori status, were not obtained in the study. Next slide, please, sir. Conclusion. The major roles of OGD in the management of GERD patients are to diagnose and treat complications of GERD, especially the peptic strictures, and to prove the presence of the Barrett's esophagus. Chronic inflammation triggered by the gastric acid reflux into the esophagus or GERD can lead to Barrett's, which is precancerous. Hence, it is critical to assess the GERD because it may be the start of carcinogenesis, especially among patients with a high risk of adenocarcinoma. Due to autonomic neuropathy seen in diabetes, the frequency of symptoms perceived is less in diabetic group. Therefore, screening upper GI endoscopy should be advised as a routine in all diabetic patients more than 10 years duration. So next slide, sir. These are the references, sir. Thank you.
Panel is open for a discussion.
Subhashini?
Yes, sir.
Yeah, I would like to ask you a question. So what is the indication for 24-hour pH metry in a case with GERD?
Yes, sir. Since there is, sir, actually, according with the endoscopy findings are grade B or more, according to the Los Angeles classification, usually the patients are subjected to 24-hour pH monitoring.
No, do you subject all patients for 24-hour pH monitoring? It's the gold standard. So in which patients you ask for a 24-hour pH monitoring in a patient with GERD?
So patients with severe symptoms or patients whose symptoms and the endoscopic findings are not correlating, sir, we would ask for a 24-hour pH monitoring, sir.
What is endoscopic negative GERD? ENGERD. Have you heard of it?
Yes, sir. I'm not sure.
For the presenter, there is a question in the chat box. Can you answer the question? How did you manage the patients and follow-up?
So the symptoms, the patients who had come to the OPD with symptoms of GRD, sir, were subjected to the questionnaire with a history of 7 days, sir, previous 7 days history. And then patients were followed up with endoscopy, sir, for about 6 months, sir, on 6 months.
That's all. Did you do any treatment?
So patients were on PPI, sir, and patients with changes on endoscopy were subjected to biopsy specimens, sir.
Any surgery?
No surgery was done, sir.
Okay.
Any other questions, sir? Okay, thank you, Dr. Subhashini. I would like to call the next presenter, Dr. Stefan Sebastian. Dr. Stefan.
Hello.
You can start your presentation. Your time starts now.
Good evening, everyone. Today I'm presenting my paper with the title of Peripheral Artery Occlusive Disease during the COVID-19 pandemic in a tertiary care hospital, a single center experience. Next slide. Aims and objectives of the study was to determine the incidence, presentation, and clinical outcome of patients with peripheral artery occlusive disease presenting during the COVID-19 pandemic. The materials and methods. The type of study, it was a retrospective record-based study. The duration of the study was from March 2021 to August 2021. The patients presenting with peripheral artery occlusive disease with tissue loss or gangrene to Father Muller Medical College, Mangalore from March 2021 to August 2021 were included in the study. The age, comorbidities, clinical presentation, surgical intervention, need for resurgery, duration of hospital stay were recorded from clinical records, operation notes, and progress sheets. The clinical status was defined using Rutherford classification system. The inclusion criteria were patients between the age of 18 to 75 years, both male and females, patient who presented with peripheral artery occlusive disease with tissue loss or gangrene requiring surgical intervention. The exclusion criteria, patient who presented with peripheral artery occlusive disease not willing for surgical intervention or who were conservatively managed. Patients below the age of 18 and patients above the age of 75. Coming to statistical analysis, all the data collected were entered into a Microsoft Excel sheet. The data was analyzed and presented in the form of mean, frequency, and standard deviation. Variables were compared using chi-square test, and p-value less than 0.05 was considered significant. Now, coming to the results, a total of 72 patients presented with gangrene or limb ischemia to the hospital between March and August 2021. Of that, 62, that is around 86% of the studied cohort were males, and around 14% were females. Around 70% of, that is around 50 of the 72 of the study population were diabetic and were on medication. Around 30%, previous slides, around 30% were hypertensive. Around 9% of the patients had undergone previous revascularization procedure. Around 60% gives history of smoking. Next slide. Now, out of the 72 patients who were admitted in the hospital and underwent any procedure, 90% presented with severe disease, that is Rutherford, grade 4, 5, and 6. Of that, only 20% of the total patients were deemed fit and underwent successful revascularization procedures. The remaining patient limbs were not salvageable and underwent amputation. Around 29% underwent AKA, 14% underwent below knee amputation, 52% underwent toe and toe disarticulations, and 5% underwent forefoot amputations. Out of the 25 who underwent major amputation, 10 required resurgeries due to ascending gangrene or stump necrosis. 5 out of the 14 who underwent revascularization also underwent amputations due to failure of the procedure or ascending gangrene. Next slide. Of the 72, around 9 patients presented with COVID-19, and comparing their value with the mean value and applied chi-square test showed that the APDT value In the mean test group was, that is COVID positive patients were around 29 and the control group was 37. The PT in the prothrombin time in test group was 14.25, control group was 16.76. The p-value of APTT was less than 0.05, hence significant, while the p-value of prothrombin time was 0.07, which is less than 0.05, hence significant. The parameters such as D-dimer, ferritin could not be used to make a correlation as it was not evaluated in COVID-negative patients. However, the test group, the values were markedly raised. Next slide, please. Coming to discussion, peripheral artery occlusive disease of a major artery below the aortic bifurcation. Vast majority of peripheral artery occlusive disease is caused by atherosclerosis. Patients with peripheral artery occlusive disease present with intermittent claudication, which progresses to critical limb ischemia with rest pain and gangrene, leading to significant disability and limb loss. Acute lower extremity ischemia, ALI, resulting from arterial embolus, arterial thrombosis, or bypass graft thrombosis remains one of the most common vascular surgical emergencies. 18 patients presented with acute limb ischemia to a hospital during this span. The post-procedure rates of mortality and limb loss have traditionally been reported as high as 20 to 40%. In our study, it was found that 34.72 limbs could not be salvaged. Conventional treatment of patients with acute limb ischemia has been systemic anticoagulation and emergent open surgical intervention, specifically thromboembolectomy or bypass. Our study, around 20% could undergo limb salvaging procedures. During the pandemic, the surgical indications of patients with PAOD became more stringent, and patients' willingness to seek medical treatment also changed. Due to the lockdown, patients presented late, which could be the reason for around 90% who presented with Rutherford more than 4. Studies have also postulated that presence of coexisting hypercoagulable state in patients with COVID-19, which might be associated with higher mortality. Our study showed APTT to be significantly lower in COVID-positive patients, and it was a hypercoagulable state. Despite the use of antiplatelet or anticoagulant therapy, patients have been presenting with irreversible lower limb ischemia due to free-floating thrombi. Coming to a case, a 63-year-old female presented to a hospital with bilateral lower foot gangrene, with gangrene of first and second digit as post-COVID sequelae. She was diagnosed and treated for COVID-19 infection and was on anticoagulant therapy when she presented. CT angiography of bilateral lower limbs and arterial Doppler of hand was free of any significant atherosclerotic disease. Echo was also normal. Patient underwent bilateral below knee amputation. Intra and post-operative period was uneventful, and she was discharged on oral anticoagulation to improve limb survival. Coming to the conclusion, our study showed an increased severity of presentation of peripheral artery occlusive disease to our center and an increase in incidence of amputation and post-operative morbidity during this COVID period. The incidence of patients with advanced vascular disease has increased due to pandemic and its restrictions. Inability to salvage the limb can be attributed to their late presentation. Furthermore, COVID-19 infection increases the incidence of acute limb ischemia due to an acquired hypercoagulable state. Prolonged anticoagulation is warranted for both salvaging the limb and improved survival. Next slide. These are my references. Next slide. Thank you.
Panel is open for discussion.
For the presenter.
Yes, sir.
We have a question in the chat box from the Madam Naz.
Yes, sir.
Have these patients received both low molecular weight heparin and dapagliflozin during their COVID infection period?
So mostly these patients were positive. They were most of them came as post-COVID sequelae. So we haven't assessed like what anticoagulation they had undergone when they were admitted with COVID-19 infections.
This actually make the impact whether they've taken the anticoagulation or not. Okay.
Yes.
Any other anticoagulation that can be used other than this low molecular weight heparin and dapagliflozin?
So normally acetrom or dabigatran has been used. Not sure. Normally, according to guidelines, these are which we
Is there any correlation between the severity of the COVID infection and your limb ischemia?
I didn't get the question, sir.
Do you have any correlation between the severity of the COVID infection, what they had before the admission, and this one
Acute limb ischemia
presentation? Yeah.
Yes, sir. Actually, we had only done inflammatory markers for the patients who are admitted with COVID. We only have reports of, because it's a retrospective study, the COVID, only D-dimer and all those inflammatory markers have been only done for COVID positive. COVID negative patients have not done all these markers. So we cannot, and then the severity actually depends on the inflammatory markers. So then we couldn't assess it properly in the study.
Any other questions? Okay, thank you, Dr. Stephen.
Thank you, sir.
I would like to call the next presenter, Dr. Prakyatyam. Dr. Prakyat, you can start your presentation.
Yeah, good evening, everyone. Today's my paper. I'm Dr. Prakyatyam, surgical postgraduate from Mysore Medical College. And my today's paper is comparison of fasciotomy wound closures using traditional dressing changes and vacuum-assisted closure device. Next slide, please. So introduction. We define compartment syndrome as an increase in the interstitial pressure within a closed osseofacial space, impairing capillary perfusion within the compartment. So the resulting fasciotomy wounds can be a reconstructive challenge to the surgeon. So these wounds often cannot be closed primarily due to retraction with muscular edema and protrusion of the muscle through the fascia. So these fasciotomy wounds can be a major contributor to the length of the stay of the patient, as well as it is a difficulty reconstructive challenge for the surgeon. So once the compartment pressure has been relieved and stabilized, the wound should be closed as quickly as and as early as possible to avoid the later cosmetic complications. The purpose of this study was to assess the closure of fasciotomy wounds using the vacuum-assisted closure device or negative pressure wound therapy. So we examined the upper and lower extremity fasciotomy wound outcomes, including time to definitive closure, comparing traditional wet to dry gauze dressings and the vacuum-assisted closure device. So our hypothesis was that the VAC has a higher success rate at achieving primary closure in comparison with conventional treatments. In addition, we believe that VAC decreases the length of time to wound closure and it expedites the recovery, decreases the need for a lengthy hospitalization and allows for early rehabilitation. So materials and methods. Then this was a retrospective study, included a consecutive series of patients over a 2-year period with the diagnosis of acute compartment syndrome. The subjects for this 2-year retrospective study included a series of 60 patients which presented to our emergency department. So the exclusion criteria among these patients included the patient with burns, extensive soft tissue loss, amputations, and infectious etiologies such as necrotizing fasciitis. The fasciotomy wounds were treated with either conventional normal saline soaked dressings or VAC device by randomization. So this VAC system consists of an open cell polyurethane foam sponge which was sealed by an adhesive drape. The sponge was cut to fit into the wound using one or multiple contiguous pieces of sponge. So above this we applied a adhesive dressing and we had to cut a 2 centimeter hole over the dressing, and with this we introduced a perforator tube which was connected to the VAC device. So a controlled suction force of 125 millimeter Hg, which was subatmospheric pressure, was applied, resulting in the sponge collapsing towards the center of the wound. The patient's VAC dressings were changed every 2 or 3 days in the operating room or at the bedside, that is, which is less than 3 times per week. So wounds healed by primary closure, secondary closure, or through skin grafting. Next slide, please. So these are our results. The success rate and time to primary closure was significantly better in the VAC group versus the non-VAC group. So when we compare the wounds, there was a significantly, that is p-value less than of 0.05, higher rate of primary closure using the VAC versus traditional wet to dry dressings. By analysis of the effects, this represents a 5-fold increase in likelihood of closing fasciotomy wound, primarily if the vacuum closure assisted device was used. Furthermore, the time to primary closure of wounds was shorter in the VAC group, that is 6 days, in comparison with the non-VAC group, that is 7 days. And also the time to the skin graft wounds was shorter in the VAC group, that is 8 days, in comparison with the non-VAC group, which was significantly high, that is 12 days. So as we can see in this image, The topmost image was the day 5 of the post-vac dressing. We can see that the edges are approximated and the wound healthy granulation tissue was present and the skin was almost approximated the edges. And when we come see the second image, there was slough present, the edges are retracted, and it took a majority of the times it took a longer time for approximation of the skin wounds. Next slide. So discussion. So these fasciotomy wounds can present a difficulty reconstructive challenge to the surgeon. Skin grafting of fasciotomy wounds is the most common procedure we use in our setting to achieve the closure. But this skin grafting, the wound, it can lead to both morbidity and scarring at both donor and fasciotomy side. It can also complicate the donor side. So in primary closure of fasciotomy wounds results in a more functional and aesthetic outcome with less morbidity for the patient. So this can be difficult to achieve, often difficult to achieve secondary to edema, skin retraction, and skin edge necrosis. So when we use the negative pressure wound therapy or VAC, it uses the viscoelastic properties of the skin, which enables it to stretch extensively in a very short period of time. So the application of negative pressure applies an evenly distributed tension along the wound margins. So this traction will pull the wound edges closer progressively, as we saw in the image, and decreasing the wound size. In addition, this vacuum-assisted closure device or negative pressure wound therapy, it removes the wound edema, and it also stimulates the angiogenesis, decreases the bacterial counts, and it significantly increases the rate of granulation tissue formation. So as a result of skin stretching, we can close the wound, and wound closing tension decreases, and it allows for primary closure of the large defects. In addition, the VAC device is simple to apply, and dressing changes occur every 2 or 3 days. So we can always avoid multiple daily dressing changes like we do in daily wet to dry gauze dressings, which frequently get soaked. So with patients with small wounds, if patients have very small wounds of fasciotomy wounds, we can always treat the patient as outpatients. So this study has shown that the use of VAC for fasciotomy wound closure results in a higher rate of primary closure versus traditional wet to dry dressings. The VAC used in the described settings decreases the hospital time. So it allows the patient for early rehabilitation, reduces the morbidity of the patient, it reduces the hospital time of the patients, and it leads to more patient satisfaction. So what we conclude from this study is using the VAC significantly improves the ability to close wounds primarily and decrease the treatment time and overall recovery time. The stretch skin is an ideal match. What major advantage is the stretch skin is it's an ideal match in color and it still has the hair bearing properties and the sensory innervation is preserved in contrast to the skin grafting which we do regularly. So what we conclude is that closing the fasciotomy wounds primarily can be accomplished at a higher rate with better outcomes by using the VAC device. Thank you, everyone.
Panel is open for discussion.
Prakhyatam.
Yes, sir.
Instead of putting a lengthy fasciotomy, this thing, or making a lengthy fasciotomy, can you make small wounds so that you can prevent the length?
Yes, sir, we can always do that, sir. But many times we have seen that when the wound length is decreased, we always retake the patient to the operative room so that we should still, we have many times seen that we need to extend the incision to further reduce the edema fluid, sir.
Was there any culture taken after the completion of the vacuum dressing?
Yes, sir. We usually take the culture after completion of vacuum dressing, but since we are not planning the wound closure by skin graft, we usually close it by the primary intention.
Was there any difference in this one non-vacuum and vacuum dressing, the culture media?
And sir, usually in what we get in vacuum dressing is we see that more of the anaerobic organisms was present in the vacuum dressing, sir. Since it is a closed compartment, so we are closing the wound. So we most of the time we get anaerobic culture in vacuum dressings than
Srikanth played a very intelligent game. He knew that after fellowship.
Sir.
Okay, can go ahead. Any other questions from the chairpersons and judges?
There is one question. What is the major mechanism of wound healing in VAC dressing?
So the major mechanism of wound healing is in VAC, we usually apply the subatmospheric pressure to the wound. So it always reduces the wound fluids. So these wound fluids majorly contains the dead tissues which preserve the wound healing. So when we apply the subatmospheric pressure, it reduces the wound edema. It promotes angiogenesis and it helps in formation of healthy granulation tissues.
What type of pressure was applied? Negative pressure was applied in your case? Is it continuous, variable, or intermittent?
Sir?
Was it continuous or intermittent?
Sir, we applied a pressure of minus 125 millimeter of Hg for 48 hours, and then we opened. Sir,
is it continuous or intermittent?
It was a continuous pressure.
Continuously, the same pressure was maintained continuously, or
we applied 125 millimeter of Hg pressure, sir, for 48 hours. Then we reviewed the wound. Then we had to apply alternate pressure, sir, for that.
Time up. Thank you, Dr. Prakhya. I would like to call the next presenter, Dr. Chandan Kumar R. Dr. Chandan, you can start your presentation.
Thank you. Good evening, judges and chairperson. My paper is about clinical profile, management, and outcome of patients with blunt abdominal trauma admitted in a tertiary care hospital. Next slide, please. In today's mechanized world, blunt trauma abdomen is a common emergency which is associated with significant morbidity and mortality. It is more common among the economically productive workforce of the population. With modernization, industrialization, and motorization of the society, there is a rapid increase in the incidence. These injuries are reported to be amongst the top 10 killers around the world, and abdominal injuries are amongst the top 3 of the overall cases, and majority are of blunt character. A motor vehicle accident occurred for 75 to 80% of the blunt trauma abdomen, and it can also occur as a result of fall from height, assault, industrial mishaps, sports injuries, and bulgur injuries. Blunt trauma abdomen is dangerous because the clinical manifestations of injury may be delayed for several hours to days, and the internal damage is lethal. The early detection of intra-abdominal injuries can be challenging in some patients, particularly those with seemingly minor trauma or normal clinical examination. The abdominal injuries may be parietal or visceral, and the visceral injuries may be intraperitoneal or retroperitoneal. Next slide, please. Liver, spleen, stomach, and various other intra-abdominal organs are included in this study. The delay in the presentation at the hospital after injury to multiple organs, excessive blood loss, and the ominous reputation for high morbidity and mortality are just a few of the many reasons which makes this topic a fascinating one. Next slide, please. The aims and objectives of my study is to study the incidence of blunt abdominal trauma, incidence of injuries to various organs, to study various factors like time of presentation after injury, age, symptoms, and clinical presentation. Also to study the importance of various investigations and outcome of treatment. Next slide, please. So this is an observational prospective study of 56 patients with blunt abdominal trauma admitted in the Department of Surgery, Care Hospital for a period of 1 year. All patients with history of blunt abdominal trauma are kept under monitoring of vitals, general physical examination, and systemic examination, and were subjected to detailed laboratory and radiological investigations. All the patients more than 18 years of age with blunt trauma abdomen admitted in the Department of Surgery were included in the study, and patients associated with severe head injury, orthopedic injury, except thoracic and rib injury, those who died before confirmation of definitive diagnosis, patient who refused to give consent, and those who left against medical advice without completing the treatment were excluded from the study. Now, majority of the patients of blunt abdominal injuries were male, and half of the patients were from second and third decade of life. This further proves the fact that young people are more vulnerable to blunt abdominal trauma. Next slide, please. In the following graph, you can see that the majority of the patients presents with pain and tenderness in the abdomen. The other features include vomiting, distension, guarding or rigidity, hypotension, tachycardia, and hematuria as well. The pulse rate at presentation varied from 74 to 150 beats per minute with an average of 94 per minute. The road traffic accident was the most common mode of injury, followed by assault, bulgur injury, and fall from height. Next slide, please. Now, this is interesting. Only about 7% of the patients came to the hospital within 1 hour of injury, while 15% of the patients came after 24 hours of injury, and 10% of the patients came after 48 hours of injury. This shows the lack of knowledge and neglect, and also the lack of transport facilities available to people. However, most of the patients came within 5 hours of injury. Next slide, please. According to the data, the liver, spleen, and mesentery were the commonest organs which suffered injury in case of blunt abdominal trauma. Associated injuries were present in 23 cases, and the most common extra-abdominal injury was found to be thoracic injury, which accounted for 41% of the cases. Next slide, please. The average duration of hospital stay was 14 days. The hospital stay directly indicates the magnitude of trauma a patient has suffered. It is observed that the hospital stay increases with complications either related to the postoperative sequel or associated injuries such as major surgery. And 62% of the patients were treated with surgery, and 38% of the patients were managed conservatively. And the surgical management decisions were taken based on the results of physical examination and radiological examinations. Here we can see that 35% of the patients were discharged after conservative management, and 51% of the patients were discharged after operative management. And 10 to 14% of the patients succumbed to injuries. The most common postoperative complication was surgical site infection. Also associated postoperative complications include ARDS, sepsis, renal failure, and hospital-acquired infections. Next slide, please. The patients were subjected to routine blood investigations and radiological investigations. X-ray abdomen was done in almost all patients. It showed normal finding in 70% of the cases. The air in the diaphragm was seen in 9 cases out of the 12 cases. The sensitivity of the X-ray abdomen in detecting pneumoperitoneum was 75%. Out of a total of 56 patients of blunt abdominal trauma, ultrasound was done in 52 patients. Out of these 52 patients, 7% had normal ultrasound, 22 showed intraperitoneal collection, 16 of the patients showed liver injuries, 10 showed splenic injuries, and 2 showed renal injuries. The sensitivity in detecting the intra-abdominal injury was 87% in ultrasound. However, the gold standard investigation was CT abdomen that was performed in 32 patients. This is an excellent means to diagnose intraperitoneal hemorrhage. Next slide, please. The male preponderance in our study reflects the great mobility of patients for either work, such as drivers and mechanics for automobiles, or recreational activities, may be resulting in higher exposure to risk of traffic injuries. Most of the patients between 21 and 30 years were most commonly affected from blunt trauma abdomen. These men must have been the sole breadwinners of their families, and we can only imagine the socioeconomic impact on their families. The highest incidence in this age group can be attributed to the active lifestyle of the age group, with highest exposure to external environment, use of automobiles, working with machinery, assaults, and contact sports. Next, please. The outcome of a victim depends on various factors. The morbidity and mortality varies with age, body habitus, force, and location of trauma. It also depends on a coexisting morbidities of an individual and magnitude of associated injuries, delay in diagnosis and treatment, sepsis, and respiratory complications increase the mortality. The clinical assessment is sometimes inaccurate since there are often distracting injuries, altered level of consciousness, non-specific signs and symptoms. Early recognition and management of associated injuries and complications is of paramount importance in reducing the morbidity and mortality. The non-operative management is gaining increased acceptance mainly because of easy availability of CT scans. The disadvantage of non-operative management are those of missed injuries and delayed treatment resulting in excessive morbidity and mortality. The commonest organ to be injured was the liver, and the post-operative wound infection was the most commonest post-operative complication. Next slide, please. The initial resuscitative measures and correct diagnosis forms the most vital part of blunt abdominal trauma management. Prompt evaluation of abdomen is mandatory to minimize preventable morbidity and mortality. The major cause of mortality was delayed presentation of patients with poor general condition, of patients with associated injuries, and delayed surgical intervention. The rules and regulations of road safety and precautions while using the automobiles have to be imbibed at an early age. Schools, social media, and licensing authorities of the government will have to play an important role in this matter. It is the golden hour of injury when prior comprehensive action can save lives. A stitch in time saves 9. Thank you.
Panel is open for discussion.
Yeah, good evening, Dr. Ganesh here.
Good evening.
Have you done damage control surgery in any cases?
Sir, in one case, we have done a damage control surgery. Sir, it was a case of liver laceration.
Liver laceration.
Yes, sir. So
when do you do a damage control surgery? How did the name came? Damage control surgery.
Sir, in case of a blunt trauma abdomen, there is a lethal triad of metabolic acidosis, hypothermia, and acidosis, hypothermia, and hypocoagulability, sir. So when the patient's vitals are unstable, sir, it is better to keep the patient alive rather than correct the anatomy, sir. So its main aim is to achieve hemostasis and also prevent the triad of acidosis, hypothermia, and
So how did you manage this liver laceration patient?
Sir, we tried to reduce the hemorrhage, sir. We packed the laceration and sutured the lacerated wound, sir.
When was the pack removed?
Sir, we packed with the hemostat, the surgical dress. I mean, with the styptic, sir. What do we call it? The spongesterone was put and it was just closed, sir.
What is damage control surgery?
Sir, initially,
for example, suppose if you have used, let me tell you, suppose if you have used a Surgicel or whatever
yes,
to control the hemorrhage, then come out, do you think that is damage control surgery?
That's more like a definitive surgery, sir.
Yeah. What is damage control surgery? In one patient, you have done a damage control surgery, isn't it?
Yes, sir.
In a case of liver trauma. See, most common case will be a blunt abdominal trauma with liver injury for a damage control. That is the most common.
Yes, sir.
Okay, so what do you do in a damage control surgery?
So initially we stabilize the patient and we correct the physiological stability has to be maintained first. And then the post-operatively in the ICU, we control the
No,
other
what do you
parameters
do
of
during
the
surgery?
patients.
I mean to say, what do you do during surgery? You do a laparotomy now.
Yes, sir.
Okay, so patient with blunt abdominal trauma has come, CT scan is showing a liver injury, you want to open the abdomen, you have done a laparotomy, you see the liver injury, when will you decide? And how will you do it, the damage control surgery? What will you do in that?
Sir, we can put packs and try to control the bleeding, sir.
Then you close the abdomen with the mop inside?
No, sir. We control the bleeding.
You don't close the abdomen with the mop inside?
Not sure, sir.
See, what you do in damage control surgery in such cases, Chandan, you pack the abdomen, you put the mop inside as a compression. Okay. Then you remove the mop after 24 to 48 hours once the patient is stabilized.
That is damage control.
That is damage control surgery. Okay.
Time up.
Resuscitation.
Time up. Thank you, Dr. Chandan. I would like to call the next presenter, Dr. Muktesh BS. Dr. Muktesh, you can start your presentation.
Good evening, panel. I am Dr. Muktesh, I'm PhD resident. I'm presenting on nanocrystalline silver dressing in wound management, a prospective study. Next slide, please. Introduction. The ultimate goal of wound healing is fast recovery with negligible scarring and to attain best function. The wounds expose patient to various hazards like infection, tissue necrosis, disfigurement. It's our task to minimize the adverse effects of injuries, remove and repair the damaged structure, hasten the process of wound healing, and to restore the function as best as possible. A poor glycemic control results in lessened inflammatory response, neovascularization, and collagen synthesis, therefore delaying healing. It is the interaction of contributory causes which leads to the breakdown of foot at risk. Next slide, please. Silver as an antiseptic or antimicrobial and an anti-inflammatory properties is a broad spectrum antibiotic effect on the wound, and silver sulfadiazine or other ionic silver agents silver zero in ion zero in an unchanged form of metallic silver present in nanocrystalline silver. Free silver cations have a potent antimicrobial effect which destroy microorganisms immediately by blocking the cellular respiration and disrupting the function of bacterial cell membranes. This occurs when silver cations bind to tissue proteins, causing structural changes in the bacterial cell membrane, which in turn causes cell death. Silver cations also bind and denature bacterial DNA and RNA, thus inhibiting cell replication. Materials and method. In this study was conducted in a tertiary care center. A total of 60 cases were enrolled in the study. Patients were divided into two groups. The first group received a clean wound with normal saline, nano silver crystalline gel was applied over the wound covered with paraffin mesh. In the second group, sulfadiazine soaked gauze was applied. A maximum follow-up of 8 weeks was undertaken, and ulcer status was noted using visual assessment, thus analyzing the response of ulcers at both dressings. Both patients who were IP and OPD patients were taken into the study, and regular follow-up was undertaken on a weekly basis. If the patients were not unable to arrive at the hospital, photo or visual aid was undertaken for follow-up. Next slide, please. Age distribution for the study was the first group had a majority of patients at 40 to 50. Since the patients were taken in a randomized area, the age was not evenly distributed across groups. Both patients, there are more patients with higher age in group B, that is sulfadiazine group, and there is less patients age under 50 in group A. Next slide, please. The initial wound size and area was measured, and standard deviation was taken with the mean for that. Initially, in the first week, the percentage reduction and initial length and the percentage reduction of the area of the wound were taken as parameters. During the study at 4 weeks in group A, the final wound size was 1 centimeters with a standard deviation of 1 centimeter. And in group B, the final wound size was 2.8 centimeters with a varied standard deviation of 4 centimeters. Wound size is comparatively less in group A than group B at 4 weeks of follow-up. Next slide, please. This slide shows the end result of the patient under the study who at 4 weeks. Here you can see that one in each group had gone into amputation, and the significantly increased number of healed cases in group A, that is under silver nanogels, with 18 patients, and 60% of the study has healed without any intervention. One in each had gone into flap, one in and primary suturing. There were non-healed cases which included both amputee and flap covers were 7 and 9 in each group. Here we can see that in group B, there were no patients which had progressed to flap cover or for primary suturing, and there were significant number of groups which had to undergo patients which had to undergo grafting. Next slide, please. This table shows the floor status at the end of 4 weeks. The pale granulation tissue is seen in 5 patients in group B at the end of 4 weeks, and in group B, and 26% of the patient in group A had pink granulation, healthy granulation tissue, as compared to 33% of the patients in group B. A granulation tissue was comparatively better in group A than in group B. Next slide, please. This table shows all the organisms that has been isolated during the study in group A and group B. Pus culture positivity for culture sensitivity. Next slide, please. The percentage reduction in the wound size in group A, it has been 84% reduction, and in group B it has been 65% reduction. Next slide, please. Discussion. Nanocrystalline silver dressing are used selectively for infected wounds, particularly in chronic wounds. The effectiveness of nanocrystalline dressing should be evaluated in weeks. Extension of use beyond this time period should be based on expert knowledge. Wound with high amount of exudate requires secondary absorbent dressing, which should be changed on a regular basis as required. Various studies have found that silver dressing is beneficial in terms of cost effectiveness. Example, reduced time to wound healing, shorter hospital stay, reduced dressing change frequency, and reduced need for pain medication. Mendoza et al. Study a direct correlation states that direct correlation between old age and poor wound healing outcomes such as dehiscence. In Holt et al. Study that in comparison to healthy human volunteers, there is significant delay of up to 2 days in epithelialization of superficial skin defects in patients who are older than 70 years of age. Next slide, please. Previous slide. A study conducted by Kotze, Willer et al. In that it has stated that the male gender has
your a time is up, Dr. Muktesh. The panel is open for discussion.
Conclusion slide, please.
The panel is open for discussion.
Was there any particular contraindication for the use of the silver dressing?
No, sir. No contraindications were present for any usage silver dressing.
Okay, what is the timing of inclusion of this silver dressing when you for the first visit to the first start of your dressing?
Sir, start of the dressing on the first visit, sir. First visit only, sir. Yes.
If there is a lot of slough, you want to start straight away with the silver dressing after debridement, or you want to wait?
Sir, after 24 hours after debridement, silver dressing was started, sir.
Okay.
Any other questions, sir? Okay, thank you. We'll conclude this session. I will thank for all the chairpersons, judges, and presentees for making this session successful. Thank you, one and all.
Good evening, everyone. Moving on to the next session of the day, that is poster presentation. I'd like to invite Dr. Hanmantaya, Professor and HOD of Department of General Surgery, Rajarajeswari Medical College, Bangalore, and Dr. Raju GH, Consultant Surgeon at Fortis Hospital, Bannerghatta Road, Bangalore, to chair this session and to chair the session of poster presentation. Now I would like to also invite Dr. Vijay Kamath, Professor and Unit Chief of Department of General Surgery at KIMS, Hubli, Professor of General Surgery at JSS Medical College, Mysore. So a brief introduction regarding the session. That is, there are total number of 12 posters. Each poster has a maximum time period of 5 minutes, in which the first 3.5 minutes is for presentation and next 1.5 minutes is for discussion. So now, with the permission of the chairpersons and judges, I would like to ask the presenters to start the session. I'd like to call upon Dr. Start the presentation.
Yes, you can go ahead.
Are you ready? The last call. Next person.
I'd like to call Dr. Vishal Muttappa to start the presentation. Dr. Vishal.
Dr. Vishal, you can start the presentation.
This is the second one in the list.
Yes, sir. The first participant is not ready. So we
I'm ready, sir. I'm ready. There was some problem with the...
Dr. Suprita. Okay.
Yes, sir. I'm ready, sir. There was some problem with the Wi-Fi.
Okay, Dr. Suprita can start then.
Yes, sir. I'll start, sir.
Your time starts now.
I'll be presenting a poster on rare case of lower esophageal diverticulum. Next slide, please. Coming to the introduction, epiphrenic esophageal diverticulum is an outpouching of esophageal lumen usually situated in the distal part of the esophagus. It is typically seen within 10 centimeters of the cardia and usually originates from the right posterior wall. Their false diverticula are mainly associated with motility disorders, and it occurs in less than 1% of the upper gastrointestinal X-rays and accounts for less than 5% of cases of dysphagia. Here is a 66-year-old male patient who presented with complaints of dysphagia since 8 months, solids more than liquids, loss of weight since 8 months, regurgitation of food since 7 months, and abdominal bloating sensations in 7 months. Past history: he is a known case of type 2 diabetes mellitus since 10 years, and he had a history of surgery for epigastric hernia 10 years ago. Next slide, please. So as a preoperative evaluation, we got all the routine blood investigation which were normal. The barium swallow showed large diverticulum in the anterolateral aspect of the lower end of the esophagus, and UGScopy showed stasis esophagitis in the mid-third and large diverticula in the lower third with the residual food particles. And the size of the diverticula was 10 into 15 centimeter. Next slide, please. So we place the patient in Fowler's position with the operating surgeon in between the legs. And 5-port technique was used, and he underwent laparoscopic transhiatal esophageal diverticulectomy with cardiomyotomy. And the patient was kept liquid diet for 3 days prior to the surgery and NPO 8 hours prior to the surgery. Next slide, please. So the cut section of the diverticula showed a thick wall, and histopathological examination showed mucosa lined by stratified squamous epithelium with dysplastic cells in the lower 1/3, and subepithelial layer showed dense chronic inflammation. Post-op, we got a barium swallow again, which showed no leakage and good flow of dye. Next slide, please. Discussion. Epiphrenic esophageal diverticula is a rare entity with varying clinical manifestation, including dysphagia, regurgitation, weight loss, chest pain, halitosis, aspiration, and heartburn, with the majority of patients being asymptomatic until the diverticula are larger than 5 centimeters. Patients suffering from echinacea usually develop diverticula, prevalence being 0.015% to 2%, and incidence being 0.002%, occurrence being more common in females as compared to males and more on the right side. Conclusion: epiphrenic esophageal diverticulum is a rare disorder of esophagus with symptoms masquerading that of the cardiac disease. Most common cause is a motility disorder. Evaluation is by imaging, endoscopy, and manometry, and minimal invasive surgery is the best mode of treatment for early recovery and minimal morbidity. Thank you.
Panel is open for discussion.
Is the manometry done for this patient?
It was not done, sir. Manometry was not done for this patient.
Okay, okay. And barium meal shows quite significant dilated
yes, sir.
proximal loop. What is the treatment for end-stage dilated megaesophagus?
Sorry, sir?
No, in case if it fails, the surgical management, because it is quite significant enlarged.
Yes, sir.
Recovery will be usually the chance of failure of surgery is high in this kind of cases. So what is the next option?
We can do either transthoracic approach of the surgery in case of bigger diverticula. Okay. With left lateral thoracotomy and then.
What about cardiomyotomy?
It has to be done, sir. Usually on the opposite side of the diverticula, cardiomyotomy has to be done.
Okay.
Is there any role of endoscopic procedures?
There's a video-assisted thoracic surgery with laparoscopic myotomy and fundoplication, sir, along with video-assisted. In case of upper esophageal diverticula, we can do minimally invasive transoral diverticulectomy.
What do you call the procedure?
It is Duncan procedure.
OM? Have you heard about?
Yes, sir. Yes.
OM.
Thank you, Dr. Supraja. Now, on the next presenter, Dr. Vishal.
Yes.
Dr. Vishal, are you ready?
Yes, sir.
Yeah, we'll be starting your presentation. The time starts now.
Good evening, everyone. Today I'm going to present a case of sickle duplication cyst. Next slide. Coming to introduction, GIT is a fertile field for various and curious congenital malformations. So duplications of the element retractor are very rare malformations, which vary in size, appearance, location, and symptoms. Multiple theories have been proposed, but no single theory explains the known variants. It can occur in any part of the GIT from esophagus to anus, and always occurs on the mesenteric side. And there are two variants, that is tubular and spherical. Majority occur in ileum, but very rare in cecum. The incidence is around 1 in 4,500 births. Until now, only 19 cases have been reported in English literature. So surgery is a treatment of choice, and it has an excellent prognosis. Next slide. Coming to my case, a 30-year female patient presented with pain abdomen, which was on and off since 2 months, and mass in the lower abdomen since 1 month to gynecopedy, which was referred back to us. And she had history of mass in the right lower abdomen, initially of 4 into 4 centimeter size, which progressed to present size of 25 into 18 centimeter. She also presented with constipation since 15 days, and there was significant weight loss. And she also gave a history of irregular menstrual cycle, and she was nulliparous. On inspection, there was fullness noted in the right lower abdomen of 25 to 18 centimeter approximately, involving the right iliac fossa, hypogastric, right lumbar, and umbilical region. And restricted movements were seen in the right lower quadrant during respiration. On palpation, diffuse tenderness noted all over the abdomen, and guardia was present. 25 to 80 centimeter mass, which was obliquely oval. All the borders were made out except for the inferior border, and mobility could not be made out. Next slide. Auscultation bowel sounds were present. Per rectal, it was normal. PV, there was no fullness noted. Initially, we thought it might be a ruptured right ovarian cyst or a cecal mass with perforation. Routine investigations, blood investigation were normal. Chest X-ray was normal. CA19 was slightly elevated, that is 170.75 per ml. And CA and alpha proteins were within normal limits. USG showed a well-defined cystic heterogeneous lesion in pelvis extending into abdomen, measuring 13 into 5 into 14 centimeter with echogenic debris as contained. Minimal vascularity was noted, and uterus and ovaries could not be visualized separately, and MRI was suggested. Next slide. It showed hyperintensive lesion. Next slide. Next slide. So intraoperatively, 2 liters of chocolate gracicular fluid was drained, and we proceeded with the cystic lesion was arising from posterolateral aspect of cecum, and the breach, cystal wall was breached, and collection was drained, and right hemicolectomy was done, and diversion ileostomy was done, and we placed drains, and post-operative event was uneventful. Next slide. A cut section showed cecum with mucosa gray brown with area of hemorrhage, and multiple areas of small ulcer proliferative growth were noted. And tumor cells were predominantly seen in mucosa and infiltrating to submucosa, and glands arising in glandular and papillary pattern. There was high increased nucleus cytosol ratio with vesicular nucleus with prominent nuclei exhibiting mild to moderate pleomorphism, and there was extensive areas of necrosis and hemorrhage were seen. Post-operatively, patient was followed up for 4 months. Next slide. Community discussion.
The panel is open for discussion now. The panel is open for discussion.
Did you try to enter first, do laparoscopic and see what is the findings, and then open the patient?
No, sir. No, sir. We straight away went with laparotomy, and we did, sir. We didn't do laparoscopy, sir.
Hello, Vishal.
Sir.
I'm Dr. Anmantaya. So what was the operative finding? Just like that, you said that you aspirated some fluid, all those things. I mean,
sir, as we
the
opened abdomen, the cyst wall was already opened. So it was ruptured, sir. So we aspirated almost 2 liters of chocolate color fluid, sir. And the cyst was communicating with the posteromedial aspect of the cecum, sir.
Posteromedial aspect of the cecum. Okay. What is the incidence of the cecal duplication cyst?
Sir, it's less than 3%, sir. Most common is ileum and jejunum, sir, in JIT. Rarer are the cecum and rectal duplication cysts, sir.
Okay.
Thank you, Dr. Vishal. The time is up. Now I'd like to call upon Dr. Vinny for the presentation.
Good evening, sir.
Yeah,
good evening, everyone. I would be speaking about the impact of COVID-19 pandemic and its associated lockdown on wound care and the resultant increase in the number of amputations. Next slide, please. The aim of our study was to study a series of cases in order to evaluate the prevalence of major amputations during the pre-pandemic and pandemic period in order to evaluate the indirect effect of the COVID-19 pandemic and its associated lockdown on people with lower limb cellulitis and wounds and the resulting increase in the incidence of lower extremity amputations. This was a retrospective study which was conducted by evaluating the data of patients who presented to the outpatient and emergency department of general surgery in KR Hospital, Mysore between the periods of March and July 2021. The period was divided into 3 phases as the pre-lockdown, during the lockdown, and the unlock period. And we focused on the activity of wound care services provided during these 3 phases of the pandemic. The results that we obtained, we got a total of 76 patients during the 3 phases, of which 45 of the patients were admitted during the pre-lockdown period, whereas 4 patients only were admitted during the lockdown. In the unlock period, we saw a total of 27 admissions. Out of the 45 patients admitted in the pre-lockdown period, 22 patients required amputations, which amounts to 40%. Whereas 2 patients in the lockdown period required amputations. In the post-lockdown, that is in the unlock period, 19 of the 27 patients admitted required amputations, which amounts to 91%, which clearly indicates that there was an increase in the need for amputations in the post-lockdown period. The indications that we observed were necrotizing fasciitis, cellulitis, diabetic foot, and peripheral arterial disease, along with gangrene. The highest incidence was in that of necrotizing fasciitis. Coming to the discussion, the probable reasons that we suggested for this increased number of amputation is an increase. It's as a consequence of the lockdown and the associated travel restrictions, a widespread fear of going to a hospital amongst the people, a lack of awareness of the wound-related complications and the ill effects of neglecting such wounds, and shunting of the personnel for COVID management. Next, please. In conclusion, I would like to say that this study throws light on the importance of wound care and the drastic end result that negligence and untimely treatment can result in. We would like to stress on considering wound care as an essential service and treating wounds as a surgical emergency, on essential role of preventive actions in wound care and importance of need for awareness of complications if such wounds are ignored amongst patients. Thank you.
Now the panel is open for discussion.
Are all your cases COVID positive status? Have they underwent a treatment for COVID?
No, sir. We were just trying to see the impact that the lockdown and the lack of regular follow-up is resulting in, sir, not the effect of COVID positive or negative status.
I mean, have you done a RT-PCR test which was done in the
Yes,
post-lockdown period?
Yes, sir. All our admissions, all our IPs will undergo a routine RT-PCR, sir, irrespective of symptoms.
Did you find any associated gangrenes other than the foot?
Sir, actually, we did have a case of upper limb gangrene, sir. This patient was COVID positive, sir. Was found to be COVID positive 3 months prior to presenting to us, and that was due to a acute ischemia, sir. So we associated that to be like a probable sequelae of the COVID. But apart from that, most of our patients had lower limb wounds, sir.
Is this patients are associated with smoking as well as the diabetes?
Yes, sir. There were the second commonest cause that we saw was diabetic foot, sir, after necrotizing fasciitis.
What is the incidence of the diabetes pre-lockdown, lockdown, and the post-lockdown, as well as the smoking?
So we did not differentiate on the incidence of the diabetes.
Don't you think that that could be the reason?
Yes, sir. Uncontrolled sugars and newly diagnosed diabetes could also be a reason, a factor that increase their wound outcomes.
Fine.
Vinay, have you classified the wounds which patient went for amputation?
Yes, sir. Based on the clinical features, sir, the patients and based on their laboratory findings, patients with high counts, CRP, and those in AKI.
Thank you. Thank you, Dr. Vinay. The time is up. Now I'd like to call upon Dr. Kshitij for the presentation.
Hello.
Yes, Dr.
A very warm good evening to all the judges, chairpersons, and my fellow colleagues. I'm Dr. Kshitij Mahajan, surgery resident from KMC Mangalore, and welcome to my poster presentation on a case report on a rare case of non-Hodgkin's lymphoma of the thyroid. Next slide, please. Yeah. Coming to introduction, primary thyroid lymphoma is a rare diagnosis being recognized more frequently in a goiter that has grown significantly over a short period. Majority of these are non-Hodgkin lymphomas and mostly of B-cell origin. It is a rare disease with an incidence of 0.5 per 100,000 population. It is 4 times more commonly seen in women. Approximately half occur in a setting of pre-existing Hashimoto thyroiditis. Next slide, please. Coming to my case presentation, we had a 39-year-old male who came with us with swelling on the anterior aspect of the neck since 4 months, which was insidious and progressive, associated with dyspnea, weight loss, with no feature suggestive of hyper and hyperthyroidism. On examination, there was a 14 into 13 centimeter thyroid swelling with the left lobe enlarged more than the right lobe, along with the isthmus. It was firm in consistency, surface was smooth, palpable lower border with no cervical lymphadenopathy. The patient had normal routine investigations, including the thyroid function tests. The ultrasound examination showed a multinodular goiter with thyroiditis, increased vascularity with no lymph node involvement. And FNAC was suggestive of Hashimoto's thyroiditis with Hurter cell changes, BSRTC category 2. Next slide. The patient underwent total thyroidectomy and following was the surgical specimen obtained. Next slide, please. Coming to histopathological examination, it was examined under microscopy 40x and 10x respectively, and it was suggestive of thyroid tissue to be replaced by atypical lymphoid cells. Hurter cell changes were seen. There was dense lymphocytic infiltrate and lymphoid follicles with secondary germinal center formation, suggestive of non-Hodgkin's lymphoma with Hashimoto's thyroiditis. On IHC examination, it came positive for CD20, CD3, and CD5, and negative for CD10, BCL6, and MUM1, CD30, confirming a diagnosis of non-Hodgkin's lymphoma, diffuse large B-cell type. Coming to the discussion, primary thyroid lymphoma is a rare condition responsible for less than 5% of the thyroid malignancies and less than 2.5 of all the lymphomas. Most of them are NHL, with majority being DLBCL 50 to 80% and only 20 to 30 being wild type. Secondary thyroid lymphoma originates from non-thyroid neoplasm that has metastasized to the thyroid and must be differentiated as treatment modality is different. Presence of Hashimoto's thyroiditis increases the risk of progressing to PTL by 40 to 80 times. However, PTL is more common in females, 3 to 4:1. Presenting in the 7th decade with a rapidly growing swelling with pressure symptoms. Coming to conclusion, the role of FNAC is limited. As a result, this condition becomes an underdiagnosed condition. However, with new technical advances such as IHC studies and flow cytometry, it can be diagnosed. The treatment of primary thyroid lymphoma remains controversial since it's a rare diagnosis with no large.
Now the panel is open for discussion.
Kshitij.
Yes, sir.
Post-operatively, have you done any other investigations to know is there any other organs are involved?
Post-operatively, sir, patient was on close follow-up with serial ultrasounds and local examination. But as specifically, we have not followed up, sir, as per oncologist opinion.
Okay. how long you, up to what period you did a follow-up for this patient?
So the patient presented to us in our surgical OPD only since 2 months after the surgery. After that, he was only being followed up by the oncologist team. Sir.
Oncologist. Okay, so that fine.
Doctor, was staging done following the surgery on this patient?
Following the surgery, sir, only the Ann Arbor staging we had done, sir. Hello.
What staging you have done?
Only the Ann Arbor staging was done, sir, according to which he belonged to.
Thank you, Dr. Kshitij. The time is up.
Kshitij, still Ann Arbor is followed?
Thank you, Dr. Kshitij. Now I would like to call upon Dr. Sabanika for the presentation.
Good evening, sir. Am I audible?
Yes.
Good evening, sir. Today, I would like to present an interesting case of angiomyxoma of right vulva. This is a case which had come to us, our surgery OPD. She was a 32-year-old female patient who came with complaints of swelling in the right side of vulva since 6 months. Initially, it was of the size of 3 by 3 centimeters and gradually progressed to 8 by 6 centimeters. There was no discharge from the swelling, pain, or itching. There was no history of trauma. There was no urinary complaints. We examined the patient further and we found a solitary swelling which was spherical in shape of size 8 by 6 centimeters over the right side of labia majora. The surface was smooth and the margins were well defined. The skin of the swelling was normal and there was no cough impulse. There was no local rise of temperature or tenderness. The swelling was soft, not fixed to the skin. On pervaginal examination, the swelling was felt to be extending up to the right lateral fornix of vagina, but not involving it. On perrectal examination, the swelling was palpable up to 5 centimeters of the rectum. We evaluated the patient further. We did an ultrasound. As shown in the image below, we could see a hypoechoic mass, and FNAC revealed a benign fibrous fragments, which was more suggestive of a plexiform neurofibroma or benign mesenchymal elements. MRI was done to delineate the mass, and T2-weighted MRI was done, which showed a high signal intensity as shown in the image here. A well-defined mass of size 12 by 4 centimeters involving the right lateral fornix of vagina, which anteriorly extended up to right labia and posteriorly up to rectum. We did an excision of the mass under spinal anesthesia, and the specimen was sent for histopathological examination. On histopathology, spindle to stellate cells in myxoid stroma with collagen, which was suggestive of angiomyxoma of vulva, was found. The patient withstood the procedure well. Post-op recovery was uneventful, and she was discharged on post-op day 5 and followed up to date. Angiomyxoma is basically a tumor of mesenchymal origin, and it is known for local recurrence. It contains estrogen progesterone receptors, hence hormonal therapy with tamoxifen, raloxifene, GnRH agonist can be used to reduce the size of mass and in treating recurrences. But this tumor is actually locally aggressive, hence surgery remains the mainstay of treatment. But chemo and radiotherapy are not suitable because of reduced mitotic rate. And the common sites of this tumor include pelvis, vulva, perineum, vagina, and urinary bladder. Hence, it is commonly misdiagnosed as Bartholin cyst, lipoma, levator hernia, or sarcoma. It is more common in females. Recurrence rates are between 9 and 72%, hence long-term follow-up is necessary. Thus, I would like to conclude by saying that angiomyxoma should be considered as a differential diagnosis in any patient who comes with tumor over the vulva. And we should follow up the patient for a long term because the recurrence rates are very common, and MRI is the preferred method for diagnosing recurrence. Thank you, sir. Any questions, sir?
Now the panel is open for discussion.
Yeah, is histopathology is commented on anything commented on the margin clearance?
Yes, sir. On gross appearance, the swelling was spherical in shape and it was tan to gray brown in color.
No, the margin, what about the margin?
No, we didn't get any comment about the margins. It was well-defined mass, sir, but it didn't involve any
No,
vista.
normally we'll end up just nucleating, and it requires, because of high rate of recurrence, it needs to be, it requires a wide excision. So revision surgery can be considered in case if the margins are not clear.
Okay, sir. We excise the full tissue in toto, sir, as shown in the image.
No histopathology proved?
No, sir.
Yeah,
We
that's
didn't have any
okay.
comment on
It's
the
only
margin.
microscopic. Okay, microscopic we need to assess and then consider. Okay.
Any other questions, sir?
Any other questions? If there are no further questions, we'll move on to the next presentation. Thank you, Dr. Saubanika.
Thank you, sir.
Now I'd like to call upon Dr. Suhas for the presentation.
Hello. Hello, sir. This is Dr. Suhas. Sir, good evening, everyone. I present a case report on the laparoscopic esophagogastrostomy in the management of the achalasia cardia. Next slide. Achalasia is a primary motor disorder affecting the esophagus. It is a rare condition with an incidence of 1 to 3 per 1 lakh population. The histopathologic hallmark of the disease is near complete or total loss of the myenteric plexus ganglion cells. The surgical treatment for the stage 3 achalasia with markedly dilated and sigmoid-shaped esophagus is a matter of controversy. Next slide. Some authors recommend esophagectomy as the primary treatment because they believe Heller's myotomy cannot improve dysphagia in such cases. We present a patient with achalasia stage 3 in whom we successfully performed a laparoscopic esophagogastrostomy. A case capsule. A female patient of age 63 years presented with history of dysphagia, regurgitation of the indigested food, retrosternal chest pains in 6 months. Dysphagia, which was initially confined to liquids, later progressively worsened to involve both liquids and solids. There was history of weight loss of 6 kilos in 6 months. Next slide. There was no significant abnormality in the general physical and the systemic examination. Next slide. On upper GI endoscopy, there was dilated distal and middle esophagus with esophageal ulcer and the constriction of the G junction, which was suggestive of achalasia cardia. On barium swallow, there was narrowing of the gastroesophageal junction, gross dilatation of the esophagus with pooling of the contrast were noted, which are also the features suggestive of achalasia cardia. Next slide. This is the barium swallow showing the narrowing of the G junction and the gross dilatation of the esophagus. Next slide. Patient was put on endoscopy-guided nasogenostomy tube for enteral nutrition. After a period of 6 weeks, patient was posted for surgery. Laparoscopic assisted esophagogastrostomy was carried out. Next slide. This is the intraop image from, this is the image showing passing of the endostapler through the gastrostomy. Yeah. Next slide. Operation time was 3 hours. Oral liquid diet was started after oral contrast X-ray on POD 7. After oral contrast study showed rapid passage of the contrast. As the patient tolerated the liquids well, she was started on semi-solid food followed by the solids. Patient was discharged from the hospital on POD 12 with instructions to report immediately on development of any new symptoms. Next slide. This is the barium swallow showing rapid passage of the oral contrast through G junction. Next slide. Patient came back with GERD symptoms after a month of surgery. She was advised to take PPI and prokinetic drugs for the same. Endoscopic examination of upper GIT did not reveal any structural changes at the 22nd month of follow-up. Patient has been asymptomatic with the above mentioned drugs till date. Otherwise, the patient is stable after surgery and leading a normal life without any significant complaints. Next slide. Laparoscopic esophagogastrostomy could be an alternative to esophagectomy and laparoscopic Heller's myotomy. Because of the wide side-to-side anastomosis, there is no risk of long-standing stenosis as reported with Heller's operation. This procedure certainly is less invasive than esophagectomy. Thank you. Next slide. This is my references, sir. Thank you, sir.
Now the panel is open for discussion.
Suhas, can you hear me?
Yes, sir. Yes, sir, I can hear you, sir.
So what made you to go ahead with your preferred surgery? Why don't you go for a preferred surgery like laparoscopy, LS cardiomyopathy, the fundoplication? That's supposed to be the standard technique what we does,
So
no?
Yes, sir. So for stage 1 and stage 2 achalasia, usually they go for laparoscopic Heller's myotomy, sir.
Oh.
But stage 3, according to the literature, it is they go for the esophagectomy.
Okay.
So we went ahead with the esophagogastrostomy for the stage 3, sir. Stage 3. This was a stage 3 achalasia, sir.
Esophagogastrostomy.
Gastrostomy, yes, sir. The fundus and the lower end of the esophagus, we had anastomosis, side-to-side anastomosis.
Did you do any drainage procedure? Because the reason is that you are going to injure both the vagus nerves now.
So yes, sir. Yes, sir.
What drainage
we preserved the
procedure?
vagus nerve, sir. I think.
You preserved the vagus nerve.
Yes, sir.
Show me. Okay.
Yes, sir.
There is no further questions. We'll move on to the next presentation. Thank you,
Thank you,
Dr. Suhas. I would like to call upon Dr. Abdesh for the presentation.
Good evening, everyone. I'm presenting a case report of gastrointestinal tumor of stomach presenting as intratumoral abscess. Introduction: a gastrointestinal stromal tumors are tumors that arise from interstitial cells of Khazad and represent the most common type of mesenchymal tumors of the GI tract, with stomach being the most common site of origin. Cysts are often asymptomatic until they grow large, and their clinical presentation is highly variable. They infrequently manifest abdominal emergencies such as bowel obstruction, tumor rupture, perforation, and intratumoral abscess formation. Case history: 63 years lady presented to the emergency department with complaints of abdominal pain since 2 months, which increases since 2 days, and intermittent fever since 1 week. History of altered bowel habits since 20 days, known hypertensive on regular medication. She has undergone hysterectomy 15 years back for fibroid uterus. On examination, the patient was conscious and oriented. BP was 110 by 64 millimeter of mercury in right arm supine position. Pulse rate was 102 beats per minute. Temperature was 99.7 degree Fahrenheit. Per abdomen was soft. Epigastric mass was palpable, and tenderness was present. Bowel sounds was present. Investigations: TLC was 16,740 cells per cubic millimeter. CRP was 17 milligram per deciliter. CEA and CA19 was negative. Ultrasound abdomen and pelvis showed 9.1 into 5.7 centimeter hypoechoic lesion, which was abutting the left lobe of liver and stomach. CECT abdomen and pelvis was showing partially circumscribed, ill-defined exophatic mass of 9.4 into 5.1 into 4.7 centimeter, arising near the pylorus part of the stomach, protruding into gastric lumen, with tumor bearing thick hypervascularized wall. CECT abdomen showed the tumor arising from the pylorus part of the stomach, with liver and pancreas being normal. These are the intra-op pictures, which shows the hypervascularized wall of the cyst. Surgical management: patient underwent exploratory laparotomy, which revealed tumor arising from the pylorus part of the stomach with loose adhesion without invasion was observed, and the tumor was easily separable with blunt dissection. So wide local excision of the tumor was done. A small portion of the tumor was sent for frozen section, which revealed proliferation of spindle-shaped tumor cells. Immunohistochemical staining showed that the tumor cells were positive for c-KIT, CD34, and smooth muscle actin. Discussion: cysts are the most common mesenchymal tumors of the gastrointestinal tract. They can occur throughout the gastrointestinal tract, but mostly in the stomach, around 60%, and the small intestine, 30%. Because cysts of the stomach often show an exophatic growth pattern, they tend to be asymptomatic until they grow large. The clinical presentation of the cyst in the stomach is highly variable. The most frequent symptom is GI bleeding, and others include vague abdominal pain, a palpable mass, weight loss, and fever. Infrequently, cyst can cause acute abdomen, such as bowel obstruction, hemoperitoneum secondary to tumor rupture, and peritonitis secondary to tumor perforation. When an abscess bearing a thick and hypervascularized wall is observed at contrast on CT scan, as in our case, an intratumoral abscess rather than a simple abscess should be suspected. Although some reports have described conservative treatments as being effective, immediate surgery is considered to be eligible when symptoms are strong or when conservative treatments are found to be ineffective, because this state may easily lead to perforation and peritonitis. Complete surgical resection is the only potential curative treatment for cyst. This report describes a patient with an intratumoral abscess caused by gastric cyst in whom emergency surgery was necessary. Next slide.
Now the panel is open for discussion.
Of this, what is the specialty of this case?
Sir, in this case, sir, intratumoral abscess was present, sir. So, and the size of the tumor was 9 into 5 centimeters, sir.
So what could be the reason why there was an abscess?
Sir, yes, sir.
You said
tumoral abscess formation.
Intramural. What is the reason for this abscess formation? Intratumoral abscess.
Sir, this can be caused by the streptococcal intermediate infection, sir.
Oh. Or is it gone for a cystic degeneration?
Sir, some part was like in some part cystic degeneration was there, and some part it is solid only, sir. With pseudocapsule was present, sir.
So you mean that the abscess is because of the staphylococcal infection or streptococcal? I mean, you said some infection, no?
Sir, the organism was streptococcal, sir.
Okay. So how did you follow, sir? What is the medical line of treatment for this?
Sir, patient was started on imatinib, sir, 400 mg, as like the patient was a high risk candidate, sir. The size of the tumor was 9 centimeter and high mitotic figure, sir. More than 6 per 50 high power field, sir. So like medical oncologist opinion was taken and patient was started on imatinib 400 mg.
Thank you, Dr. Abdesh. Now I'd like to call upon Dr. Abhishek Chaturvedi for the presentation.
What Chaturvedi?
Abhishek, sir. Good evening, respected judges and my dear colleagues. I shall be presenting a case of multiple magnet ingestion in a child. Next slide, please. Foreign body ingestion is very common among children, but usually less than 1% of cases will require surgical intervention. Multiple magnet ingestion poses a higher risk to children as it can lead to dangerous complications such as necrosis of the bowel, volvulus, perforation, and sepsis. And the present day neodymium magnets are used, which are stronger than the traditional ferrite magnets used previously. The case is of a 1-year-old girl who had presented to us with 8 to 10 episodes of bilious vomiting and abdominal discomfort since 48 hours. She had not passed stools for the past 2 days. Retrospectively, we had obtained the history of multiple magnet ingestion from the mother. On examination, the child was developmentally normal for the age. There was tenderness present over the epigastrium and right hypochondrium. However, there was no guarding or rigidity. Blood investigations were found to be normal, showing no signs of sepsis. The erect X-ray abdomen showed 11 radio-opaque spherical magnets with the dilation of the proximal bowel loops as seen in figure 1. The patient then underwent an exploratory laparotomy with ileal resection and anastomosis with an ileostomy. Intraoperatively, as shown in figure 2a, we can see there is a dilation of the proximal small bowel, the jejunum and the proximal ileum with 8 magnets, 4 in each of the loops, which were adherent to the adjacent bowel loops, leading to a volvulus and congestion of the bowel due to the entrapment of the bowel by the magnets. 2 perforations were noted, that is 7 centimeters and 30 centimeters proximal to the ileocecal junction. Post-op period, the child was started orally on feeds at post-op day 3 and full feeds were allowed by post-op day 6. On post-op day 7, the child was discharged and the stoma was reversed after 3 weeks. So foreign body ingestion is a common pediatric problem usually occurring in children less than 3 years of age. And the present day neodymium magnets, which are 10 to 20 times stronger than ferrite magnets, pose a bigger problem as they are, owing to their strength, they can attract adjacent bowel loops, which then leads to necrosis and perforation. And these magnets are now being more commonly used in smaller and multiple toys. So complications occur when these magnets after ingestion attract different bowel loops, trapping them, causing ischemia, which leads to necrosis and then leading to volvulus, perforation, and sepsis. At presentation, children can have vomiting, abdominal pain, or fever following the ingestion of a foreign body. Therefore, an accurate history and importance to the clinical features and an appropriate imaging are the most important. If a single magnet is ingested, a wait and watch policy is advised. However, if multiple magnets are ingested, the surgical intervention is being advised at the earliest. If the magnet is within the stomach, endoscopic removal can be tried. If that fails, then surgical exploration has to be done. If it is beyond the stomach, we can directly proceed to a surgical exploration.
Thank you, Abdesh. Now the panel is open for discussion.
What warranted you to take the patient for surgery?
So the child was looking a bit sick despite having normal blood count, sir, and was had abdominal discomfort with continuous crying, sir.
You said that there was a big type of volvulus because of the magnets.
Yes, sir.
So was the patient presenting with signs of intestinal obstruction or something like that?
Vomiting was there, sir, and patient had not passed stools for the past previous 48 hours, sir.
Abdomen was silent.
Sorry, sir?
Was abdomen silent?
No, sir. Abdomen was not silent, sir.
Abhishek, an X-ray showed there's a dilated loop of bowels, isn't it?
Yes, sir.
So still the child was not in the obstruction.
No, sir. Apart from the vomiting, the child was in obstruction, sir, but with features of...
Your presentation says vomiting, abdominal pain.
Yes, sir.
Then what could be the reason for vomiting and the abdominal pain if there is no obstruction?
So there were features suggestive of obstruction. On the X-ray, since we had seen the dilated bowel loops, and clinically the vomiting was there, though there was no distension as such, sir.
So only vomiting was there and pain abdomen was there. X-ray dilated bowel was there, but there is no abdominal distension.
Thank you, Dr. Abhishek. The time is up. I'd like to call Dr. Shweta for the next presentation.
Good evening, sir. Hello.
Good evening. Yeah.
Hello. Am I audible? Good evening, sir. Myself, Dr. Shweta from Mysore Medical College. I'm going to present a case report of a rare case of perforation of Meckel's diverticulum in an infant. Next slide, please. Meckel's diverticulum is a persistent remnant of the vitellointestinal duct which measures about 5 centimeters approximately and occurs in about 45 to 60 centimeters from the ileocecal valve. The male to female preponderance is 1:1. It is a true diverticulum which contains all the layers of the bowel, containing either gastric mucosa, which accounts for 50%, pancreatic mucosa about 5%, and colonic mucosa. The clinical presentation are most commonly is lower GI bleeding, diverticulitis, intussusception, chronic ulceration, intestinal obstruction, and rarely perforation. Preoperative diagnosis is difficult as there is no specific investigation available. Technetium 99 pertegnate scan is available at certain centers for diagnosis, but this scan has a sensitivity of about 85% and specificity of only 95%. My case report is a 9-month-old male infant presented to the casualty with history of refusal of feeds and crying continuously for 2 days. On examination, the child had abdominal distension with diffuse tenderness over all quadrants of the abdomen. On further evaluation, the ultrasonography of the abdomen and pelvis showed mild fluid in the peritoneal cavity with internal echoes with features suggestive of pneumoperitoneum. Erect X-ray abdomen showed air and diaphragm. The total cell count were increased with predominant neutrophils. The infant was resuscitated and underwent emergency exploratory laparotomy. Perforation of the Meckel's diverticulum at the base along with peritonitis was identified intra-op. The resection of the Meckel's diverticulum along with 5 centimeters of the ileum on either side was done, followed by end-to-end anastomosis of the ileum. Postoperatively, the child postoperative period was uneventful and the child was monitored closely and was discharged on postoperative day 6. Child was reviewed after 15 days in the OPD and followed up to 3 months. Discussion. Meckel's diverticulum is the most common congenital anomaly of the small bowel. It can present as a symptomatic Meckel's diverticulum or as an incidental finding peroperatively. There is no specific investigation of choice for diagnosis of Meckel's diverticulum. Treatment of a symptomatic Meckel's diverticulum is either diverticulectomy or segmental resection of the ileum, which depends upon the pathology. Conservative approach is still supported for the incidental Meckel's diverticulum. However, studies have shown the incidence of malignancy in Meckel's diverticulum to be about 1.44 per 10 million population. Hence, the decision for surgical resection of Meckel's diverticulum is made on a personalized basis, weighing the risk-benefit ratio based on the age, complication, and malignancy. Next slide, please. Coming to the conclusion, perforation of Meckel's diverticulum is a rare complication which is difficult to diagnose preoperatively. The incidence of Meckel's diverticulum is common among children less than 2 years of age. Spontaneous perforation of Meckel's diverticulum can present as acute abdomen. Hence, early diagnosis and timely intervention is essential for the better outcome of the patient. Hence, Meckel's diverticular perforation has to be considered as one of the differential diagnoses in case of acute onset pain abdomen among the infants. Thank you.
Thank you, Dr. Shweta. The panel is now open for discussion.
Shweta,
Yes, sir.
what was the final histopathology report of the specimen?
It had a heterotrophic gastric mucosa, sir.
So it contained gastric mucosa. Anything
Yes,
else?
No, sir.
On the gastric mucosa.
So, Shweta, they know that it is a Meckel's diverticulum before surgery or
No, sir. It was an intraop finding, sir.
intraoperative finding. What is the incidence of perforation Meckel's diverticulum in adults? The
It is
commonest is
0.04%, sir.
what is the commonest complication of the Meckel's diverticulum?
In children, it is lower GI bleeding, sir. In adults, it is diverticulitis, sir.
Diverticulitis.
There are no further questions. I'd like to thank Dr. Shweta for the presentation, and I'd like to call upon Dr. Vishal for the next presentation.
Good evening, everyone. So, am I audible, sir?
Yeah.
Good evening, everyone. Today, I am going to present a case of endodermal sinus tumor. Coming to introduction, pediatric germ cell tumors are rare and they account for 3 to 4% of childhood solid tumors. Yolk sac tumors are those that resemble yolk sac, allantois, and extraembryonic mesenchyme. They are also known as endodermal sinus tumors. EST can be seen in males and females involving testes, ovary, and other sites such as mediastinum. EST of the testes are observed in two forms age group, that is pure yolk sac tumor in young children and mixed type in adults. Pure yolk sac tumor is the most common testicular neoplasm in prepubertal children, accounting for 80% of testicular germ cell tumors in this age group, with median age of 1.5 years. In adults, yolk sac tumors presents as a component of mixed non-seminomatous germ cell tumor with an age averaging 25 to 30 years. Next slide. Coming to my case, a 3-year male child presented with swelling in the left testis since 1 year, initially of 2 into 2 centimeter size and gradually increased to present size of 6 into 5 centimeter approximately. And he presented with pain since last 1 week and fever and cough since 3 days. On inspection, the left side of the scrotum swelling was noted in the left side of scrotum measuring 6 into 5 centimeter. Skin was swelling was stretched with loss of rugosity. Median reprieve was pushed to other side. Impulse on cough was negative. On palpation, tenderness was present with swelling, and swelling was 6 into 5 centimeter, which was vertically oval, hard in consistency. Ghetto swelling was present. Skin was swelling was not pinchable. Right side wrist was palpable and normal. Bilateral inguinal lymph nodes were palpable. Investigations, total counts were raised. AFP was more than 1,000, which was significant, and LDH was slightly raised. HCG was normal. Ultrasound, USG inguinal showed grossly enlarged left testis with heterogeneous echo texture with mild increased vascularity, and left epidermis was enlarged involving the head, body, and tail with increased vascularity. Next slide. CC abdomen showed a heterogeneously enhancing lesion measuring 6.5 to 5.8 to 4.3 centimeter, noted in the left testis with no obvious calcification or cystic changes. The lesion showed subtle non-enhancing central areas within it. It represents necrotic changes, which was concerned with the left testicular neoplasm, and bilateral inguinal lymph nodes were present. Chest X-ray was normal. We went with the high inguinal orchidectomy, and gross specimen showed congested blood vessels. On cut section, there was gray-white growth involving the old testis, and no normal testicular tissue was seen. Microscopy showed malignant neoplasm comprised of tumor cells which are arranged in a microcytic, granular, and reticulated pattern, and stellar dual bodies were seen. And coming to discussion, endodermal sinus tumor is a highly malignant neoplasm of germ cells which grows rapidly and metastasizes early via the lymphatic and hematogenous routes. The pattern of metastatic disease of yolk sac tumors in childhood differs from pattern in adult germ cell tumors, owing to high incidence of hematogenous spread. Next slide. Approximately 90% of yolk sac tumors are confined testis. Lungs are most common site of metastasis, which are affected in 20% of patients. Metastasis of yolk sac tumors to retroperitoneum is uncommon in children, whereas in adult it spreads usually to retroperitoneal nodes. Coming to conclusion, childhood renal cell does not appear to be associated.
The time is up. Now the panel is open for discussion.
Shall have we done a FNSC?
No, sir. We didn't do FNSC.
Why you not done FNSC?
Sir, FNSC is contraindicated as there is chance of seedling of metastatic cells to the scrotal skin also, sir.
Are you sure?
Yes, sir.
Okay.
Any further questions?
Have you followed this case further?
Yes, sir. I followed the case, sir. Actually, recently, baby had again come with metastasis and he has underwent left nephrectomy, sir. Left nephrectomy has undergone, sir. He was referred to higher center to Hyderabad, sir.
Left nephrectomy. What you mean that it has been spread to the?
Yes, sir. Yes, sir.
Left side kidney.
Yes, sir. But I didn't get all the reports, sir. The reports with the hospital we couldn't get. Based on what I spoke with the patient and attendants, I got this information, sir.
Okay.
Any further questions? If there are no further questions, thank you, Dr. Vishal. We'll move on to the next presentation. I'd like to invite Dr. Sushant for the presentation.
Good evening, everyone. This is Dr. Sushant. Like today, I'll be presenting about a case of gallbladder volvulus, pendulum that swung too far the other way, a rare case of gallbladder volvulus. Next slide, please. Coming to introduction, the volvulus of gallbladder was first described by Wendell in 1898. Like has a floating gallbladder. There are only very few cases till now. Only 500 cases were discovered till now. It is usually common in women around the ages of 60 to 80, and they usually present to emergency with acute abdomen. In gallbladder volvulus characterized by mechanical clockwise or counterclockwise organoaxial torsion along the longitudinal axis of gallbladder, involving cystic artery and cystic duct. And coming to case presentation, a 30-year female presented with pain upper abdomen 6 months, since 6 months, not associated fever, jaundice, and she gives history of nausea and episodes of vomiting. And patient had similar complaints in the past, like 6 months back, for which she was treated with antibiotics, and USG abdomen and pelvis was done, which showed cholelithiasis. She also has a past history of infertility treatment, and like she was conceived 6 months ago. And on examination, patient was moderately built and nourished and vitally stable. And per abdominal examination, abdominal wall and mild tenderness was present in right upper quadrant. Bowels also present. Patient underwent all other relevant investigations and blood investigation, which were in normal limits. And the UGI was done, which showed scattered erosions, and MRCP showed cholelithiasis. And intra findings, as we entered the abdomen, we were surprised by the varied anatomy of Callet's triangle on table. We have done a meticulous dissection to delineate the anatomy, which showed a lengthy gallbladder with a long mesentery. And most of mesentery was only attached to cystic duct rather than to the whole of the gallbladder. And there was a 180-degree rotation of the pedicle, actually less than 180 degree. And unlike regular cholecystectomy, here we had to clamp and ligate cystic artery first, and then later cystic duct. Excess gallbladder was sent for histopathology, which showed a chronic calculous cholecystitis. And patient withstood procedure well. She tolerated orally after 6 hours of the procedure, and on post-op day 2, patient was discharged. These are the pictures showing the varied anatomy. You can see the cystic duct like medially and cystic artery laterally. Varied Callet's triangle anatomy is seen. And you can see long gallbladder with small gallbladder fossa and very small mesentery, long mesentery. And then first we had to ligate the cystic artery first, and in the end we have ligated the cystic duct. Thank you. And coming to discussion, gallbladder gallbladder volvulus is a rare case entity, which is only 500 cases were seen till now, and we have described three their clinical features can
The
be
panel is open
grouped
for
into
discussion.
Was there any gangrene of the gallbladder?
Yes.
What was the finding, Parag? Apart from
Yes,
what about the vascularity to the gallbladder?
So gallbladder was healthy, sir. Here it's not a complete torsion, sir. It was
yeah, volvulus or torsion when the
Yes, sir.
vascularity is compromised
Yes,
and
sir.
the gallbladder looks gangrenous.
Yes, sir.
And the findings is only just a long cystic duct and it has gone for a little rotation. That we,
Yes, sir. Yes, sir.
So do you call this as volvulus?
Sir,
And a long pedicle.
but the anatomy is varied, sir. Like the cystic duct is
Just because of the anatomy, you want to.
Can you call this as a volvulus?
What is the basic definition of volvulus?
It's the rotation of the organs causing obstruction or
Just rotating or something else?
Twisting, complete twist will be this.
Sushant, you said you are taking, I mean, you are subjected this patient for a MRCP, isn't it?
Yes, sir. Yes, sir. Yes, sir.
Do you subject all the patients with a correlated for MRCP?
No, sir. Like if we are
The
suspecting
time
any
is up.
cystic duct, yes.
Thank you, Dr. Sushant.
Yes.
Now I'd like to call Dr. Vedant to present the final poster of this session. Dr. Vedant?
Yes, yes. I'm ready. Hello? Hello?
Yeah, continue.
Good evening. Today I'll be presenting upon Ripon syndrome with gastric trichobezoar in a young postpartum female, an intriguing case report. Next slide, please. So, introduction. A bezoar is a ball of swallowed foreign material which collects in the stomach and fails to pass through the intestine. Generally, it is found in patients with psychiatric disorders such as trichotillomania, which is urge to pull out one's head, and trichophagia, urge to eat one's head. Trichobezoars within the gastrointestinal tract remain asymptomatic for many years. They are characterized by late-onset non-specific symptoms like abdominal pain, nausea, vomiting. Symptoms develop as the bezoars increase in size. Diagnostic procedures are commonly initiated owing to acute abdominal symptoms. The occurrence of trichobezoar has seldom been described. So the case details: a 21-year-old female, married lady, post-normal term delivery 4 months ago, presented with abdominal discomfort and intermittent episodes of vomiting for a duration of 1 month. Her parents revealed history of trichophagia as a child on further questioning. On examination, she was moderately built and nourishing, her vitals stable, her scalp showed no evidence of alopecia. Per abdomen findings, a mass was palpable, occupying the epigastrium, umbilical, and right hypochondrium regions, which was mobile, non-tender, and non-pulsatile. Was firm in consistency. Investigations. Hematological and biochemical parameters were within normal limits. Erect X-ray abdomen showed no radiological abnormalities. On further CT scan, a well-defined round to ovoid heterogeneously hyperdense mass was seen in the lumen of the stomach, with multiple air foci extending up to the pyloric region and smooth surface. So the patient was taken up for exploratory laparotomy, and she underwent gastrostomy with upper midline incision, and a giant trichobezoar was identified, occupying the entire stomach and extending into the first part of duodenum, and extracted. Post-operatively, patient recovered well. She was giving psychiatric counseling prior discussion. Bezoar is accumulation of food or foreign material within the gastrointestinal tract. They're classified based on the content into phytobezoars, which are vegetables, trichobezoars, hair, lactobezoars, which is milk and curd. The incidence of trichophagia is up to 18% of the patients with trichotillomania. 1/3 of the patients with trichophagia develop trichobezoars. Conventional laparotomy continues to be the preferred surgical treatment. Surgical options have been modified with the advent of laparoscopy. As most of the patients suffer from psychiatric illness, psychiatric intervention and counseling is required. The underlying illness, that is trichotillomania and trichophagia, needs to be addressed. This reduces the complications. Next slide, please. Conclusion. Rapunzel syndrome is an uncommon condition that should be considered as a differential diagnosis in young females presenting with non-tender mobile epigastric abdominal mass. Delayed or misdiagnosis can lead to catastrophic outcomes like gastric perforation. Early diagnosis and removal of such trichobezoars augmented with psychiatric counseling and long-term follow-up results in best outcomes. Thank you.
Thank you, Dr. Vedant. Now the panel is open for discussion.
Dr. Vedant, and when was this diagnosed? How did you come to a conclusion it is trichobezoar? Was it pre-operative or after the CT or ultrasound scan?
A pre-operative diagnosis was actually suggested. The radiologist suggested for a CT scan, sir, and they told us that it could be a trichobezoar, and the confirmatory diagnosis was done only on a per-operative finding.
Have you done a endoscopy before?
So, endoscopy was not available. So, as the patient was presented to us in the late midnight, so we could not do endoscopy at the time.
How will you perform an ultrasound scan if there is a CT is not available? If you are suspecting a trichobezoar.
Yes, sir. Yes, sir.
Have you operated the same day?
Yes, sir. Operated the same
night. Same night.
Yes, same night, sir. Yes, sir.
What was the reason to operate such an emergency?
So she was she presented with severe abdominal pain, and she was not passing stools, and she was having severe multiple episodes of vomiting, sir. We suspected
what was the indication for surgery? What was the indication to do an emergency surgery?
So her vitals, not vitals. Actually, we due to severe pain abdomen, we took her up for surgery.
No, any patients come with a severe abdomen, you want to explore and see.
No, sir.
Then
on diagnosis, also we got a CT scan and revealed.
Have you not thought of a pancreatitis? Both CT said it's a trichobezoar.
Trichobezoar, sir. There was
you
a
should
mass
have hold on
completely
for the next
obstructing
day,
it.
no? If that is the case, you should have hold on for the next
I'm
day.
sorry, sir. Due to time constraints, we have to end this session. Thank you, Dr. Vedant. Now we have come to the end of the session. I would like to thank all the chairpersons and judges for getting involved amidst the busy schedule. And I would also like to thank the presenters for their active participation in the event and making this a successful one. Thank you, everyone.
Moving on to our next session of clinical case discussion. To chair the session, I would like to welcome Dr. Ishwar Hosmani, sir, Professor and Principal, Department of General Surgery, KIMS Hubli. Dr. Sharat Chandra PJ, sir, Professor and HOD, JSS Medical College, Mysore. Dr. Tejaswini Vallabha, Madam, Professor, Department of General Surgery, DM Patel Medical College, Bijapur. Dr. K. Lakshman, sir, Consultant Surgeon at Sagar Hospital, Bangalore. Now I'd like to call upon our first presenter, Dr. Deepika Dinesh. Deepika, are you ready with your presentation?
Yes, am I audible?
Yes, you're audible, Deepika. Kindly share your PPT and start the presentation.
The PPT is there. Please go ahead, Deepika.
Good evening, everybody. I'm here to present a case of lump in the left breast. Myself, Dr. Deepika Debelgo, third year postgraduate from Mysore Medical College. My mentor, Dr. Prakash SS, Head of the Department of Surgical Oncology, Mysore Medical College. A 47-year-old housewife, Mrs. X, belonging to lower socio-economic class, Hindu family, resident of Hunsur Taluk, belonging to Mysore district, presented with chief complaints of lump in the left breast since 2 months, ulcer over the lump with discharge since 10 days. Patient was apparently asymptomatic 2 months back when she incidentally noticed a small lump of about 3 × 3 cm in the upper part of the left breast while taking bath. Lump gradually progressed to present size of approximately 6 × 6 cm over a period of 2 months. History of ulcer over the lump since 10 days with serious discharge. There is no history of pain in the lump or mastalgia, no history of any changes in the nipple and areola or recent retraction of nipple, no history of trauma to the breast, no history of swelling noticed over both arms or neck, no history of fever, no history of weight loss or loss of appetite, no history of backache, bone pain, cough, difficulty in breathing, hemoptysis, chest pain, abdominal pain or distension, headache, vomiting, seizures or jaundice. No history of chest irradiation, no history of any swelling in the ipsilateral axilla, or no history of any swelling in the opposite breast or axilla or elsewhere in the body. Known case of neurofibromatosis since age of 13 years. Past history, no history of any radiation exposure, especially to the chest, no history of hormonal replacement therapy, no history of previous history of any pain or lump in the same or opposite breast, no history of any chronic illness like diabetes, hypertension or tuberculosis, no history of any past surgery or intervention to the breast. Coming to family history, no history of carcinoma breast in the first degree or second degree relatives in both maternal and paternal families, no history of malignancy like ovarian, pancreatic, colorectal, prostate in the family, no history of neurofibromatosis in the family. Personal history, predominantly non-vegetarian, she belongs to lower middle class, no history of smoking, alcohol intake or tobacco chewing, bladder and bowel habits were normal, and she is married for 26 years. Age at menarche was 15 years and her marital life is 21 years, attained menopause 1 year back, P1, para 1 and abortion 1. Age at first pregnancy was 23 years and menstrual cycles were regular. I would like to summarize my history. Postmenopausal lady of 47 years presented with painless swelling in the left breast since 2 months, which was gradually progressive with ulceration of skin over the swelling since 10 days, with no significant family past personal history, with history of abortion, no full-term pregnancy, and no history of breastfeeding with neurofibromatosis. History level diagnosis, I would like to give it as carcinoma of the left breast, phyllodes tumor of the left breast, traumatic fat necrosis of the left breast. Coming to examination, adult female, conscious cooperative, examination done in sitting position after verbal consent in a well-lit room. Her BMI is 20.5, which is normal. ECOG performance score being 1, Karnofsky score 90, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. Pulse rate is 76 minutes, BP is 130/70, respiratory rate is 14 per minute, temperature 98.8 degree Fahrenheit. Head to toe examination, there were multiple neurofibromas present all over her body. Skull was normal and mild kyphosis was present since birth. Local examination, on inspection in sitting position with arms by the side, arms raised and arms over the hips in a well-lit room, bilateral pendulous breasts were noted, which were asymmetrical. Both nipples were at the same level. Right breast, nipple areola complex, neck, axilla and arm appears normal. Left breast appears bulkier than the right breast. A globular lump of about 6 cm vertically and 5 cm horizontally noticed in the upper outer quadrant, 1 to 2 o'clock position of the left breast near the axillary tail with well-defined edges. With arms above the head, left nipple appears slightly above the right nipple. No other obvious changes and the lump moves up with this position. Solitary ulcer of 1 × 1 cm, irregular margin present over the lump with serous discharge. Skin over the lump is edematous, shiny and redness was present. No nodular lesions, dilated veins, pudgy or dimpling seen. No scars or biopsy marks seen. On bending forward, both breasts fall forward equally. Nipple area complex appears normal, dark, no retraction or discharge. Supraclavicular and neck region appears normal. Left axilla appears normal and there was staining of clothes. On palpation, it was done in sitting, 45 degree semi-recumbent and supine position. Right breast, nipple areola complex, neck, axilla, arm were normal. Left breast, there was no local rise of temperature, no tenderness. A solitary palpable lump, 6.5 × 5.4 × 3 cm in the upper outer quadrant, near the axillary tail of left breast is noted. Margins were well defined and irregular. Nodular surface hard in consistency. Lump is fixed to the breast tissue with restricted intrinsic mobility, and there was no discharge from the nipple. There was no skin tethering, no fixity to the chest wall. Lump is fixed to the pectoralis muscle. Lump is fixed to the skin. Skin over the swelling is edematous, and the ulcer 1.2 × 1 cm present over the swelling with serous discharge. Left axilla, no local rise of temperature, non-tender, 1.5 cross 1 centimeter firm mobile lymph node with well-defined margins and smooth surface palpable in the anterior axillary group, free from skin and no overlying skin changes. The brachial, subscapular, central, apical nodes not palpable. Supraclavicular lymph nodes were not palpable. On percussion, no internal mammillary lymph node dullness felt. Systemic examination was found to be normal. Pervaginal and perrectal examination was normal. I would like to give a diagnosis. My patient, Mrs. X, 47-year postmenopausal lady, presented with painless progressive lump in the left breast since 2 months with skin ulcer over the lump, fixed to the pectoralis major and palpable solitary left axillary lymph node is a case of locally advanced breast malignancy with no evidence of clinical metastasis. Carcinoma of the left breast in postmenopausal women, T4B N1 MX, stage 3B.
Ma'am, okay, go on. Sure, please go on. Yeah.
Dr. Deepika, good evening.
Good evening, ma'am.
Good evening. Can you justify your diagnosis at history level regarding the possibility of traumatic fat necrosis?
Yes, ma'am. Usually, traumatic fat necrosis is a rare disorder, rare entity. Usually, the history of trauma will be forgotten by the patient, and it presents similarly like this as a progressive lump, but there will be as a lump in the breast, ma'am. But there will be no progression in the lump, ma'am.
Here she has
breast is more common, fatty breast or glandular breast?
Sorry, sir, I can't hear.
Which breast it is more common, traumatic fat necrosis, in a glandular, in a younger age group or in the elderly?
Elderly
most
group,
of the
sir.
gland is replaced by a fatty.
Elderly group.
Elderly group, okay. So what made you to put it as a phylloidous tumor on history?
A malignant phylloid can present as a swelling lump in the breast with ulcers, and the age group of my patient, more than 35 years, is more likely.
Is it the common age group? 47 years is the common age group for
no,
phylloidous
sir, it is around 30 to 40 years.
So it is much younger group. Even in the history level, looking at the age,
yes,
the possibility of a phylloidous tumor is uncommon. Even the
yes,
traumatic fat necrosis is also uncommon.
Yes, sir.
Okay. So you have taken the case of multiple neurofibroma along with that. Can you correlate this particular disease with your diagnosis?
Yes, sir. Multiple neurofibromatosis. One is mainly associated with breast cancer, sarcomas, and other bone-related tumors, sir.
Yes.
So this is a risk factor for breast cancer, sir.
Okay, fine. Okay. So in the history, in the obstetric history, you have mentioned about the what is the important risk factor in this?
Sir, she is para 1 and abortion 1, sir, and her abortion took place at age of 3 months, sir. So it is almost it is not completed pregnancy, which is almost considered as nulliparous. So it is a risk factor for breast cancer, sir.
Anything else other than this? The 5 headlines which you have made.
Yes,
Can
sir.
you pick up the important risk factor in these 5 parameters you have mentioned?
So menarche at age 15 is normal. So it was not an early menarche, sir.
It is the menarche at the early, and then the first child at the age of married at 23 years. So
Yes,
there will be a gap of around 8 years. So this is the single most risk factor in this. Apart from that, she considered only 1 child. This is also adds to the as the risk factors.
Okay, sir.
Madam, you please go ahead.
You also suggested that there is no history of radiation to the chest. What you had in mind when you asked this history?
So, ma'am, Mantle's radiotherapy, which is given usually to Hodgkin's lymphoma, especially to the chest lesions, are more susceptible for as a risk factor for breast cancer, ma'am.
I don't know. Okay. Sir, Lakshman.
Yeah, Dr. Sharat Chandra, you have anything to ask, sir? Can you unmute yourself, please?
Deepika,
right.
could you think of a possibility of a tuberculosis in this case?
So there's
because
no.
you mentioned the ulceration and a serous discharge following the onset of a lump which is there for some time and later it breaks down and producing a serious discharge. Can you consider the possibility of tuberculosis on history level?
So there's no history of fever, night sweats, or no significant weight loss history, sir, in the patient.
Okay, the constitutive symptoms pertaining to the tuberculosis, which is not there in this case, it
Yes,
doesn't mean that they will be there all the time. So tuberculosis breast is a total different entity. There will not be any systemic symptoms like coughs and the fever and other things. But you have to, in Indian scenario, that if you would like to give a differential diagnosis history, in such cases like this, you would always keep in mind the possibility of the tuberculosis also.
All right, Deepika, you mentioned mastalgia. What was the importance of that?
Sir, in this case, actually, usually
Not much,
carcinoma
okay.
breast is not associated with pain, sir.
Yeah, so mastalgia is not a main thing. You mentioned about a serious discharge. Would you have liked to ask about a foul smell in the discharge?
Yes, sir.
Yeah, what would be, if you did, what would be its importance?
Sir, any abscess or
Infection. Infection. It could be drainage from an underlying area. I'm talking about the history level, mind you.
Yes.
And you mentioned risk factors for several cancers, but you missed out uterine cancer. The two main ones you should mention are ovary and uterus, and of course stomach and pancreas are also important. You had covered the nipples in the photograph that you showed. Why did you do that? It is the examination of a breast. Why would you want to cover the, people would like to see what the... All right, I mean, these are all things where I just want you to be perfect in what you do. You're doing a good job. All right. And could this be a neurofibroma at the history level? Then talk about fixation to pectoral cell on that. But at the history level, neurofibromatosis, would you or would you not consider a malignant neurofibromatous lesion which could have ulcerated?
So coming to the consistency of the lesion,
I'm talking about history level, Deepika. Your history level diagnosis didn't include an ulcerated neurofibromatous malignant lesion, and that is something you would consider if you are giving a DD at that level.
Okay.
Please go ahead with your investigation.
One of these nodule must have been ulcerated and must have been produced. Yes, what Dr. Lakshman sir has put it out, you could also think this, because there are multiple such studied over the breast, both the breasts. Who knows, it could have been history level, one of them must have been ulcerated and started producing this. It's a good point to be noticed.
How would you proceed? Please go ahead.
Sir, I would like to do investigations. First, I would like to confirm my diagnosis, then do certain investigations to stage the disease, and then to rule out metastasis. Triple assessment. Now, as clinical examination is done, I would like to go with radiological examination. I want to get a USG, both breast and axilla for the patient, and then mammography, bilateral mammography. Then I would like to confirm it by histopathological examination by core needle biopsy, sir.
All right.
Then I would like to get hormone status, CRP or HER2 status of the patient, and then also the histopathological status for the patient, sir. Then I would like to stage my disease. And I would like to rule out the metastasis by doing a USG abdomen to rule out liver metastasis and ovarian metastasis, sir. Then I would like to get a CT thorax and X-ray of the lumbar spine and cervical spine, sir.
Even though on clinical examination there is no signs supportive of a metastasis, still then why you would like to go about the extensive investigations like CT and MRI or a bone scan?
There can be micro metastasis, sir.
Any reason you would like need for the investigations to go for the metastatic workup?
So if it is a metastatic, then the stage will increase and we will have to treat it differently. So I would like to rule out all the metastasis before going forward with my treatment.
On your clinical diagnosis, it is a locally advanced breast carcinoma. It's 3B. So if it is a 3B, there is a fair chance, even though clinically if they are M0 or M0, there could be high incidence of a micrometastasis in the distant organs. That is the reason you need to investigate the extensively by the metastatic workup. Okay.
Yes, sir.
Then in spite of all these advanced disease, you have mentioned about the mammography. What is the need to do a mammography for this patient?
I can't hear you, sir.
What is the need for mammography is the question.
Yes. In USG, I can only make out if it is solid or cystic lesion, sir. So I would like to get a mammography to rule out multicentral or multifocal disease, and also to rule out the disease from the other breast.
You based your utility of mammography on the ultrasonography findings, independent of the ultrasonography findings.
Sir, I could not hear.
You insist for mammography depending upon the reports of USG?
Yes, sir.
Yeah, that is not truly acceptable, Deepika. Yeah. See, mammography has to be done. You cannot depend exclusively on
Deepika,
yeah.
you switch off video mode.
Okay, sir. Yes, sir.
Yeah. Okay, go ahead. Madam, you have any questions, ma'am?
How you talk?
No. See, basically, as what sir was telling, what are the actual indications of mammography in a locally advanced breast carcinoma like this? A lady where we clinically were almost sure and other investigations corroborate.
Yes,
what
sir.
is the specific reason for getting a mammogram done here?
Many small lesions which are present in the opposite breast, which could not be picked up by the USG, I would like to confirm and rule out through mammography, ma'am.
Mainly it is for the opposite
involved
breast, isn't it?
You don't want to image the involved breast mammographically?
Indication for ultrasound of the involved breast. Will it help us to plan further procedure? Are we confident of diagnosing all the lymph nodes which are present there on only clinical examination? Do you think the ultrasound is going to help us in a better way?
Many multifocal lesion which would not be found out clinically.
Okay, that's one issue. Second would be, do you think using of an ultrasound in the axilla is going to help us detect more number of possible involvement of the lymph nodes in comparison to our clinical examination?
Yes, ma'am. Yes, ma'am.
There may be quite possible.
Subcentrimetric lymph nodes which could not be picked up by clinical examination is found out by the ultrasonography, ma'am.
That is the main indication.
And even in mammography, axilla is not seen. So ultrasound is preferred for axillary examination, ma'am.
Definitely. See, the indication for asking for an ultrasound mainly here is the detection of the non-palpable lymph nodes which may be possibly enlarged there, isn't it? Both
yes,
the
ma'am. Yes, ma'am.
And the main indication for mammogram is trying to find out what has happened with the opposite breast where we are clinically unable to detect a particular lesion.
Yes, ma'am.
Because this is 3B, would you like to do a bone scan?
Yes, ma'am. If the patient, it requires bone scan, ma'am, because it is a locally advanced breast cancer. So I would also like to rule out any micrometastasis present in the skeletal system.
What is the percentage of a pickup of in the bony mets?
60%. 60%.
Okay. So what percentage of bone has to be dissected to be casted on X-ray?
Sir?
What percentage of bone has to be demineralized before
20 to 30%. 20 to 30%.
No. Until unless more than 50 to 60% of the bone is demineralized, then only it can cast as a lesion on a plain X-ray. What sort of lesions are there in the bone?
Osteolytic.
Osteolytic. So can you name the other malignancies which can have osteolytic lesion?
So CA osteolytics, CA uterus.
CA uterus, then?
Prostate, multiple myeloma.
Okay.
Dr. Sharachandra, question, sir.
Hello. Yes. Why you go for core needle biopsy, not FNAC?
FNAC, sir, it cannot differentiate between in situ and invasive lesions, and it can also not give us the hormone status, ERP or HER2 status. So I would like to go along with true cut biopsy, sir.
You get a more the reason behind that core needle biopsy. In core needle biopsy, you get a good amount of tissue so that you can do histopathology, invasion, ERP and HER2.
As an extension to what Professor said, do you have an option here other than a core needle biopsy and an FNAC?
Yes, sir. There is something called vacuum-assisted biopsy, sir.
Nothing, something that you can do in your outpatients. In this case, you have an ulcerated lesion. Did you think of an incision biopsy?
Yes, sir. Incision biopsy can be done.
Big
sir.
chunk, much bigger than your core needle biopsy.
Yes,
a bit of lateral thinking, that's what I'm trying to encourage in you. It need not necessarily be only core. Of course, you wouldn't cut into something which is not ulcerated, but when there is an ulcerated lesion, you can easily think of an incision biopsy. Take an ulcer edge biopsy like you do it for any other ulcer. Take a big chunk and pathologist will be very happy. How would you treat this patient, Deepika? How much time do we have?
You can have scrapings also. What Lakshman sir added, you can have a scraping of the ulcerated lesion.
Yes,
Then if you don't want to, then you can take even imprint cytology also. It is a faster there with outpatient. These are other extensions of when the patient is budget of the ulcerated lesion.
Ulceration.
You can take the imprint cytology, you can take the scrapings, and you can do the edge biopsy at the bedside or even at the OPD setting.
Okay.
You need not go for the core needle biopsy.
Put across the how you would like to go about your treatment.
Since it is a locally advanced breast cancer, I would like, and it is stage 3B, I would like to go with first with neoadjuvant chemotherapy, 2 cycles of AC regimen, adriamycin and cyclophosphamide, then reassess the tumor and then see if it is responding well or if it is a progressive lesion or responding tumor. If it is responding tumor and it is operable, I would like to go ahead with MRM, modified radical mastectomy.
What do you mean by the complete responder? What do you mean by the responder? What exactly may be?
So, less ink 75% decrease in the tumor size is called as responder, sir.
Okay, 50 to 70% of the tumor regression in the size is considered as a good responder. Okay, what do you mean by the poor responder?
Poor responder is 25%, less than 25%, sir.
Yeah, apart from that, less response and they're progressive to grow in spite of your treatment. They're all called as a poor responder. Okay.
So you can have a complete response, partial response, and stable disease.
So what are the things you're going to achieve by neoadjuvant treatment? Not just in this case, in general. What is it that you use it for?
It tells us about that the tumor is chemosensitive or not, sir.
Which is useful in the post-operative treatment phase. Agreed?
Then it also targets the micrometastasis which is present systemically.
All right.
And then it makes the tumor size smaller, which helps us to go ahead with the BCS also, sir.
In certain cases, yes.
Okay.
Yeah.
How do you plan your treatment protocol? Whether you opt for a chemotherapy or whether you opt for endocrine therapy? What factors you decide?
So we should look for the receptor status, sir.
Okay.
If it is ERPR positive, then I would.
Looking at the metastasis. They are a hormone response. Then only you go for endocrine therapy. If the ERPR positive, then only you'll go for endocrine therapy. Otherwise, you'll not go for that. Looking at the metastatic disease, how you decide?
So, if it is a metastatic disease,
the chemotherapy is an ideal, or whether you go for an hormone.
In other words, does it depend on the organ involved in the metastasis?
Organ involved. Yes, that is a better question.
No, sir.
Think again. Ishwar, you want to give the answer, please? Yeah.
Yeah. If it is more of a bony metastasis, these are the patients who will better respond to endocrine therapy or hormone therapy. Okay, so we can achieve almost around 1 to 2 years of a disease free, even though they are advanced malignancies. Then, if they are visceral metastases like skin and soft tissue and other things, in those cases they will be better respond to chemotherapy because our idea is to target about the micrometastasis in the chemotherapy protocol.
Right. Thank you. I think we are done with the time.
Yes.
Okay, we're done with the time. Deepika, I think you did well. Others to opine, please. Yeah.
It is definitely good. I think little clarity regarding the protocol of the investigations would be definitely better. Otherwise, overall her presentation and approach is definitely logical and sequential.
Thank you.
Hello.
Deepika, well done. All the
Thank
best.
you.
Well done, Dr. Deepika. I think you did a good presentation, and as Madam told, you can improve on those minor things, and I think you will do a good job in your ensuing examination. Thank you.
Thank you, sir.
Thank you very much, Deepika.
Thank you, Deepika. Now, I would like to call upon our second presenter for the session, Dr. Abhishek Chaudhary.
Good evening, sir. Am I audible, sir?
Good evening. Please go ahead. Yeah.
Yes, sir. Yes. Good evening, sir. Myself, Abhishek Chaudhary, a postgraduate student in the Department of General Surgery, KIMS Hubli, going to present a case on right iliac fossa mass with undescended testes under the mentorship of Dr. Burshantapa Vai, sir, Professor and HOD, Department of General Surgery. Next slide, please. A 53-year-old male came with complaints of mass in the right side of the abdomen since 1.5 months, which was initially small in size, progressed to the present, and it is not associated with pain, vomiting, altered bowel habits, jaundice, loss of appetite, cough, evening rise of temperature. There is a history of undocumented weight loss. There is history of absence of the right testis in the scrotum since childhood. He is married with 2 children and he is chronic alcoholic since 25 years, and the last pinch was 1.5 months back. Next slide, please. General physical examination. Patient is moderately built and nourished. On vitals, pulse rate 80 beats per minute, BP 120, 70 millimeter of mercury, saturation 97% at room air. He is afebrile with a respiratory rate of 18 cycles per minute. He has no pallor, icterus, pedal edema, generalized lymphadenopathy, and his ECOG performance status is grade 0. Next slide, please. On per abdomen examination, inspection, umbilicus was central and inverted. A mass of size measuring around 10 into 8 centimeters was seen in the right iliac fossa, extending into the hypogastric region, the umbilical and right lumbar region. Superiorly, it is extending around 8 centimeters below the right costal margin in the midclavicular line. Inferiorly at the level of the superior iliac spine in the midclavicular line, medially up to the midline, and laterally up to the level of the anterior superior iliac spine. Next slide, please. Here is the mass on inspection. Next slide. Hernial orifices are intact. Scrotum on the right side is underdeveloped and it is empty. And like on leg raising test, mass becomes less prominent, and there are no other visible mass noted in the abdomen. Next slide, please. On palpation, there is a well-defined mass of size 10 into 8 centimeters in the right iliac fossa, extending into the hypogastric region, umbilical and right lumbar region, extending superiorly 8 centimeters below the right costal margin in the midclavicular, inferiorly at the level of anterior superior iliac spine in the midclavicular line, and medially up to the midline, laterally up to the level of anterior axillary line, with well-defined border, smooth surface, and non-tender, which is hard in consistency, and mass moves in all directions. Next slide, please. The rest of the abdomen is soft and it is not tender. There is no hepatomegaly or splenomegaly. There are no other palpable mass in the abdomen, and hernial orifices are intact. Scrotum, right side is underdeveloped with absence of right testis with absent cough impulse, and left side is well developed with testis and spermatic cord palpable, and it is normal. There is no left supraclavicular lymphadenopathy. Here is the video of palpation of the abdomen. You can see the rest of the abdomen is soft. No organomegaly. This is the mass with well-defined borders, and it is movable freely in all directions. We will see subsequently. Also note that the right scrotum is underdeveloped. Next slide, please. Percussion, tympanic note heard over the mass except at the lateral aspect of the mass where dull note is heard. Rest of the abdomen is tympanic note is heard, and auscultation, bowel sounds are present. On distal rectal examination, mucosa is normal. There is no growth or melena. Next slide, please. All the other systems are within normal limits. Next slide. Summary: a 53-year-old male, chronic alcoholic, presented with complaints of painless mass in the right lower abdomen since 1.5 months, with no altered bowel habits, with history of absence of right testis in the scrotum, with undocumented weight loss. On examination, 10 into 8 centimeter size mass in the right iliac fossa, extending into hypogastric, umbilical, and right lumbar region, with well-defined borders, non-tender, hard in consistency, mobile, with absence of right testis and underdeveloped scrotum. Next slide. My provisional diagnosis first is mesenteric mass, likely a lymph node mass. Second is testicular tumor in a right undescended testis. Next slide, please. I'd like to get USG.
Just hold on. You're really going at a very fast pace. Can you please go back to the history, because you were so fast I couldn't really catch up with everything that you had asked. Okay, document absence, right testis, no pain. Just give me 10 seconds.
Yes, sir.
All right. Would you like to ask about urinary symptoms, if any?
Yes, sir.
Did you do that?
Sir?
Did you do that?
Yes, sir. I asked about the urinary symptoms, sir, for hematuria, sir, but he didn't have any hematuria, sir.
Okay, you mentioned about weight loss, unintended. What is the definition of that? When would you call
Sir, undocumented weight loss, in patient gave history that his clothes have become looser.
No, I understand, but what there is a definition which includes the time frame, not only
Yes,
the
sir.
quantity.
It is 10% of the loss of 10% of the body weight within 6 months, or it is 5% within 3 months, sir.
Yeah, that is the.
Abhishek, you have to always give the objective assessment. Subjective is variable from person to person. You always give the what sir said. It is a 10% of weight loss in last 6 months is a better way of objective assessment of the weight loss. History of absence of right testes in the scrotum since childhood. Okay. So the moment the patient gives such history, the diagnosis are always obvious. In spite of all these things, so what made you to put as a differential diagnosis of a mesenteric lymphoma?
Sir, actually on examination, the mass is movable in all directions, sir.
Okay. Wait, do you expect a mass related to the genitalia doesn't move in all the directions?
Sir, as a testicular mass will be retroperitoneal, it is unlikely to have movements in all directions, sir.
No. For your kind information, undescended testes with a mass invariably the intraperitoneal nature. So rarely they go into the retroperitoneal.
Go on, man. Yeah.
Sorry, sir. When I observed the video, what I observed was you were attempting to move the mass, and it appeared like it was moving. Especially masses of this size, don't you think it is a tree-top mobility? Were you able to hold it and move it to a separate quadrant or significantly away from its original position?
No, palpation, I couldn't move it significantly, man. Like we asked the patient to turn around and examine them so that the mass pulse, but it was not that significantly in movement.
This particular mass is in the right lumbar area also. Have you elicited the bimanual palpability and palatability in this case, which I didn't see in your palpatory findings?
Yes, sir, I did, sir, but it was
is it necessary to do it? One thing, and second thing, the inference is different. Is it necessary to do it? This is my first question.
Yes, sir. In lumbar region, bimanual palpation is necessary, sir.
Yes. Your inference is different, whether it's palpable or not. But is it mandatory to elicit the bimanual palpability, palatability in this case?
Yes, sir.
Yeah, it is necessary. You have done it?
Yes, sir. I've done it, sir.
But you have not mentioned in your history, in your presentation. You have mentioned it? I didn't say it properly.
No, that was not mentioned, nor was a specific mention made of the plane of the swelling. I didn't see you.
Sir, on leg raising test.
I mean, I know you know what it is, but you didn't mention it, and I think it's important to mention that it is an intra-abdominal swelling. Would it surprise you that there is no hernia? I know you looked for it.
Sorry, sir.
Would it surprise you that there is no hernia there? That there is no cough impulse?
No, sir.
No? Don't you think undescended testis is generally associated with a?
Yes, sir. In some of the cases, sir, there will be it will be associated with the hernia, sir, and we will make out cough impulse, sir.
Yeah. Did you specifically mention about a left supraclavicular node in your examination?
In cases of
looking for it, that is that's an important thing that you should look for.
Yes, sir.
All right, please go ahead with your investigations here. Any others, Dr. Sharat Chandra, sir? You have anything to ask?
Sir, it's a renal, right lumbar mass. He has completely missed out on the examination of the renal angle, and that as Professor Aishwar told that palatability, palpable, and all those things. It's a basic. This one we cannot accept this lapse when a postgraduate presenting this in presentation, physical examinations.
Yeah, that's an important issue. You should look at the renal angle. Yeah, please go ahead with your investigations. Yeah.
I'd like to get USG abdomen and pelvis or USG scrotum, sir.
Can somebody change the slides, please, for the investigation slide? Hall in charge. Yeah, go ahead.
Along with tumor markers, CCT abdomen and pelvis, chest X-ray, and routine blood investigation, sir.
Okay. Why you ask for USG scrotum?
Sir, as there is absence of right testis,
Okay.
I'd like to get. I'd like to know the status of the left testis also, sir.
Why you will look for the status of the left testis?
Sir, sometimes there is chances of contralateral testicular tumor also, sir. If we are suspecting a testicular tumor on one side, sir.
In a known case of testicular tumor occur in undescended testes, there is definitely increased incidence of the malignancy in the opposite. What is the incidence of malignancy developing in the opposite testis?
Sir, around 10%, sir. If
no, not that much. Around 2 to 3%, not 10%.
2 to 3%, sir. 2 to
3%. Okay. Then you asked specifically mentioning about the tumor markers. What tumor markers you are interested?
Sir, I'd like to get alpha fetoprotein, sir, beta HCG. And,
what probable histopathological diagnosis you are expecting a tumor arising in undescended testes?
Sir, most commonly it is seminoma, sir.
If you're thinking in terms of seminoma, which tumor markers you would like to go for it?
Sir, LDH and placental alkaline phosphatase, sir.
Then why you mentioned about alpha fetoprotein in the beginning then?
Sir, there are chances of mixed germ cell tumors also.
Yeah, more than 60 to 70% of the intra-abdominal testicular tumors will be the seminoma in nature. So you have to give the preference first for the which you know it.
Yes.
If you start mentioning about which are not required, then it gives the impression that probably you don't know what are the tumor markers you're supposed to do it.
Yes, sir.
Okay. CCT abdomen and pelvis.
Yes, sir.
What is the need for that? What is the need for going for CCT abdomen and pelvis?
Sir, in this case, I would like to delineate the mass from the organ of origin, sir, and also I'd like to know regarding the nodal status, sir.
Okay.
Ma'am,
just X-ray?
Sir?
Okay.
Just X-ray or CT? You mentioned both.
Sir, I'd like to get first chest X-ray, sir,
Why?
Sir, to know, to see any cannonball metastasis, sir, or any mediastinal widening.
Are you interested in only lung metastasis, or are you interested in something else? If you want to know in X-ray chest.
Mediastinal widening also, sir.
And then which is a better investigation of choice then?
CCT, sir. If
then why you mentioned about it? You are contradicting your own investigation protocol. If you want to assess the nodal status completely, the better investigation of choice is always CT. You could have mentioned only CT abdomen and chest. So your CT chest also will show the cannonballs. No, why only the chest X-ray will show the cannonballs? The CT chest also shows the cannonballs. Okay, when you are asking for investigation, you have to choose which gives the maximum information in this case, because you are interested to know the stage of the disease, whether the mediastinal nodes are involved, supradiaphragmatic as well as the infradiaphragmatic. So ideally, the CT abdomen would have been better.
Yes, sir.
Okay, sir, you please take on.
Ma'am, go on. Yeah, go on, sir. Sharat Chandra, sir, please go.
You spoke you want to go for tumor markers. Would you like to go for tumor markers before having tissue diagnosis? What is the goal of tumor markers?
Yes, sir. I'd like to go for tumor markers before tissue diagnosis.
Why?
That is preoperatively.
Want to interested to do tissue diagnosis in this case? You want to do the tissue diagnosis for this case?
Tissue diagnosis
sir?
After surgery. Before surgery, you want to know tumor markers or?
Before surgery, sir.
Why you want to know tumor markers before surgery?
Sir, after surgery, the tumor markers may reduce, sir. So we can correlate.
You're getting a baseline level.
Yes, sir, baseline level.
A simple answer. Related question from the chat box: is tumor marker required before making a final diagnosis?
Not for making diagnosis, sir.
Yeah.
But for further follow-up, we may need the tumor markers.
Correct.
Then how do you establish the diagnosis in this case?
Sir, in this case, after surgery only, sir. And
then what is the role of a tissue diagnosis? Sir was asking about the tissue diagnosis.
Sir, for tumor markers, it doesn't play any role, sir, for tissue before tissue diagnosis.
Abhishek, your answer would have been there. There is no tissue diagnosis required whenever
required. Yes, sir.
Whether it is an intra-abdominal testicular tumor or testicular tumors occurring in a normal scrotum. So there is no way unless the scrotum is involved. So your answer would have been images and as well as the tumor markers.
Tumor markers, sir.
You're supposed to make your diagnosis and you have to go ahead with the
and you're justified in exploration even without a preoperative tissue.
Preoperative. Yes.
Ma'am, you have anything to ask, ma'am? Please unmute yourself.
Is there any role of FNAC here?
No.
No, ma'am.
Why?
Ma'am, it can cause seedling of the tumors, which can alter the spread, which can cause the spread of the tumor to the extra.
No doubt. No, this is standard teaching, but this is quite debated now.
Yes.
Reasonable evidence
really have FNAC?
Regarding the advantages of FNAC. Anyway, your answer is accepted. Okay. Now, how do you
Abhishek, when can you have an FNAC?
Sir, after either when there are secondary mets, whenever there is tumors.
Okay, if your image has shown that there are already metastases, are there one thing? Anything local involvement?
If there is no local tumor, sir, a primary tumor is.
I'm asking about the testicular tumor occurring in a normal scrotum, in a descended testis.
Sir, if there is a tumor in the testis and there are nodes, sir, then we need not go for tissue diagnosis in that case, sir.
When do you go for tissue diagnosis?
After treatment, sir, like after post treatment, if you want.
You are not catching my question. If there is the scrotum is already involved, the skin is already involved, where you cannot see the scrotum, then there is definitely you can go ahead with that biopsy or true cut, whatever it is, provided you are going to encompass that lesion in your surgical exploration.
Later exploration. All right. Okay. So can you give us the findings of these things that you have done, please, Abhishek?
Yes, sir. Next slide, please. In USG abdomen and pelvis, there was a well-defined encapsulated heterogeneous lesion of size 9.3 into 9.5 into 10 centimeters noted in right iliac fossa, umbilical and hypogastric region with few cystic areas. There were no calcification and there was minimal vascularity on venous Doppler, suggestive of neoplastic entity, and liver was normal with fatty change. Whereas, next slide, please. USG scrotum showed empty right scrotal sac and not right inguinal region, and right testis was not appreciated in the right inguinal region. Left testis was normal with spermatic cords. Tumor markers, AFP was normal, sir, 1.89 nanogram per ml. Beta HCG was normal, 3.66, whereas LDH was raised 435 international units per liter. Next, CCT abdomen showed well-defined heterogeneously enhancing large solid mass with central non-enhancing necrotic areas with few calcific foci measuring 9.5 into 9.2 into 10.7 centimeters in right iliac fossa, anterior to ileocecal junction, and it is in close proximity with the adjacent small intestine, and IC junction is normal. Cecum and colon are normal. There are no lymph nodes. Next slide, please. Here is the CCT abdomen transverse section. So as you can see, this is the tumor. The right iliac fossa. This is the urinary bladder. Next slide. In the slide, we can see that the tumor is with cystic areas in the. This is urinary bladder. Next slide. In this section, we can see that both the kidneys are normal and there are no lymph nodes, and the tumor is separated from the bladder. Next slide. This is the same for CCT. Next slide. This is the X-ray of the X-ray chest of the patient, which shows no mets. Next slide. We did surgery, and this was the intra-op tumor noted. And HP came as seminoma testis.
On table, were there any lymph nodes?
No, ma'am.
Of lymph nodes or any? Did you attempt for any biopsy there?
No, ma'am. There were no visible lymph nodes, ma'am. And no.
Did you plan for a frozen on table?
No, ma'am. Not for this tumor.
If you find that some nodes are there, is there an indication to go for lymphadenectomy in this case?
Yes, sir. If any nodes are there,
when your image and when your markers are suggestive of a seminoma, then you have done excision of the tumor, you would like to go for a lymphadenectomy in these cases?
Depending upon the size of the nodes, sir. and extent.
There maybe small few nodes are there. Many of the times they are reactive in nature. Aortic cable, pre-cable, when the image has not picked up, your CT has not picked up any tumors, then most probably, if at all the small nodes are there, most of the time they are reactive in nature.
Reactive.
If you are suspecting is a seminoma, my question is, would you like to go for a lymphadenectomy in this case?
No, sir.
Abhishek,
Why then?
Yeah, that is a very important and weighty question. And you must have your answer very clear. Your answer that you do not go for a lymphadenectomy is correct, but you must know the reason for it.
Sir, the lymph node dissection causes more morbidity, sir. In this case, we can go for retroperitoneal lymph node dissection, sir, which has more morbidity.
You are a very competent surgeon. I'm sure that you are not going to injure anything. Still, you would like to do it?
No, sir. We would like to wait.
What justifies that weight?
In one answer, there is no indication of lymphadenectomy in a suspected case of seminoma because the adjuvant therapy like chemo is highly effective for this.
Yes, sir.
Even the medicines are there in the nodal disease can be taken care by your adjuvant therapy by this one. There is only a small role of lymphadenectomy if they are non-responded to chemotherapy. So very rarely when seminoma occurs, then there may be a role of extensive lymphadenectomy in seminoma. One answer would have been there is no indication of a primary lymphadenectomy during the orchidectomy. Your answer would have been more specific like this.
Yes, sir.
If it's something else, teratoma, surprisingly uncommon in these cases, then probably it gives an indication to go ahead with the lymphadenectomy and retroperitoneal lymph node dissection.
Yeah. All right. Good. With the permission of the panel of examiners, we will stop here. I know we are stopping about 3 minutes earlier than the scheduled time, but we will catch up because this session is supposed to get over at 8 p.m. Can we do that, sir?
Yes, sir, sure.
Yeah. Thank you. I think you did well, Abhishek.
Thank you,
but
thank you the MidCon team and other thing for giving me an opportunity. Thank you once again.
Thank you, all of you. Thank you very much.
Thank you, everyone from the MidCon, and thank you, sir.
Thank you. Yeah.
Thank you, organizers, for this opportunity. Thank you.
Thank you. Hall in charge, please proceed with the next session.
Yes, yes, sir. Thank you all the chairpersons for chairing the session. Now,
Abhishek, good presentation. By the way, good presentation and good case.
Abhishek, you did a good job.
Thank you, ma'am. Thank you all. Thank you.
Yes, sir. We'll move on to the next session.
Hello. Good evening, everyone. I welcome everyone to free paper presentation session 6. Firstly, I like to welcome the chairpersons for this session. Dr. Sharath B.V. sir, Professor and HOD, Department of Surgery, Shri Basaveshwara Medical College, Chitradurga. Dr. Sachin V., Assistant Professor, Department of Surgery, MMCRI, Mysuru. Dr. Madhura, Assistant Professor, Department of Surgery, MMCRI, Mysuru. And also I would like to welcome the judges for this session. Dr. Naveen Gowda, Assistant Professor, Department of Surgery, MMCRI. Dr. Harish Kumar P., Assistant Professor, Department of Surgery, JSS Medical College, Mysuru. Firstly, I would like to call upon the participants. And before the starting of the presentation, there are some instructions to the presenters. The duration of the presentation will be 10 minutes. In that 8 minutes for presentation, 2 minutes for the discussion. And in each session, alarm bells will be ring first at the end of 6 minutes and last alarm bell at the end of 30 seconds. I request every presenter to kindly switch on their video. And first, I would like to call Dr. Mohammed Shahid. Your time starts now.
Hall in charge, just 1 sec, please. I see Dr. Ashok Godi there. I think he was there for as a judge. Yeah. Sir, were you a judge there for 8 o'clock session, sir?
Sure. I am here for that only. I am here.
Yeah, I'm just. Yeah, please include him as a judge. I didn't see you announce his name. Kindly include that. Yeah.
Yes. Sir.
I also welcome Dr. Ashok Godi sir as a judge for this session.
Yeah. Okay. Please go ahead, presenter. Yeah.
Good evening, everyone. Yes, am I audible?
Yes.
Hello, am I audible?
Yes, you are. Please go ahead. Yeah.
Good evening, everyone. The topic of my paper today is a study on association between benign prostatic hyperplasia and inguinal hernia. Next slide, please. Introduction. Benign prostatic hyperplasia is a histological diagnosis associated with unregulated proliferation of connective tissue, smooth muscle and glandular epithelium within the prostatic transitional zone. BPH may cause physical compression of the urethra and result in anatomical bladder outlet obstruction. The occurrence of inguinal hernia and benign hyperplasia with accompanied urinary tract obstructive symptoms are related to age. Benign obstructing prostatic enlargement also predisposes to hernia and aggravation of symptoms related to hernia. On the basis of this evidence, significant correlation between inguinal hernia and obstructive benign prostatic enlargement may be expected. Inguinal hernia and symptomatic prostatomegaly are found together with a high frequency amongst the elderly patients. There occur
We lost your voice, is it? All in charge, can you hear him? I have lost his voice.
No, sir.
You
We are
can't
unable
hear
to
him.
hear. No.
Please tell him so. Tell him so when that is the
Hello.
case. Yeah.
Mohammed? Hello?
Am I audible? Hello.
Your voice is not clear. Yeah, right. Yeah, you can speak now.
Inguinal hernia and symptomatic prostatomegaly are found together with a high frequency amongst elderly patients. The occurrence together is considered a chance coexistence rather than a cause and effect. Although approximately 5% of the general population is affected by hernia, the incidence of inguinal hernia is 15 to 25% in patients undergoing prostatectomy. The mechanism that might explain the increased risk of subsequent inguinal hernia in patients with BPH are unclear. One possible hypothesis is that the BPH patients have to push or strain to begin urination, which might lead to an increase in the intra-abdominal pressure. Next slide, please. Aim of the study to find out whether there is any causal association between benign prostatic hyperplasia and inguinal hernia, materials and methods, source of data. 75 male patients aged more than 50 years admitted with inguinal hernia to the surgery male ward of KVG Medical College from 1st October 2019 to 31st December 2020 are selected as cases. Inclusion criteria were male sex age more than 50 years and those with inguinal hernia. Exclusion criteria was female sex age less than 50 years, known case of connective tissue disorders, known cases of BPH who are already on drugs or have had any form of surgery for BPH in the past, a presence of complications of hernia such as irreducibility, strangulation, and obstruction. Next slide, please. The inclusion criteria for controls include male sex, age more than 50 years, and not seriously ill. The exclusion criteria for controls include female sex, age less than 50 years, known case of connective tissue disorders, known case of BPH who are already on drugs or have had any form of surgery for BPH in the past, presence of inguinal hernia unilateral, bilateral, or recurrent, history of surgery done for inguinal hernia in the past, seriously ill or bedridden patients. The study design was a prospective study. Sample size was 150 and sampling procedure. First, 75 male patients aged more than 50 years in order of their date of admission with inguinal hernia to the male surgical ward of KVG MCH Sulia between October 2019 and January 2021 are selected as cases. Every week after selecting cases, the corresponding number of control subjects was selected randomly from the patients admitted to KVGMC Sulia for conditions other than inguinal hernia so as to make a control group of 75 subjects. Informed written consent was obtained from each of the cases and controls. All subjects were interviewed and examined by a single observer. For this study, 3 independent variables, international prostate symptom score, prostate-specific antigen, prostate volume were taken, and prevalence of BPH in cases and controls were found out for each of the 3 variables separately. International Prostate Symptom Score. International Prostate Symptom Score was obtained by reading out the questionnaire and answered options in the prescribed format, as many of the study subjects were not able to read the questionnaires and mark the answers in the prescribed format. Each questions were read out with its answer options, and the score for each questions were marked separately, and the sum was calculated to find out the international prostate symptom score of each subject. The International Prostate Symptom Score is an 8-question, 7 symptom questions, and 1 quality of life question written screening tool used to screen for rapidly diagnose, track, and symptoms of and suggest management of symptoms of the disease benign prostatic hyperplasia. A score of 7 symptom questions were added to get the International Prostate Symptom Score IPSS result of 7 symptom scores. 0 to 7 was considered as mildly symptomatic, 8 to 19 moderately symptomatic, and 20 to 35 severely symptomatic. Next slide, please. Subjects who are moderately or severely symptomatic, that is those with International Prostate Symptom Score more than 8, were taken to have significant benign prostatic hyperplasia. Those who are mildly symptomatic, that is those with International Prostate Score less than 8, were taken to have no significant benign prostatic hyperplasia. Prostate-specific antigen. Prostate-specific antigen is a glycoprotein produced by prostate epithelial cells. It is responsible for liquefaction of seminal fluid and allows the spermatozoa to swim freely. As a consequence of altered architecture of the prostate in conditions such as BPH, prostatitis, as well as prostate cancer, PSA may enters the bloodstream and is detected in the blood tests. The blood samples from the subjects were taken before doing digital rectal examination. Subjects with the prostate-specific antigen values more than 4 nanogram per ml were taken to have significant benign prostatic hyperplasia in the study. Those subjects with prostate-specific antigen less than 4 were taken to have no significant benign prostatic hyperplasia. Prostate volume, more than 20 cc of prostate volume was taken as significant benign prostatic hyperplasia in the study. Transabdominal ultrasonography was used to measure the prostate size in this study. So subjects with a prostate volume more than 20 cc are taken to a significant benign prostatic, and those with less than 20 cc are taken to no significant benign prostatic hyperplasia. International Prostatic Score serum prostate specific antigen and prostate volume were found out for all cases and controls. The prevalence of benign prostatic hyperplasia in both cases and controls were done for each of the 3 variables studied here. Univalent analysis of the association between inguinal hernia and the benign prostatic hyperplasia were done for each of the 3 variables separately. KSCA test is used to find out the association, and p-value were calculated for each variable. A p-value of less than 0.05 is taken as statistically significant. Next slide. Analysis and discussion. A study was conducted over a period of 15 months from 1st of October 2019 to 31st of December 2020. A total of 75 cases and 75 controls were selected. The cases were all males aged between 51 years and 85 years with a mean age of 63.42 years. The age distribution of the cases were as follows: 51 to 60
Time is up for
years,
discussion. Now panel is open for discussion.
Mohammed, can you hear me?
Yes. Yes, sir.
You have divided your subjects into control subjects and the study subjects. Okay?
Yes,
so,
sir.
what
Yes,
did you
sir.
do with the study subjects? What did you do with the control subjects? Your slides are too crowded. The entire text is there on the slides. This is not the way to make slides, Okay? Can you answer my question? What did you do with the study subjects? What did you do with the control subjects? And how did you compare them?
So for the study subjects and the control subjects, I did the international prostate scoring system. We evaluated with that, and then the prostate specific antigen was also done, sir. And prostate size was determined, sir. Based on these values, those suffering from, we tried to find out whether there was any correlation between benign prostatic hyperplasia and inguinal hernia. Sir.
What were the conclusions?
The conclusion was that there was no cause and effect. There was no association between inguinal hernia and benign prostatic hyperplasia, and it is more of a chance coexistence because both.
Any more questions from the audience?
Dr. Mohammed, can you hear me?
Yes, sir.
This is Dr.
Yes, sir.
Sharath here. So how did you get that
Hey,
75
time up.
control and 75 case? cases? Did you use any formula for that?
No, there was an inclusion and exclusion criteria. So those patients who were suffering from inguinal hernia, we took
Time
them
up,
as
time up for the
cases.
discussion. I
And,
would like to next call upon the next presenter, Dr. Pawan Kumar.
Hello.
Dr. Pawan Kumar, are you here? Your time starts now.
Yes. Good evening, everyone. I'm Dr. Pawan. Today I'm going to present a free paper on spectrum of wound infection secondary to snakebite. Introduction. Snakebite is a serious health hazard in tropical and subtropical countries. In developing countries, occupational hazards for rice field workers, rubber plantation workers, and herders and hunters. Whereas in industrialized countries, snakes are increasingly popular as pets, and most bites are inflicted when snakes are mishandled or attacked. The dearth of information exists about the bacteria responsible for wound infections in snakebite patients. So in this study, we have evaluated the aerobic bacteria responsible for snakebite associated wound infections and the antibiogram of these isolants. The aims of the studies are to determine the frequency of wound infections secondary to snakebite, to identify the bacterial pathogens responsible for wound infections secondary to snakebite, and to determine the antibiotic susceptibility pattern in patients admitted to Victoria Hospital. The materials and methods, study design. It was a retrospective review was performed of patients admitted to our hospital with snakebite. The study period was taken from September 2019 to March 2020. Inclusion criteria. The diagnosis of snakebite was confirmed by the Department of Physicians. All cases who received polyvalent antivenom and tetanus toxin. Exclusion criteria. Patients who received prophylactic antibiotics. The data collection was done as the infected tissues were surgically debrided and inoculated onto blood agar and McConkey agar for aerobic bacterial culture, followed by antibiotic susceptibility testing. And antimicrobial susceptibility testing was performed by Kirby or disk diffusion method as per CLSI guidelines. The statistical analysis. Data was collected and tabulated in the Microsoft Excel sheets, and analysis was done by using SPSS VS20. The results were, during the study period, 60 patients presented to the Victoria Hospital with snakebite, which included 38 males and 22 females, among which 24 patients developed secondary wound infections to snakebite, in which 16 are males and 8 are females. The most gram-positive isolate was found to be Staphylococcus aureus, which is 10 in number, followed by Coagulus negative Staphylococcus and Streptococcus species. Among gram-negative bacilli, member of Enterobacteriaceae were most frequent isolates, followed by non-fermenters. The E. coli was found to be 6 in number. Next slide, please. Yeah, the Staphylococcus aureus formed the 42%, whereas Streptococcus formed the 13%, and 8% by Coagulus negative Staphylococcus, and 25% from the E. coli, 8% from Klebsiella pneumonia, and 4% from the Pseudomonas aerogenes. The Staphylococcus aureus strains showed sensitivity to oxacillin, amikacin, and ciprofloxacin. However, it showed penicillin resistance was observed in 53% of the Staphylococcus aureus. Most of the streptococcal isolates were sensitive to commonly tested antibiotics. Whereas in gram-negative bacilli showed more than 85% sensitivity to aminoglycosides, third-generation cephalosporins, and ciprofloxacin. Ciprofloxacin was the most frequently prescribed antibiotic with good response. The patient responded well to the treatment. So these are the susceptibility. The Staphylococcus aureus showed 44% susceptibility to oxacillin, and 80% to ciprofloxacin, and 18% to amikacin, and 45% to piptaz, and 56% to the ceftriaxone. Whereas E. coli showed 16% to the oxacillin, and 44% to the ciprofloxacin, and 87% to the amikacin, and 17% to the piperacillin, and 34% to the ceftriaxone. The discussion. The oral flora of the snake comprises a wide range of aerobic and anaerobic microorganisms, especially the fecal gram-negative rods, because they prey usually defecate while being ingested. Soft tissue infections are major complications of snakebite with local envenoming. The proteolytic properties of snake venom causes extensive tissue destruction and devitalization, thus predisposing the wound to bacterial infections from the snake's indigenous oral flora. In our study, the antibiogram showed that the majority of the isolates were sensitive to commonly tested antibiotics such as amikacin and ciprofloxacin and ceftriaxone. Ciprofloxacin, an oral drug effective against both gram-negative and gram-positive isolates, was most frequently prescribed to the patients who developed wound infections. The patients responded well to this treatment. These are my references.
Now panel is open for discussion.
Thank you.
Pawan Kumar, can
Yes,
you hear
sir.
me? Can you hear me? Huh?
Yes, sir. Yes, sir. Yes, sir.
Yeah, was it a cobra bite or a viper bite? Or?
No, sir. The snake were not identified, sir. It was not
What do you
included in the
think
study.
from the study? What do you think? They are cobra bites or viper bites? From the study, from the literature that you have read.
Yes, sir. Viper bites, sir.
Viper bites. Okay.
Yes, sir.
Do you think some of these organisms might be nosocomial infections instead of coming directly from the bite, from the mouth of the snakes? Could it be nosocomial infections?
Yes, sir. Hello. Hello. Hello.
Yes, you're audible. You're audible.
You're
Yes, sir.
audible. Please speak.
Yes, sir. It can be nosocomial infection, sir.
Okay.
So that means that doesn't represent the oral flora of the snake, right?
Yes, sir. It can be both because of the nosocomial infections or the infections from the oral flora, sir. Hello.
Hello. Can you hear me?
Yes, ma'am.
So
Yes, ma'am.
finally, what is the use of doing your study? Like comparing
Ma'am,
the...
to find out the most common organisms associated with the wound infection secondary to snake bite and to start an empirical antibiotic to it, sir.
Okay. And did you exclude other comorbidities or confounding factors for wound healing?
Yes, ma'am. Only diabetic patients were taken, like was included, ma'am.
Have you mentioned that in your inclusion criteria?
Like I mentioned it in the graph. Yes, ma'am.
And any reason for retrospective study? Why not prospective?
Have you compared your study with other publications?
Yes, sir.
Does it match or is it different?
No, it's almost similar, sir.
Thank you.
Thank you, sir.
Thank you, Dr. Pawan Kumar.
Thank you, sir.
I would like to now call upon Dr. Ashwin P. John for the next presentation. Dr. Ashwin, your time starts now.
Good evening, respected judges. My today's free paper topic is a comparative study of interrupted versus continuous abdominal fascia closure using polydioxanone, that is PDS suture in laparotomies. Myself, Dr. Ashwin P. John, third year surgery PG from Department of General Surgery, KSCASImidCON2021 Rajajangar. My guide is Dr. Satyanarayana N. Introduction. Midline laparotomy is the most common technique of opening the abdomen in both emergency and elective settings because it is simple, provides adequate exposure to all four quadrants and affords quick exposure with minimal blood loss. A midline laparotomy requires opening of the linea alba, which is a weak tendinous zone. The weakness of the linea alba is enhanced when its fibers are vertically sections to access the peritoneal cavity. Thus, when closing the linea alba using sutures, these fibers are subjected to the tension induced by the mechanical forces that act upon it. PDS is a first absorbable synthetic monofilament suture that is marketed for clinical use and is suitable for closure of an abdominal wound. PDS is an reabsorbable polymer material that persists in the mid or long term for about 180 to 230 days. Complications which may arise following facial closure include wound dehiscence, wound infection, incision hernia, and suture sinus formation. Next slide, please. Need for the study. Laparotomy wounds have traditionally been closed in a variety of ways in terms of continuous versus interrupted closure, single layer versus mass closure, and absorbable versus non-absorbable sutures. The mesh method of wound closure would be one that provides adequate tensile strength through the incision until the wound heals, approximates the tissue in a way that normal healing mechanism can occur under optimal circumstances, remains secure even in the presence of local or systemic infection. The suture material is well tolerated on a short and long-term basis, and finally should be able to be done with expediency. The continuous suture has an advantage of evenly distributed tension across the suture line and being more expedient. It has a disadvantage of being a single suture holding the whole fascia together. The multiple interrupted suture method has been used successfully for many years, but has the disadvantage of being time-consuming to perform and of isolating the tension to each individual stitch. In view of studies showing that interrupted suture technique is better than continuous technique to reduce incidence of complications, this prospective observational study is planned to compare two techniques of fascia closure using a delayed absorbable suture material, that is PDS, in patients undergoing midline laparotomies in our institution. Next, please. Next slide. Aims and objectives of my study to compare the two techniques of abdominal fascia closure, namely continuous interrupted using a delayed absorbable suture material, BDS, in patients undergoing midline laparotomy in terms of occurrence of complications within 6 months. That is wound dehiscence, wound infection, incision hernia, suture sinus formation. Next is duration of intraoperative time taken for fascia closure. Next, materials and methods, source of data, patients admitted with acute abdomen undergoing laparotomy in Department of General Surgery at KSCASI Medical College and Bangalore. Study design, prospective study period 18 months from 1st January 2020 to 30 June 2021. Sample size 2 group each of 30 patients. Informed consent was taken from all patients. Ethical clearance from the institute obtained. Next slide, please. Selection of patients, inclusion criteria, all patients, males and females admitted with acute abdomen undergoing laparotomies with age between 18 to 75 years, laparotomy through midline incision. Exclusion criteria, cases of primary peritonitis, ileostomy and colostomy. Pre-existing severe comorbidity conditions, that is severe renal and liver disease, anemia, HB less than 10 mg per deciliter, uncontrolled diabetes, malignancy, and patients on anti-cancer chemotherapy or steroids, age less than 18 and age more than 75 years, previous laparotomies through midline incision. Coming to methodology, pre-operative evaluation, all patients enrolled in the study shall undergo pre-operative investigations including complete all blood investigations and X-ray, abdomen, erect and supine, chest X-ray, ECG and USG abdomen. Procedure, patients was seen in emergency department where detailed history shall be taken from the patient if possible, or the relative accompanying the patient. They shall be thoroughly examined and optimally stabilized before laparotomy. Method of closure. Group 1, that is interrupted BDS, PDS number 1 used taking interrupted sutures at a distance of 1 centimeter from the divided edge with a distance of 1 centimeter between the two constituent sutures, taking 5 to 6 square knots in a single suture tie. Group 2 contained continuous group, that PDS number 1 using simple running technique starting just proximal to incision. The bites are taken 1 centimeter from the divided edge with a distance of 1 centimeter to the two consecutive bites in a non-interlocking manner and was closed using abdominal knot at the other end of the incision. Next slide, please. These are the intra-op photos. Next slide, please. Next slide, please. Post-operatively, wounds shall be examined on second day of for any infection. If there is any discharge, dressing to be done as required. Condition of wound shall be monitored regularly and any complications shall be noted in a chronological manner. Suture shall be removed at appropriate time, that is 10 days, assessing the wound condition. The number of days patients stayed in hospital will be recorded. The patients to be followed up at 3 weeks, followed by 2, 3 and 6 months interval after surgery in outpatient department for any suture sinus formation or incision hernia. Status analysis software used was SPSS version 2. Descriptive studies were performed while calculating mean and standard deviation for the continuous variables. Categorical variables will be presented as absolute numbers and percentage. A p-value less than 0.05 considered as statistically significant. Results. In our study, the mean age in group 1 was 36.72 years and 43.72 years in group 2. Majority of the patients were male, that is 39 out of 60, out of which group 1 had 19 male while group 2 had 20 males. Most common diagnosis was duodenal perforation in 27 patients, followed by enteric perforation in 22 patients. Least number of cases were of gastric perforation. Most common procedure performed was modified Graham's patch in 27, followed by primary repair in 25 and resection anastomosis in 8 patients. Mean time taken for closure in group 1 was 31.6 minutes and in group 2 was 17.3 minutes. In our study, mean duration of the operation in group 1 was 12.88 days and 13.76 days in group 2 with no significant difference between two groups. 4 patients in Group 1 develops wound discharge as compared to 6 patients in Group 2. In total, 10 patients out of 60 developed wound infection. The difference was not statistically significant. Next slide, please. These are the tables showing the diagnosis and procedures performed. Burst abdomen occurred in 3 patients out of 60 patients. 1 patient belonged to Group 1 who had localized facial burst, and 2 patients were in Group 2, out of which 1 had localized while the other had complete facial burst, with no statistical difference between the 2 groups. The patient who had complete facial burst was managed by application of Bogota bed under general anesthesia and was followed by secondary wound healing. On the other hand, both the patients who had localized facial wound. Next slide, please. 1 patient developed incision hernia in each group during 3rd month of follow-up. In total, 2 patients out of 60 had incision hernia as complication of surgery. There was no difference in incidence of incision hernia in both the groups. 3 patients in interrupted group and 1 in continuous group developed suture sinuses. In all, overall, 4 patients out of 60, that is, as suture sinus as a complication of laparotomy. The difference was found to be statistically not significant. These are the complications. Coming to discussion, the best method of abdominal closure is one that maintains tensile strength throughout the healing process with good tissue approximation, does not promote wound infection or inflammation, is well tolerated by patients, and is technically simple and expedient. We enrolled total 60 patients with mean 40 age, with 39 males and 21 females. Patient person with acute abdomen underwent midline laparotomy. Duration of abdominal facial closure was statistically significant, with difference of nearly 40 minutes. While comparing post-op complication rates in both groups, it was found to be...
Time up for presentation. Now panel is open for discussion.
Dr. Ashwin.
Yes, sir.
Your study, what is the title of your study?
There is a comparative study between abdominal facial closure using absorbable suture material, sir. That is versus technique, sir. Interrupted versus continuous technique, sir.
Yeah, but you're closing fascia, right? Or
yes,
the sheath?
Rectal sheath, sir. Rectal sheath.
But your study mentions that it's a fascia, but I think you need to change that the title.
Oh, okay, sir. Okay, sir.
Because fascia is different. Fascia is again deep fascia, superficial fascia. That becomes different, right?
Okay, sir.
Okay. And did you find any difference in the 2 groups?
The only
wise or
difference is statistically significant difference not there's only time. Regarding time, it is significant, sir. That is group continuous.
Yeah.
Yes, sir. Other complications wise, better my outcome is, sir, better is interrupted in terms of number, but it is not statistically significant, sir.
That's what statistically it's not insignificant. It's insignificant. So
yes, sir.
So it's not that beneficial. Again, the time
no,
you're increasing. Time is very important, right?
Yes, sir.
Because you're even 10 minutes more time is.
Yes, sir.
It again deters the.
Yes, sir.
So that's why it's better to use continuous, according to you, the conclusion.
Yes.
Okay.
What about post-operative discomfort in thin individuals where you are using interrupted sutures?
In base of complications, interrupted will be better, sir, because even if any wound infection happens, it will be localized, sir. And even if once in continuous, if one that main key stitch, if it goes means it stands for burst abdomen is there, sir.
Time up. I thank Dr. Ashwin, and I now I will welcome
you,
Dr.
Sir.
Deepak for the next presentation.
Thank you, sir.
Dr. Deepak, your time starts now.
Good evening, everyone. I'm Dr. Deepak. I'll be presenting a free paper titled Hyperbilirubinemia as a Diagnostic Tool in Patients with Perforated Appendicitis, the Prospective Study. Introduction. Am I audible, sir?
Yeah.
Proceed.
Yeah. Introduction. Acute appendicitis is one of the commonest causes for acute abdomen in any general surgical practice. The lifetime rate for appendectomy is 12% for men and 25% for women, with approximately 7% of all people undergoing appendectomy. If caught early and managed appropriately, can be the most uneventful surgery. But when missed, appendicitis can turn into a disease with great morbidity and mortality. Aims and objectives of my study was to determine the effectiveness of hyperbilirubinemia as a diagnostic tool to predict perforated appendicitis. Materials and methods. This was a tertiary care hospital-based prospective study conducted at SSIMS in Asudam, and the study was done between August 2018 to August 2020. A total of 140 patients were included in the study. Inclusion criteria: patients aged more than 18 years presenting to Department of General Surgery at SSIMS Davangere with features of acute appendicitis were included in the study. Exclusion criteria: patients were excluded if they had documented liver disease, history of alcoholism, hemolytic disease, and other acquired or congenital biliary disease. The 140 patients that were analyzed were stratified into 4 groups based on the histopathological results. The group patients with the non-inflamed appendices were categorized in group 1, and group 2 patients are those with acute appendicitis. Group 3 patients in histopathology were found to have inflammatory infiltrate extending to the full thickness of the appendiceal wall to the serous. And group 4 patients are the one who had perforated or gangrenous appendix. And the relevant preoperative laboratory results were analyzed for diagnostic properties. And total bilirubin levels greater than 1 mg per dl were defined as hyperbilirubinemia. Statistical analysis was done using IBM XPS's version 22 software. The diagnostic value of bilirubin was predicted with sensitivity, specificity, positive predictive value, and negative predictive value for all the above groups. Categorical variables were presented as frequency in percentages. To study association between the categorical variables, chi-square test used, and p-value of less than 0.05 is considered significant. Observational results. A total of 140 patients were included in the study, and the mean age of presentation was 32 years. And the study included 18 to 70 year age group, and 53% females incidence of acute appendicitis was comparatively higher in females in our study. Next slide, please. And this table depicts the distribution of patients into groups based on the histology. So in the first group, a total of 25 patients were included in the group 1, of which only 3 patients had hyperbilirubinemia. In the group 2, with patients of acute appendicitis, of 80 patients, 24 patients had hyperbilirubinemia. And in the group 3, which included patients with transmural inflammatory infiltration, among 21 patients, 8 patients had hyperbilirubinemia. And in the group 4, with patients having perforated or gangrenous appendicitis, among 14, 10 patients had hyperbilirubinemia. And this table depicts the level of bilirubin in the following groups. Among the group 1 with no acute inflammation, the mean bilirubin levels was 0.5 mg. And in the group 2 patients with acute appendicitis, mean bilirubin levels was 0.8. And in the group 3 patients with transmural inflammatory infiltrates, mean bilirubin levels was 1. And in the group 4 patients with perforated or gangrenous appendicitis, mean bilirubin levels was 1.5 mg per dl. Next slide. This table depicts a statistical analysis of hyperbilirubinemia as marker of perforated appendicitis, where we can see the sensitivity of bilirubin levels assessing the chance of perforation is 71.43%, specificity of 70%, and diagnostic accuracy of 70.21%. Next slide. And similar studies were conducted in the past, where diagnostic accuracy of hyperbilirubinemia as a marker of appendix perforation was conducted. The common ones are the Estrada et al., Sand et al., Etahan et al., Emmanuel et al., and the results of our study are inconsistent with the following studies. To conclude, this study shows that hyperbilirubinemia is an independent predictor of appendiceal perforation with nearly 5-fold risk of perforated appendicitis in patients with total bilirubin levels greater than 1.5 mg per dl. And no single clinical or laboratory test is able to reliably predict appendicular perforation. Therefore, obtaining serum bilirubin values upon admission in conjunction with history, clinical examination, laboratory and radiological investigations is used to make the diagnosis and decide appropriate management. Hyperbilirubinemia alone is not a strong enough predictor, but might have more useful when integrated into a scoring system. These are my references.
Now panel is open for discussion.
What is the cause of hyperbilirubinemia in acute appendicitis?
When the patient with acute appendicitis, once the bacteria sets in, through the portal venous system, it will reach the liver. So there will be endotoxin-related cholestasis, and also the excretion of bile into the biliary canaliculi will be hampered by the endotoxins of the bacteria. This will result in hyperbilirubinemia.
Were your results statistically significant? Did you do any test for that?
Test, yes, sir. Like chi-square test was assessed, but I have not put it in the slides.
No, was it statistically significant?
Yes, sir. It was statistically significant.
Hello. Hello. Can you hear me, Dr. Deepak?
Yes, ma'am, I can hear you.
Did you repeat LFT post-surgery?
No, ma'am. Like
Okay,
during my, as I said, my inclusion criteria included the patients with patients where the bilirubin levels are supposed to be normal. Like I did not include chronic alcoholic patients or the patients who had previous history of elevated bilirubin levels. So I did not repeat the bilirubin levels post-operative.
Okay. Even if the patient is not an alcoholic, so what do you expect post-operatively if the bilirubin levels are not reduced, even after surgery?
It can be due to again.
Yeah, because you answered that, yes, you told hyperbilirubinemia is due to portal pyruvia. Yes. So can it be the reason post-surgery if the patient
Yes,
has?
ma'am. Definitely, ma'am. Even though we have addressed the septic foci, the bacteremia will be eventually addressed with the IV antibiotics.
Okay.
So,
Deepak, one question to you.
Yes, sir.
Did you consider the duration of interval between the admission to the hospital or surgery to the symptoms in your study? Does
No,
it have
sir,
bearing to bilirubin presentation at all?
No, sir, I did not consider that.
Okay, thank you.
Any questions? Okay, thank you, Dr. Deepak. Now again, I will welcome Dr. Deepak for the next presentation. Your time starts now.
This is Dr. Deepak again. I'll be presenting another free paper titled Prospective Study of Acute Appendicitis with its clinical, radiological profile and scoring system in tertiary care hospital. Introduction. Acute appendicitis is one of the commonest causes for acute abdomen in general surgical practice, and the diagnosis of acute appendicitis remains essentially clinical, requiring a mixture of observation, clinical acumen, and surgical science. Most commonly used scoring system worldwide is the Alvarado and the modified Alvarado scoring systems. And the Raja Isteri Penegran Anaxala appendicitis, also called as RIPASA score, is a fairly newer scoring system developed in 2008, where the study was done in RIPAS Hospital, Brunei Darussalam, to find a more favorable scoring system than Alvarado and modified Alvarado. The aims and objectives of my study was to assess the association between clinical, radiological, and operative findings, and thus evaluate the clinical diagnostic accuracy and radiological diagnostic accuracy, to compare RIPASA and modified Alvarado scoring system, and to validate the scoring system in our setting. Materials and methods. This was a tertiary care hospital-based prospective study, and patients with clinical suspicion of acute appendicitis presenting to SSIMS were taken into study. And the period of study was from November 2017 to July 2020. A sample of 70 was included in the study. And the RIPASA and modified Alvarado score will be applied to each and every patient. And all the diagnosed patients will be subjected to surgery depending upon the RIPASA scoring system. And in all cases, operative findings in post-operative diagnosis by histopathological report will be correlated with the RIPASA score. Inclusion criteria. All patients above the age of 18 years admitted to the surgical department in casualty or emergency ward SSMS-RC with history of pain abdomen suggestive of acute appendicitis were included in our study. Exclusion criteria. Patients of age group of 18 years and below were excluded, and patients admitted for interval appendectomy following recurrent appendicitis, appendicular abscess, appendicular mass previously treated conservatively were excluded. The table on the right lower side is the RIPASA scoring system. As we can see in the RIPASA scoring system, the following factors are taken into consideration. It takes the patient demographic features such as the age of the patient and gender of the patient into consideration. Along with that, the symptoms, signs, and the laboratory investigations, including WBC count and negative urine analysis, will be considered in the RIPASA scoring system. And the table on the left depicts the modified Alvarado scoring system, where the modified Alvarado, it takes into consideration of symptoms of the patient, signs, and laboratory investigations, which is WBC count. And following the scoring systems will be applied for all the patients, and the patients will be categorized into 4 groups. So they'll be categorized into a definite group, high probability group, low probability group, and unlikely group. So when it comes to RIPASA scoring, a score of more patients with score of more than 12, and in modified Alvarado, a score of more than 8, the patients should be categorized into definite group. And under RIPASA scoring, patients with score of 7.5 to 12, and under modified Alvarado, a score of 6 to 7, patients will be categorized into high probability group. And patients with a score of 5 to 7.5 of RIPASA and 5 to 6 of modified Alvarado will be categorized into low probability group. And patients with score of less than 5 in both the scoring systems, the patients will be categorized into unlikely group. So after categorization, like I said, the treatment will be based upon the RIPASA scoring. So all the patients who are categorized under definite category and the high probability category were straight away operated for appendectomy. And the patients categorized under the low probability, they were further evaluated with CT scanning of the abdomen. And patients who were categorized under unlikely, they were evaluated further for other causes of pain abdomen other than acute appendicitis. Next slide, please. Observational results. The bar chart on the left, it shows the age distribution of the patient in the study. Most of my patients belong to the age group of 21 to 30 years. And again, there was a female preponderance seen in the study. Next slide. And the bar chart on the right depicts the categories in the final score of RIPASA. Among this, one patient was categorized into the definite category, and 34 patients were categorized under high probability, and 36 patients were categorized as low probability, and 8 patients were categorized to be unlikely. And the bar chart on the right depicts the categories in the final score of modified Alvarado scoring system, of which 3 patients were categorized into a definite group, and 20 patients into high probability, 14 patients into low probability group, and 33 patients were categorized unlikely in modified Alvarado system. This table this depicts a comparison made between the RIPASA score positive patients, that is, the patients who were categorized under high probability and definite were called as a score positive. So these patients were compared with the final histopathological diagnosis patients of acute appendicitis. So in the first column, we see that RIPASA score positive patients, a total of 27 patients, all the 27 patients had features of acute appendicitis in the final diagnosis, that is based on the histopathological examination. And among the RIPASA score negative patients, which were who were 43 patients, 25 patients in the histopathological examination had acute appendicitis features, and 18 patients had features of non-appendicitis. This will result in low sensitivity and low negative predictive value. Next slide, please. So when compared between the RIPASA scoring and modified Alvarado scoring system, both the scoring systems have specificity and positive predictive value comparable, but there is a definite upgrade in the sensitivity, negative predictive value, and diagnostic accuracy in RIPASA scoring system over modified Alvarado scoring system. Next slide, please. To conclude, RIPASA score is more sensitive than modified Alvarado score, and it also has a higher negative predictive value and diagnostic accuracy. And this scoring system also categorizes treatment of patients with right iliac fossa pain, suggesting that in most cases, patients with high probability or definite category can be straightaway taken up for surgery without any extra imaging modality. Patients under low probability category would benefit the maximum with CT imaging, and patients under unlikely category can be worked up for non-appendiceal diagnosis. And this 14 fixed parameters in the Ripasa scoring can be easily and rapidly obtained in any population setting by taking a complete history and conducting a clinical examination and 2 simple investigations. So in remote settings or in case of emergencies, a quick decision can be made with regards to referral to an operating surgeon or observation. These are my references.
Now panel is open for discussion.
Deepak.
Yes, sir.
I have 2 questions. Number 1, yes. According to you, on palpation, what do you think the most important finding of to diagnose acute appendicitis on palpation? First question.
Yes. So tenderness in the right iliac fossa and the rebound.
Okay, rebound. According to Ripasa, tell me what is the maximum score given to which sign? Your study only.
Yes, sir. So rebound tenderness is given a score of 1, sir.
What is that other sign there? Look at the carefully. Rowings.
Rowings.
What do you think? Do you think take it seriously? Okay, that's all my comments. It's for you to decide. Thank you.
Yes, thank you.
There is a question from the chat box from Dr. Nashe. Doing CT for low scores, does it not increase unnecessary imaging? Can they be just monitored?
Yes, the intention of doing a CT scan for low scores is to rule out the other diagnosis from acute appendicitis, which will be of more useful when such dilemma is happening in case of when we are handling young female patients. So only in such cases, yes, it's better to rather evaluate than observe the patient.
Okay, in this scoring system, females it's given 0.5 and male 1. What is the importance of it?
When it comes to the demography or epidemiology as such, the incidence of acute appendicitis is more commonly seen in males compared to females. So that's why more weightage is given.
But in your previous study, you said the lifetime incidence in males is less when compared to females in your first study.
Yes, that is there, but yes, there is a certain
contradicting thing.
Yes, sir, I agree.
There is one more question in the chat box by Dr. Ramakrishna HK. You had only 70 cases in 3 years or so?
No, sir. There actually both the studies were the previous paper I presented was a 140 paper. So this was taken for this study is a part of the study that I conducted before.
Time is up.
Sorry, sir.
Time is up. Thank you, Dr. Deepak. Now I will call upon Dr. Vishwajit for next presentation.
Hello, sir.
Dr. Vishwajit, your time starts now.
Okay, sir. Okay. Good evening, respected teachers. I would like to firstly thank Dr. KSCASI for providing me an opportunity to present a paper on various flaps in hand injuries, our institutional experience. Our moderated by Dr. Murali Krishna sir, Dr. Somsekhar Samgandi, and Dr. Pawan sir from Department of Plastic Surgery, WIMS Ballari. Next slide, please. As you all know, hand is an intricate part of the body that plays an essential role in social functioning, expression, productivity, and interactions with our environment. The thick glabrous skin of the palm, it withstands shearing forces encountered during daily activities and provides a discriminatory sensory function that transfers touch, pain, temperature, whereas the dorsal skin is pliable and mobile that permits a wide range of motion of the hand, such as finger grip and pinch. Soft tissue defects of the hand following a trauma are frequently encountered in hand surgery, which may result in temporary or permanent disability if not managed appropriately. As we all know, a flap is a skin with varying amount of underlying tissue which has its own blood supply that is used to cover a defect and receives its blood supply from the source, which is other than the tissue which it is transferred to. Now the flaps are classified basically as local flaps, regional flaps, and distant flaps. Ours is a comprehensive study which provides an overview of the presentation of different types of hand injuries, their management, their outcome, and complications after surgery in our institute, that is WIMS Ballari. Next slide. Ours is a retrospective study. We took 25 cases of hand injuries over a period of 2.5 years, and we included all those patients with hand injuries aged between 6 to 65 years presenting to WIMS casualty, and we excluded those patients with vascular injuries and those patients who required orthopedic intervention. That is mainly the fractures of the phalangeal bones. Orthopedic intervention was required prior to the reconstruction of we have excluded those patients. Previous slides. Next. And the reconstructive surgical procedures were crafted based on the nature of the injury and the integrity of the bone which is left out. These were the various flaps which were employed in our study. Cutler's VY flap in 3 patients, Thiener flap in 3 patients, Atasoy Cleaner VY flap in 4 patients. Majority of them were cross finger flaps, that is in 11 patients. Abdominal flap, that is in 1 patient, and groin flap in 1 patient, and first digit flap, that is FDMA flap in 2 patients. And coming to the next picture, as we can see, there's a majority of the patients, the age preponderance between 27 to 36 years, which corresponds to the working population. So they had majority of them had hand injuries, and they were included in our studies. And the male preponderance, that is 83% of them were males in our study, and 17% were females. Next slide. And these are the pictorial representations. In the first photo, which you can see, the patient had crush injury during the machinery work, and it was initially decided KYs, and this was the step ladder flap. Step ladder flap, which convert step ladder abdomen flap, was marked on the ipsilateral side of the patient, ipsilateral side of the abdomen of the patient. And the fourth picture we can, as is depicted, as we have the defects have been sewn, sutured to the flaps which have been raised on the abdominal flap. And the penultimate picture, it depicts the post-operative day 7th of the patient, which are divided, which are and the graft and the flap has been divided. And after 21 days, we have divided the flap, and we can see the post-operative follow-up. And the lower one, which represents the groin flap, the patient had ring avulsion injury of the hand, and the patient ipsilateral side we had marked the groin on the groin side, and the patient underwent closure. That is in the third picture, which is represented. After 21 days, we have removed it, and it shows the presentation of the post-operative picture, the dorsal as well as volar aspect in the final 2 diagrams. Next slide. And the patient, and we have depicted the Thiener flap. The patient had avulsion injuries of the index finger as well as the middle finger. And the Thiener eminence based flap was raised, and after 3 weeks, it has been divided, and it shows the post-operative follow-up photo in the last diagram. Then the patient on the penultimate picture, the volar VY flap, it has been shown that the patient had injury to the ring finger as well as the middle finger, for which VY flap, that is the volar VY, volar side, we have raised the flap, that is based on the V and Y pattern we have raised, that comes under local flaps. Volar V and Y pattern we have raised, and it has been closed, and the pulp of the finger has been restored. It's very important. Pulp of the finger has been restored, and the patient's post-operative photo has been depicted there. And next slide is the FDMA flap. The FDMA flap, the patient had injury to the volar aspect of the index finger, volar aspect of the thumb, volar aspect of the tongue, for which we have marked the first digital metacarpal artery based flap, and it has been raised and it has been repositioned there. And for the defect in the first finger, that is the index finger, we have done a split skin grafting. The last picture depicts the cross finger flap. The patient had injury to the ring finger and also the little finger, for which cross finger flap has been raised from the dorsal aspect of the middle finger, and it has been transpositioned to the index to the ring finger and little finger, and it has been divided after 3 weeks, and the patient had shown the post-operative follow-up in the last picture. Next slide. Coming to the results of our study, the total duration of treatment, it varied between 1 to 4 weeks. 1 to 4 weeks, and the majority of the abdominal flaps and groin flaps, they took 6 weeks for us to divide, and those were the only 2 exceptions. And these patients, they were followed up over a period of 2 months to 1 year, and they were checked for any presence of any optimal sensation over the pulp, and for any other complications associated with the surgery. And these were the complications seen in our paper, in our study. The wound infections were seen in 3 patients, for which local debridement and regular dressings were done, and subsequently the patient recovered. The partial loss of the flaps was done in FDMA flap, which subsequently the patient underwent a groin flap. For the neck, there were no complete necrosis of the flap. Joint stiffness occurred in one patient with cross finger flap, and one patient lost for follow-up in our study, for which and he presented after 1 year, for which and he presented with the flexion contracture of the index finger, for which K-wire was done and split skin grafting was done later. Next slide, please. And coming to the discussion part, these are the various other studies done under the similar topic. These are the Shady A. Rahim and Kevin Chung, Michigan University, Fernando A. Herrera and Brennan, RBS, Department of Surgery from California University, and one from the Father Muller Medical College, India. That is Arvind Elrao and Sriranjini Srivatsava. Those studies, they are coming to all of the above studies, they arrive at a similar objective, and those studies results were comparable to our studies, and they arrive at a similar objective, that is restoration of painless and functional digit with protective sensation after the hand injury with various loco-regional flaps. Next slide, please. To conclude, the individualizing the treatment based on the type of injury and keeping a wide variety of surgical options was followed in our study, which has shown optimal recovery in study patients, and the restoration of pulp in case of fingertip injuries plays an important role in preserving sensory function of that finger. Next slide. These were my references. Thank you.
Now panel is open for discussion.
There's a question in chat box. What is the purpose of surveying? What is the purpose is surveyed by listing all the flaps done? Would it be more useful to compare different options in a given injury and prove that one is better than the other? No data on follow-up. How do we know how these flaps work? Your conclusion has absolutely no data to support it. How can you say this is a study? You know,
sir?
Yeah. Individualizing treatment based on the type of injury and restoring a functional painless limb is good. How do I know that your patient, so many you have listed, how do I know that they had a functional painless limb? I have no data. You have listed what you have done, but what is the outcome?
Yes,
that is the real question. Every study must have outcomes and objective measurement of the pain factor. Do I know what the pain was? Do I know if the flaps healed or not? If they did not heal, what was the reason? Please, you youngsters must understand that without data, don't give conclusions. Ramakrishna has mentioned it at least 5 times in this conference. We keep telling you this. So when you present a paper, there must be a focused research question, and just listing what was done over the last year or 2 years or whatever, honestly, I'm sorry I'm using the strong word, serves no purpose. So you have to have research questions, get objective data, and only then come to conclusions. Please, I don't mean to discourage you youngsters, but I find it very disheartening that our papers are not studies. We must start doing studies. Okay, thank you. I'm sorry I had to say this. Yeah.
Thank you.
ಹೇಳ್ತಲ್ವಾ
Are there any other questions? Are we going to end the session? Chandru, can you please, hall in charge, can you?
Sir, one more thing, sir. I request you to, presenters are there only.
Yeah.
Give an idea about these things, sir, feedback, because another 15 minutes we'll have a valedictory.
All right.
So we can brief them regarding how it was, feedback, and what they have to do.
All right. Is the chairman here, Dr.
Yes, sir.
Arvind Patel? You want to go first, Arvind? Can we?
Arvind sir is there.
Chandrasekhar first.
Sir, it is
Chandru.
not valid. Yes, sir. Yes, sir. Hear sir. Hear sir. I'm hearing you.
Okay,
Sir,
you should this thing.
Sir, valedictory, it's another 15 minutes is there, sir, because we have announced already timing.
Okay.
But now feedback from others.
All right.
I want a feedback from all the participants.
Yeah, let me go first.
Yes, sir.
There are other seniors, Dr. Ramkrishna, Dr. Rajgopal, they're all here. They can go afterwards and give their feedback.
Yes.
I'm going to be candid and honest. Okay, I'm not disrespecting anybody. I'm definitely not disrespecting the work done by our youngsters. But as a senior, as a representative of the association, it is my duty to give an honest feedback. So I want the whole surgical fraternity, my senior colleagues, departmental heads and the students to take what I am saying in the right spirit. See, a time has come when the world is flat. Okay, what we mean is that all of us in India are seen as people, as members of the world, as it were, and we have to measure up to the scientific standards across the world. We cannot claim to be developing anymore. We are almost a developed nation. We talk so much about tourism, health tourism. We talk so much about how we have reached the pinnacle in science, in aviation, for example, in satellites and things like that, going to the moon almost. But in surgery, I'm afraid we have stayed behind. Is it because of our expertise in being surgeons? Definitely no. I can tell you, having worked across 3 continents, that our expertise as surgeons is matching or in fact surpasses the skills of surgeons elsewhere in the world. I think we are really, really very good as surgeons, and I am very proud of it. But where we really lack is in documentation of data, in presenting that data to the rest of the world, and being very objective about what we do. And it is hard work. Any kind of research or audit or anything is hard work. That one extra step that we have to take, we are not taking. Okay, and so it is my very sincere, humble request to all the departmental heads in various medical colleges and all the institutions running DNB to kindly give some time and importance and focus on research, ethics and communication skills. Just learning the skills of surgery, not completely justifying what you're doing without enough data and without enough scientific evidence of our practice. Please understand that I cannot go by what Americans say or the Britishers say. We have to go by what we have to do. So we have to have our own data. Kindly spend time and effort on collecting that data and sharing that data in a scientific way with the rest of the country and the rest of the world. I think it is extremely important. ASI headquarters has recognized this in a very big way. The new National Medical Council has recognized this in a big way. They have revised the curriculum, and it includes all this. We have to actually implement it. One of the areas where we lack is we don't implement it. We have all this on paper, it's not really actually carried out. And so I think all of us must work together, put a shoulder to the wheel and actually implement it so that we produce better surgeons for our society. As far as these are the general things I would like to say. Please focus on research. There's plenty of material on the web. If you want to learn, you don't need anybody teaching you. You can just go onto the web, and KSCASI website itself is a fund of knowledge. Myself and Ramakrishna have put up a lot of things. If people want to learn, it's all free of cost. You just have to spend time listening to those videos, reading those the chapters in the book that we have co-authored,
It is not a question of saying that we have done this, we have done that. That's not it at all. But there is material available. Please use it. There's plenty more available free on the net. Download and read. Just reading your textbooks, having the goal of passing your MS or DNB as your only goal, and then getting ready for MCQs of MCH is, I think, the wrongest way to go about learning surgery. And that's the feeling we have. I'm sure Rajgopal and others will agree. Students of today are not broad in their vision. They must be good, safe, ethical surgeons for society. Please have that as your goal. Again, this MidCon, I must, in the valedictory, I hope I get a chance to thank all the people who have worked very hard. So I'm going to not talk about it now. But as far as the presentations are concerned, I do not think people really read what we asked them to read before coming. People were ill prepared, both in terms of time. I repeatedly said that you will be stopped, but our hall managers were very kind. They allowed overtime. I kept on telling Dr. Chandrasekhar, please stop them. We had to do that. The hall managers were very nice. But I feel that you must be strict rather than be nice. Stop everybody at a given time, and people must come prepared for that time. You have a 3-minute presentation, you must finish in 2 minutes 50 seconds. No questions asked. Now that is the kind of preparation that you must have. A lot of applications, submissions came expecting that it should be automatically accepted. No, we had a very objective way. 3 very good people who are aware of what research is, they evaluated the abstracts, and we had to reject about 30% of the submissions because they didn't measure up. This is not to punish our youngsters, but to make the point very clear for the next time. Do the job properly. Go and read up about what a study is, prepare a study, present it, the abstract, how to write an abstract, prepare for it, and then abstract, and you will have a very high chance of your work being accepted. I stop here and leave it to others to make their comments. Thank you very much. Dr. Shana, you have something to say, sir?
Yeah, I mean, what can I say that Dr. Lakshman, whatever has told is directly coming from his heart, I can say, not from his brain or something. But I just want to tell that for all the postgraduate students, one thing I always tell them that my time means, almost 35 years back story and present day. Lot of difference between how you look at the thesis, or most of them are doing their thesis actually, presentations. I have collected, Chandru, some thesis of 20 cases of abdominal emergency. See, long back stories, these were the type of thesis. So from that mindset, we have changed a lot over a period of years, number one. So every postgraduate who joins should have that in mind, that I need to do something which is better than what has been done, number one. Number two, whenever a topic they select, also it should go through 2 or 3 faculties who are working in the medical college or whichever the the national board. So that is next step. Now third step, whenever a candidate is presenting in a podium like this, they should show it once or twice to their faculty who is connected with that. That is what is missing. In fact, sorry to say, including my college, somebody has not shown the presentation to one faculty and it has gone through. So these are the important things which we need to keep it in mind. And Ballari Medical College, of course, my college also, so much clinical material is available. So a little bit efforts from everybody's side. It makes a lot of difference, as Lakshman has put it. This last paper that plastic surgery, the results fantastic. That's a different issue, no? The ultimately the aim of the study and those were not matching. I mean, many things can be told. I think that's where I stop. That's all. Thank you.
Dr. Ramakrishna. Dr. Ramakrishna, are you there? Can I invite one of the postgraduate to say what they feel? Please feel free. We will not take any your criticism amiss. We will not feel bad about it. We all have to learn, and I believe that I am as much of a student as you are. So please go ahead and speak your mind. While the postgraduates are making up their mind, can I ask Naz to say a few words, please? Deepika, are you there?
Naz, madam.
They don't seem to be there. They're logged in, but they may not be in front of the system.
Naz, madam.
Any postgraduate, you want to come up and say, the last presenter from Ballari, I want you to say what you say openly and very honestly. I will not be offended if you disagree with me.
Varun.
Sorry?
Varun,
please say what you have to say. As I'm saying openly, I will not be offended or upset if you disagree with me. If you have a fair enough explanation for what you have to say, please say that.
No, sir. Hello, sir.
Yeah, tell me.
Sir. I got to know the mistakes. The post-operative follow-up was missing in our case.
Yeah.
We have included the recent follow-up. That is the recent follow-up. That is wound infection, necrosis. We have been included, but for pain and sensory point of view, we have not included. I got to know.
Yeah.
We'll work on it, sir. I'll work
so
on it.
would you then design a prospective study? Okay, and then, work on it, and by next year you will have tremendous data, which is very useful to all the people of Karnataka and the country. Okay, that will be the goal. Yeah.
Thank you.
Okay. Anybody else? Please say what you have to say, because as a scientific committee from the association, we would like to facilitate this process, and you tell us, educate us as to how we can do it, and we'll do it. Unless you postgraduates come and tell us what you want, it will be difficult for us to read your mind. Please tell us.
Sir, our chairman.
All right, chairman, sir.
No. As Lakshman said, our view he has very clearly said. Only thing is how we should conduct or what they expect from us is very important as far as postgraduates are concerned. As the MidCon is mainly for these people, they need to tell us. So if they want our EBS module, if they want our other modules to be on a regular basis, other than this our journal club and other things, for that also we are prepared to do it. Only thing is we need to hear from them what exactly they want from us for their own benefit and for the benefit of our fraternity. So this is what we expect. Even if they want, if they cannot tell right now, even if they put it in black and white to
you can write to us anytime. Yes.
Yeah, we will take it forward.
Arvind, if you, with your permission, see,
yes,
what I am to tell is PG is a postgraduate with lots of other things are there. Let us not worry about think about what are the duties. I request each PG and one person to take the, I don't call it responsibility, to guide them properly whenever they come to this forum. That is only my request. That's all it is.
Agreed.
And any PGs, please.
Yeah, this is another appeal. Please voice your concerns, voice your views, right from our Bangalore society meetings to state level meetings. PGs don't talk at all, and we need you to talk, and we need you to say what you have to say. The name Vinny is familiar to me. Do you want to say anything, Vinny?
Yes, sir. Good evening, sir.
Go on.
So first of all, I would like to thank everyone for this opportunity that we got, sir. It was another learning platform for us as we were preparing for our papers and posters. We came across as we were preparing for our own presentations, and as we heard the various other presentations and the lectures from esteemed people and surgeons, it was a nice learning experience for us, sir. And for me personally, as I was also helping in bringing this together, it was another learning experience for me on how a conference should be conducted. And there are so many things that go into bringing this together is what I realize now, sir. And I would really like to thank everyone for giving us this opportunity and this learning experience.
Anybody else?
Chandan?
We would like some criticism also, not just praise.
We learn more from our criticism than from our accolades. Go on, Chandan.
So good evening,
Say what was
Good
wrong
evening.
with us. Yeah.
Sir, I'll say that in the end, sir.
Okay,
In continuation
good.
with what we said, this was again a great experience for all the postgraduates. Also being a part of the organizing team, it was a good learning experience for all of us, sir, including the academics as well as the administrative aspect of it. Also being a part of the panel discussion gave us a lot of insights about how to go about things. And it was really helpful, sir. I mean, it was not a small process, sir. I mean, we got to know how we have to prepare and what we have to prepare, what to speak and what not to speak in the panel discussion. And also with respect to the paper and post presentation, we have to go through a lot of research and other journals and make sure we get the things right. And maybe in the panel discussion, it would have been better if there was more active participation with regard to the discussions. And apart from that,
how can we improve on what we have done? Tell me that. Think about it. Or you can, if you know, tell me now. Otherwise, you can suggest later. How, for all of you PGs, how do you think we can do this better? Is the important thing. We all have to learn together. Okay, I see something saying it would have been nice if we had a surgical quiz. Yeah, you know, we really seriously thought about it, and time was a constraint. But yes, quiz will be a part of future programs. Yeah. All right, Chandan, you have anything more to say? All right, back to Dr. Chandrasekhar. Yeah.
Actually, sir, more than this people, they have came to know that how to prepare, how to make papers and presentation. See, they have learned participate in conferences. That is more important. Actually, our own postgraduates. Just a minute, sir. One. That's what discussed, sir. Sir, for Dinesh, sir, somebody has sent. If a quiz was there, it was very good. That's what.
Yes, I've just replied.
You have given an answer, sir.
Yeah, Ritesh Anand had written it, and I have said that yes, we really seriously considered it, but time constraints didn't allow us to accommodate it this time. We will definitely do it.
And our PGs actually involved in all communication skills they have learned, and especially in Mysore Medical College, they called to whom to call, how to talk to with the seniors. Those things they have learned by organizing one conference. That's what when they called some senior person how to talk, somebody told repeatedly these people are calling, and they told, see, I'm not interested in MidCon. Don't put me in a chair as a chairperson. Like that they have told. Then I called. Then sir told, no man, so many times he called and got fed up with that phone call.
Chandru, lighter way.
Yes,
Your PG so many times have called me fantastic communication skills with me, but let them have also with the patients. Lighter way.
Okay, sir. Thank you very much.
Yeah.
Sir, now shall we
start the valedictory function?
Valedictory function.
Yeah.
Sir, idu
chairperson.
1 minute, sir.
Yeah.
Dear delegates, this is a time for conclusion. The valedictory function will be there, small formal valedictory function. I invite our chairman, Dr. Arvind Patel, to chair this valedictory function, and I welcome our scientific committee chairman, Dr. Lakshman, and I welcome our treasurer, Dr. Chandrasekhar, and I welcome all the EC members and all the national EC members and our Vice President, National Vice President, Dr. Siddesh. Now, I take an opportunity to welcome all the delegates who have participated and chairpersons and judges and moderators. So now I request our scientific chairman, Dr. Lakshman, to address the gathering, sir. Please.
Thank you very much, Dr. Chandrasekhar. It has been a privilege and a pleasure to be the chairperson of the scientific committee and having some role to play in the organization of this MidCon. As you all know, this is meant for postgraduates to encourage them to present papers, not just to meet the requirements of the university, but to really learn the process of doing some research work and presenting it and publishing it if possible. But having said that, I think the majority of the work, the large majority of the work was done by the Mysore team, headed by Professor Dinesh, Dr. Chandrasekhar, and the youngsters Raghuveer, Lokesh, and a battery of, I'm told, 15 or even more volunteers, postgraduates, who have put in a tremendous effort in making this possible. All of us, including the delegates and myself, do not realize how much work is involved. As Chandan said, it is an enormous amount of work, and all these people have put in their effort. I have seen personally in first hand what they have done, and my sincere thanks to them for having put in such a lot of work and for having made this such a smooth process. Thank you again. I hope it has not been too strenuous for you. I hope it has been a learning experience, and I would very much like you to take it forward, take the leadership in future conferences, because we are on our way out. We have had our innings. Now the innings is from you people. You have to now flourish and take the association and make its flag fly high. I would like to thank the Governing Council, the Executive Committee of the Executive Committee of the KSCASI for cooperating with us in such a nice way that everything was very smooth. Anand and John from Keystone have been very helpful in giving us very important infrastructure support, always approachable. We have disturbed them at any time of the day and night, not considering if it's a Sunday or a holiday. They have always responded promptly, and we are very grateful to them for the kind of help they have provided. I would also like to say, before I close, a sincere thanks to all the postgraduates who put their submissions in. I know that some of them were rejected. We are sorry for rejecting it, but we must understand the constraints under which we work, because we have to maintain some standards. We have to show you what is the right thing to do, and so it is like an exam. There will be some failures, but this failure, if you want to call it that, I don't want to call it that. I just want to call it an event. This event must be a learning exercise for you to improve your work, so that the next time you submit something, it will fly through the process of selection, and you will have a good opportunity. For those whose presentations were accepted, congratulations, and all of you have done a great job. I'm sure Dr. Chandrasekhar is going to announce some prizes for it. Prizes, in my view, are not really important. It's good, it's a good incentive, but the pleasure of doing the job, the pleasure of just getting things done itself is an enormous pleasure. So it's good to get a prize, good to know that your work is recognized, but that should not be the primary aim when you submit a presentation. I again thank all the people involved in making this conference a great success. Thank you very much again. Good night.
Thank you, sir. Actually, this is the first ever in KSCASI. A panel discussion was arranged for PGs. It's really nice, sir. This is all because of Dr. Lakshman sir's effort, and is having a views of involving postgraduates, and that means youngsters, to participate in academic this one. Thank you very much, sir, once again.
Thank you.
I request our chairman to deliver Anybody, sir, Rajgopal Shanai, sir, want to speak, sir? As a national EC member, please.
No, nothing. That the MidCon should continue, whatever it is. Yes, participation, efforts put by whether it's Mysore Surgical Society or Bangalore or Lakshman or anyone, tremendous efforts. Participation of number of people attending, irrespective of that, somebody may be watching in a YouTube or that's a different issue. As long as we should not discontinue this program. That's all is my take. Whether it's virtual or it may be in reality, let us continue with this work, because any form of education which we are doing selflessly for postgraduate should be welcomed by everyone. This is my principle. Thank you. That's all.
Okay. Thank you, sir. Thank you, Shanai, sir. Now I request our chairman, KSCASI chairman, to give a presidential speech.
I think Dr. Lakshman and Dr. Shanai, both of them told everything regarding scientific meet. That is our MidCon. This MidCon is fourth step. That means this is the fourth step we are moving. Still a long way ahead. What I feel is we are moving in a positive direction. Means this time we have included the PG panel discussion and probably record number of rejection of papers also, with the intention of improving the papers in the oncoming conferences. We have sent a message to our postgraduates and our scientific committee time and again during papers also, very clearly stated what exactly we expect and what exactly they should do. Because with the type of scientific mind we have today, whether our JC members or Lakshman or others, we will be able to give the best to our postgraduate. That's what I believe. KSCASI is doing tremendous job. And as far as this MidCon is concerned, the Mysore team has done wonderful work headed by our Dr. Dinesh, Dr. Chandrasekhar, and all of them. I may not be able to name. All of them have done very good this thing. Very happy. Thank our John. Is all the way helpful for this meeting to be arranged. And I personally feel KSCASI will move in positive direction as far as scientific programs are concerned. Our monthly meetings are going to be continued. Next month is again already from WIMS Ballari, I believe. As far as next conference is concerned, we will take a call during our next EC meet. So this MidCon has done a good job, and we will be very, very, very receptive to the feedbacks, which is most important for us to improve further, I believe. So with this, I hand it over to our dynamic secretary, Chandrasekhar, who has done wonderful job. 3 cheers to Mysore team. Thank you, one and all.
Professor Dinesh, to say a few words, please. Unmute, sir.
Now, sir, next is our last end of the program, that is vote of thanks by our beloved Professor and HOD, Dr. Dinesh, and President of Surgical Society of Mysore. I request him to give a vote of thanks.
Sir, good evening, sir. Good evening to everyone. Even though this virtual fourth MidCon conference is hosted by Karnataka State Chapter, but it is, since it's our secretary is from Mysore, and it is our responsibility to be a part of this MidCon. Always we are with the KSCASI, and it is my duty as a president of Surgical Society of Mysore to thank everyone, particularly KSCASI, for giving an opportunity in the name of Dr. Chandrasekhar, Secretary, to host a MidCon. Even though it is hosted by KSCASI, we are part of it, and I can openly say that we are hosted. And thank you for giving an opportunity to be part of the academic feast, sir. As it's my duty to propose a vote of thanks. I thank sincerely our National President, Dr. Abhay Dalvi, and our Dr. G. Siddesh, Vice President of Surgical Association of Surgeons of India, and all the governing council members of the KSI, particularly from the Karnataka, who are all the 3 days they were with us. And even before the conference started, they were guiding us to conduct the program very meticulously. I thank our President, Dr. Arvind Patil, sir, and all the executive committee members of the Karnataka State Chapter of ASI for their constant guidance and helping us to conduct the program. And of course, Dr. Lakshman, sir, we have learned so many things from you.
Thank you.
Definitely, sir. Even all our postgraduates and most of us, even in a later veins, actually, even Chandrasekhar has learned so many things. We are just watching him, how he is managing the laptop. So we have learned so many things, sir. And this program was meticulously, even in the midnight, 1 o'clock, we used to see the message from Lakshman, sir. That is the commitment, that is the meticulous planning of the execution of the work. Thank you very much, sir, for guiding us to conduct this program. And also all the scientific committee members also, Ramakrishna sir, Chandrasekhar, and our Arvind Patil, all the members I thank once again. And I extend my sincere thanks to all the faculty members, chairpersons, judges of the various sessions, and presenters, the PG presenters, and the faculty, guest lecture faculty members, and particularly all the delegates who have participated, made this program a wonderful, successful again. And a special thanks to our Anand and John from Hubli. They were here in the Mysore for the last 5 days. They were in the assisting us to conduct these things. And it is my duty to extend my sincere thanks to our Dean of MMCRI, Dr. Nanjaraj sir, and the Mysore Medical College Alumni Association. We are utilizing the auditorium as a classrooms. So we extend our sincere thanks to all the office bearers of the Mysore Medical College Alumni Association for their cooperation in conducting the MidCon. And I will be failing in my duty. I don't extend my sincere thanks from the bottom of my heart to all the volunteers, all my postgraduates, and even the house surgeons posted in the surgery department. Few are volunteered from other department also to be with us. And to be frank, my work was just relaxing and walking all around, just like a boss. I am moving around, sir, to be frank. So all the works have been done by our postgraduate, and of course led by our Chandrasekhar. So it was all in charge, particularly Dr. Lokesh and Raghuveer. And I think you can see all our postgraduates are standing here only, all the volunteer groups. I sincerely thank them. I extend on the behalf of Karnataka State ASI committee also, scientific committee also, I extend my sincere thanks to all of you. And special thanks to our Rajgopal sir, for his special books. Always his books, they will remember definitely, sir. As a prize award memento for them. It is particularly sponsored by the Rajgopal sir. They will remember forever. And I extend sincere thanks to one and all who are directly or indirectly helped in our conducting this program. Thank you one and all, sir. Good night, sir. Good night.
Good night. You're muted, Chandru.
Sir, with this, we are came to an end. So, good night, sir.
Good night. Good night, everybody.
Good night. ಬರ್ರಪ್ಪ ನಡೀರಿ ಎಲ್ಲ ಟೈಟ್ ಆಗ್ಬಿಡೋದು ಕೀರ್ಕಳಿ ಜಾನ್